Assalamu alaikum, sabah al-khair, good morning. We're going to start this session. Our first speaker is Dr. Melissa White. She's an associate professor of emergency medicine at Emory University. She is a past residency program director. She completed her master public health in epidemiology and her EMS fellowship at Emory University. She's going to talk today about challenging airway in the emergency department. Welcome, doctor.
Thank you. Do you know how to flash? As with emergency medicine, there's always a kink, so you have to go with the flow. Give me one moment. Perfect. Thank you. Mahaban, thank you so much for having me. It's a pleasure to be here. And I send greetings from Atlanta, Georgia, which is southern United States, as many of you know. And I'm excited to talk about the airway today. It's a little bit of a different lecture. I know we have quite a few different learners here. We have attendings, as we call you, also in the States. We have a lot of students, I hear, and residents. So this would be, though, a little bit of a different take on the airway. We actually presented something like this for the first time to our residents this past year. And we talk about the airway just a little bit differently. So where I hail from, yes, Emory University, but we actually train primarily at Grady. Some of you may have heard. We have something called Emory Proud, Grady Made. So I know some of our alumni are in the room as well, too. And we're the only level 1 trauma center in the city of Atlanta. We're the only training center in the city of Atlanta, and one of the busiest hospitals in the country. I don't know in comparison, but about 150,000 a year come through the ED. So very busy. When you do your training with us in emergency medicine, yes, you work at Emory, but most of the training is at Grady. And again, we're one of the only county hospitals in the country as well, too. And this comes into a little bit more context when we talk about the airways and what we do. I'm going to apologize. Hopefully nobody in here is squeamish since you're all emergency medicine, so you may see a couple of pictures. But in our trauma center, so we have over a 900-bed hospital. The trauma center holds upwards of 30 to 40 on a very busy day. During the holidays, sometimes 50. So we're stacking patients in rooms and trying to move people out as quickly as possible. The residents, when they train with us, we do progressive responsibilities. And they are always head of the bed. So the airway in our program is very important. All of the trauma airways are done by the EM residents. This is great, great training. And across the country, you may not see this, okay? The other thing that's unique is we also stand on the side with the trauma surgeons as well, too. So when we run the trauma center, yes, we're head of the bed. We do the airways, which is what we're going to talk about today. But we also are on the side doing procedures on even days or doing the full exam. And we work with the team and create plans. So a little bit of a busy night, but pretty usual. I hope that this gives you a little bit of anxiety, but these are some of the things that we see, right? Trauma centers, I'm sure you see some of the same. We do see quite a bit of penetrating trauma in Atlanta, unfortunately. And to say that we're the busiest, projected to be the busiest trauma center in the country, is a good thing when you train, but maybe not such a good thing overall. Our residents learn how to deal with this, penetrating injuries. How do you manage just even a basic airway is sometimes difficult depending on where you are in your training, right? But you get one of these airways, and it makes your pulse go up, it makes you pause, and you're like, can I do this, right? And you get this moment where you're like, I don't know, maybe. I'm going to tell you, you have the greatest tool to your airway, and we're going to talk about that. And it's actually in this room. So, this was my patient about 2 months ago. We get this call. Again, probably will cause you a little bit of anxiety, yes? Yes. Okay. So when we talk about training residents and relearning ourselves, there's some theories that when we talk about the airway, I want you to understand something called performance psychology. What we do is difficult. We're going to talk about this in just a minute. And something that you'll hear in adult learning theory called cognitive load. I don't know if many of you have heard of it, but it's coming up and up a little bit more. And especially this time of year when we have new interns, it makes a lot of sense. I'm a little older, been doing this since 2002, so my cognitive load will be different, and we will talk about that as well, and then present ways to navigate some of these difficult airways. All right. So what do all of these pictures have in common? High stress. You have to work under pressure. Thousands of hours of experience. You have to think on your feet. You have to be precise. And emergency medicine is no different, especially when it comes to the airway. So I took this picture actually after one of my 8-hour shifts. If you look, you see those are gyroscope blades for students in the room. That's how we primarily intubate our patients, especially in the trauma center. This was actually on the medical side. And I walked in and I said, I've got a difficult airway lecture. I'm going to take a picture. So can you imagine, as a brand new intern, you walk into a shift like this, right? And this is where performance psychology and cognitive load comes into play. When you're a new intern, and if you think about it, especially for the attendings in the room, I bet if you close your eyes and you think about your first code, your first airway, you will probably remember everything about it, right? You can probably almost smell the room. You can hear people yelling at you. And you take all of that in, and to some extent, it becomes overwhelming. One patient, yes, you can probably manage that one case. But as you move along in your career, you have to learn how to manage 10, 15 patients coming in. So as you start learning this, you kind of put this schema in your mind. This is a normal airway. This is how I do a normal airway. This is how I do a trauma airway. This is a difficult airway, and this is how I'm going to manage that difficult airway. But then what do you do when you get something a little bit in the middle? Do I intubate them? Do I not? Do I put them on a pressure ventilator? Do I put them on high flow O2? And then how do I RSI them? Okay? It's a little bit like learning what a bed is and then maybe what a couch is. You learn those two things, and then you get a futon, right? And you're like, I'm not sure what a futon is. So you have to learn. That's your schema. You have a bed, you have a couch, and then you get this futon, and you have to kind of figure it out. Same with your airways. These are what your learners are doing. And I forget about that as an attending. I forget that all of this is coming at them so quickly, right? And we sometimes have to take it back and make it a little bit basic when we're talking about airways. So how do we do that? What are the critical points? So I'm going to take you through kind of what happens when you're on call with us. So you're in the ER, you're the only attending from the emergency standpoint side. Usually the trauma surgeons are upstairs. You have a chief resident who's a second or a third year resident, and maybe one other. So sometimes it's just me and the resident in the trauma center. And you get the call, charge nurse, charge resident, and attending. We have a 10-minute ETA on a pitchfork to the face, truth. We don't know anything about the patient, but we know they'll be here in 10 minutes. We hope to give you more information. A few minutes later, charge nurse, charge resident, and attending. We have 2 more patients coming in from an MVC. One is ejected. We'll give you further information. So as a new learner, how do you approach this? Does it make you nervous? In your mind, you know that this is going to be a difficult airway. And I'll tell you, even after 20 years, this made me nervous. So what do you do? What do you do to prepare for this critical airway? Or what you think might be a critical airway? And I'm going to take you back actually to the training, and this is what we do in our center. So prior to your clinical shift, we do a lot of case-based reviews. We do adult learning theory, if you will, where we will give you a case, and then you come in and you run through those cases in a controlled setting with the attending in the room or a senior resident. And we think that that's very important, especially for the residents, because if you can teach it, then you know it, right? If you can teach a difficult airway and you can talk about it and you can run through those cases, then you're helping others, but you're also helping yourself. We do quite a bit of simulation. If you hurt or kill the patient in sim, I will not yell at you. I will give you some feedback. If you do that in practice, we will have a big discussion. Okay? We will have feedback. Okay? But you need to understand, again, and this goes back to the cognitive load, you need to understand what the basic airway is and then advance from there. And this is what we're doing. We are moving into a little bit of AI to help as well, and hopefully you'll see this in your training too. So prior to the patient entering the emergency center, so you are in the trauma center, you now have 8 minutes. What are you going to do? How are you going to know that you're going to get this airway? So this is what our residents do. I walk through with them and make sure, especially as interns, that they know what they're going to do from the very beginning. I know they've done the preclinical stuff. Do they know where their gyroscope is? Have they come in on their shift? Do they have everything set up? And so one of the things that has helped us a lot when we deal with the difficult airway is that we have our trauma bays and our critical care rooms set up the same every single time. And I'll show you our airway box at the end, which is very helpful. It reduces some of that cognitive load because you know it's in that airway box the minute you open it, okay? And it's sealed. It's wonderful, okay? But I run through, how are you going to intubate this patient? If this, what are you going to do? And all of this is laid out. Now, we tend to use glide scopes. Those are that is really our first option for most of our trauma airways. And that's in conjunction with our trauma surgeon and our anesthesiologist, their recommendations. I trained when we did direct laryngoscopy. I will tell you as an attending, and you all may agree, I hope, it's a lot easier. My pulse rate goes down a little bit when I can see what you are seeing as well, too. And then the bougie, we almost always have a bougie out as well, and particularly the blue bougie. The Crite kits are a little bit different in our airways, but as long as you know what you have, that's going to be one of your greatest tools as well. Understanding the difficult guidelines, again, I will run through this with the resident very quickly. We will go and talk about each little piece if we need to, especially if it's a new learner. If it's a third year, then they're going to be telling me what they're going to do. And this is an example of some of our difficult airway guidelines, and this is one of our national guidelines as well, too. So you have the tools, and then you're getting your team together. Really, over the past 10 years, I've noticed this big difference, and this helps with cognitive load and your performance in the trauma center in particular, is having your team set up. We used to not do this, and now we do. So you know who's going to be airway, and you introduce yourself before the patient comes in. You know where the trauma surgeon is. Usually I, as the attending, am at the head of the bed behind the resident. The attending's at the base of the bed during all the trauma airways. And then we have the residents on the side, and they're particular to the year. And then the nurses all introduce themselves as well, too, because that communication is key as I'm going in and helping with this airway. All right, during the procedure. So the patient comes to you, rolls in, you put the patient over on the bed, and we listen to the EMS team for like the first few minutes. We ask for a very quick report as long as they don't have to emergently control the airway. This gives the opportunity for teamwork as well, too, and we found that this has been very effective. And again, I'm pre-hospital, so I think more effective communication is always best, but especially in understanding the mechanism of injury. So, there's something called, in tactical medicine, square breathing. And I tell the residents this. They look at me kind of funny. I said, no, this helps. So as you go in, before you go in and do this airway that you think is going to be hard, we do something called square breathing. It sounds funny. It works. 4 seconds in, not 4 minutes, 4 seconds, and then out 4 seconds. In 4 seconds, out, kind of going around the square, and then you go in. It calms you down. It calms the residents down, and it's very meditative. Try it if you haven't. It's interesting. Even when you give a lecture in Saudi, it helps to do square breathing. But your greatest tool is your mind. So if you go into your airway and you think, am I going to get this? I don't know. You're probably going to have a little bit of difficulty. And that's why all these other pieces are important. The training, going through all of the cases, getting prepared, knowing where things are. That will reduce your cognitive load over time and help you become more efficient and effective. Okay? Your mind is the greatest tool. My daughter is a college athlete. And she actually has a psychologist that helps her because she started getting in her mind that she couldn't do her skill set. She clearly is skilled, right? She got a full ride scholarship to college. And then she got into her mind that she couldn't do it. Your mind is your greatest tool when it comes to airway management. And we don't talk about this, that your mind is the greatest tool. So overtraining, understanding that adrenaline is going to be running through your veins, right? And you're going to be maybe tremoring. You can support yourself, right, as you're moving your laryngoscope around. And use some ergonomics as well to help you adjust your bed. And the attendings will help you with this as well, too. The square breathing that we talked about. And go step by step. So last night when I was at dinner with some of my alumni, we were talking about some difficult airways that they've had. And it was so interesting to hear. They said, Dr. White, I went back step by step, and I knew then which way to go, right? Just like when you go through ACLS, you go back to your airway breathing and circulation. If you don't know, you go back and you reassess, and you calm down, because you're going to get it. In your mind, you're going to get it. Okay? And then you have to make a decision. Let me go back to this. So you have to make a decision. In the airway, you cannot be indecisive as emergency medicine. And that's where you're going to grow so much. You make the decision and you go. When you correct the patient, you have made that decision in that moment. Okay? And you know what you're doing. You know what you're doing. That positive self-talk and walking to your codes. Very helpful. I let my junior residents run if they want to, but I walk and it's calming. That's when I do the square breathing. And then control your room. I don't know, again, and it depends on where you work, but again, in our facility, in the emergency room, especially when it comes to airway and the airways of trauma, you have to control your room. Airway is not controlled. I am going to take this airway. We are going to do X, Y, and Z. Pre-oxygenate, give RSI drugs. I have everybody ready to go. If this, then that, and you are clearly the leader in the room. So you have to speak up. All right. Also, when it comes to your mind, feedback. So after these difficult airways, I try to sit down with the residents, and if it was a fine airway, I'll say, okay, now the patient is unresponsive. What are you going to do, right? If the patient has lost their pulse and you have a ballistic injury to the chest, you're going to what? Right? And we walk through this in a little bit more of a different setting, right? It's not threatening, but you're learning because you've got that cognitive load where you have this working memory while on shift. Do you right main stem them? Do you put an OG tube down them? Yes. Perfect. You learned, right? You've got this. So we talk about feedback, and I give that feedback actively to the residents. How do you think it went? Let me tell you what I thought and how you could improve. And then I follow up with them as well, and we were talking about this last night. You want to follow up with your residents or your learners, or even yourself sometimes. You know what? Maybe I need to work on X, Y, and Z. Sometimes it's very humbling. So I will tell you, that patient that arrived in your trauma center with the pitchfork to the face, no airway issues. It actually went to the side of his face. They pulled it out in the emergency room. When we rounded, he was 17, he and his cousin decided to throw pitchforks at each other. We don't know. Boys, I can say, I have two. When we walked around rounds, he held up the pitchfork and smiled. I was like, oh no. So we did a little education after that. The mom let me get on my soapbox. But remember that other patient, those other two that were coming in, this was one of them, say. Not mine, but the other attending picked him up. And he looked fine. And then EMS, we heard he was fine, and EMS rolls in, and they're bagging the patient. Heart rate goes up. It is okay. You know what to do. You've got this airway. You have to secure the airway. And in this patient, he got criked. Looked normal on the outside, but all of a sudden he comes in and you know nothing about him, but you have that training, you have that mindset, you can do it, and you fall back on that. Make sense? Yes. This is why you train. All right. So to end and summarize, this is our airway box, just as an aside. We use the DeWalt's. They're actually wrapped, so we know that nobody has tampered with them. Anytime they're open, we send them back, and we have a new one. And we keep about 3 or 4 of them in each trauma bay. They have everything in it, and they're checked off with the dates, so it's very helpful. The residents don't do this. We have somebody else do that, but it's very helpful when it comes to decreasing that cognitive load. If you don't have something like this, I suggest just maybe look into it to see if it might help. But I hope that you've understood the concept of cognitive load. It's going to be very different for you as a new learner. We understand that as that patient comes in, that one patient may be enough, but we want you to learn from that one patient, that difficult airway. How am I going to manage this, Dr. White? How am I going to do this? And that conversation is so important. For attendings or junior residents, it gives you the opportunity to train and push your learners even more so that when they leave, they carry your name and provide excellent care. So I hope this has helped. Thank you so much. And if you have any questions, I'm happy to take them.
Thank you, Dr. White. Anyone have a question to Dr. White? Dr. Jamil?
Thank you, Dr. White. Fantastic talk. And interesting, all the difficult airway talks we usually hear in conferences jumps into the technicality part, and I was expecting to see that, but you really shed the light on a completely different aspect that we don't or we underappreciate. Right. So thank you very much. My question to you is, can you elaborate on where to draw the line when you let juniors dealing with difficult airways with maintaining patient safety,
yes,
not compromising patient safety? Yes. I see physicians let the patient go down to severely unacceptable hypoxic numbers, right, and it has nothing to do with the time factor. Some people will just say, I'll give you 2 minutes, but really I think it needs more clarification for attending supervision to residents.
It's very difficult, isn't it? It's difficult, and I find even in our own practice, when I watch my colleagues, because now I work with other attendings on our shifts, it used to be it was just me, and I didn't really know how anybody else practiced. So my practice pattern is if they start desaturating and I think that it's harming the patient, and I don't think the resident has a clear idea of what they're doing, then I will step in, and we will work together, because I don't want harm to come to my patient. Right? And there is learning in that too. But then there are times where you even go in on that first airway, like that first attempt, and the patient just bottoms, right? And you have to also let the resident struggle just a little bit, right? Or else they're not going to learn that cognitive load, that ability to learn and persevere. You have to give them a little bit of that grit, if you will. But it's a fine line. There's a little bit of gray, right? And you don't want to harm the patient, right? You don't want to harm the patient. So I think that's also where if we do have maybe a resident who's struggling, and maybe we've heard that maybe their skill set needs to change in a different area, going back to the non-clinical arena and doing a little bit more of the case-based or simulation has been very helpful too. And that's when going, if this, then that. Well, what would you do if you can't ventilate this patient? And then we go through those procedures in a little bit of a non-threatening way. But in the moment, it is difficult. And there are often times where even our trauma surgeons, if it's the second look and we can't see it, they're like, Dr. White, take over. and I do, if it's in the best interest of the patient. But I think Dr. Gari will tell you they get a lot of training, and we give them a little bit of leeway, but hopefully not at the expense of the patient. It's hard as an attending sometimes. The gyroscope has made a big difference, I found. I don't know if you feel this way, especially as an attending, because I can see what you're doing. And when you listen to the literature on airways, Weingart talks a lot about, actually, you're not looking for the cords, you're looking for the epiglottis. Have you heard this? So that's exactly what you're shooting for. So as long as I can see what's going on, that makes me feel a little bit better. And then we can manage from there.
Thank you. Any other question? If no other question, thank you, Dr. White.
There is one question.
Dr. White, thank you so much for your presentation. It's really very beautiful and enlightening. My question is about the box that you presented in here. I read some of the materials that you have there. It's the basic things that you require for airway management, which is for, let's say, easy airway management. However, for difficult airway management, what other things that you would have if you anticipate or
Yes.
you...
The difficult area. Yes. So I always have a bougie and the Crike kit for us. You know, if you have to crike somebody, I know we don't like to say, oh, I crike some, but it's still an airway. You have still succeeded in your airway, and sometimes you have to. So in that box has really everything, all of our advanced, even our advanced maneuvers that we do. Usually it's the gyroscope. We have a very hyper-angulated gyroscope that we move to. I don't know if you use that one a lot. That has been very helpful, especially our African-American population, I find, and in our area is very anterior. So we always have a low pro that is very angulated, and that has been a game changer for us too. But having the resident maneuver with their own hand and really find for themselves, because they're going to have to do that on their own, has been helpful too. And then the bougie really has also been helpful. We have LMAs, we have King Airways, we can retrograde, and we have fiber optics. But really in trauma, and specifically for the trauma airway, if we're heading down that route, then time is of essence. And on top of giving blood and everything else, then we'll end up criking the patient. So that's pretty much our trauma kit as a whole right there. I don't know, do you all do anything else in particular?
I'm thinking about the pediatric trauma. Do you get pediatric trauma?
We don't see a lot of pediatric trauma. We don't see a lot. Usually they go to we have children's receiving centers. We'll see them with burns, but usually they go straight upstairs. But we do have small laryngoscopes for children as well if they do come in. Now that you need to do some square breathing in the children. I don't know, we have PIM here, pediatric emergency medicine physicians, but even now, that will definitely throw me into a little bit more cognitive overload just because I don't take care of as many pediatric, especially airway patients. But I think once you get in, for the most part, we were talking about some of the airways last night in children, sometimes they're a little bit easier too, so sometimes not, especially when you have parents yelling at you, right? So.
Thank you so much.
So thank you, Dr. Melissa. Airway topic, it's always an exciting topic. So if you have more questions to Dr. Melissa, you can catch up with her after the session. It gives me a great pleasure and honor to introduce our next speaker, who is an EMS and emergency medicine consultant at King Fahd Hospital of the University. He's a head of emergency medicine scientific council at Saudi Council for Health Specialists. He is a board member of SASM. He established an EMS unit at King Fahd Hospital of the University, founder of EM Today SA Conference, and he's a co-founder of medical director of Emergency Medical Care Program at Imam Abdulrahman bin Faisal University. So, ladies and gentlemen, let's welcome Dr. Thamer Al-Junaid.
4 seconds, breathe in. 4 seconds, breathe out. So thank you so much for the organizing committee to invite me to have this very difficult lecture to speak about. When Dr. Ma'an called me and he said, talk about shock, I was shocked that he gave me only 25 minutes to do that. Last year we held a workshop that was 8 to 4 to talk about shock. It took 8 hours to say everything we needed to say about it. And that was a challenge. The second challenge was that everybody last night in their lectures, or yesterday in their lectures, had a touch and go on every aspect I wanted to speak of. So if I wanted to present anything, it was already spoiled, and if everything I wanted to talk about was already mentioned. And looking at the audience, we have students, we have interns, we have residents, and we have attending. So what exactly do they expect of me? 3 different dilemmas that made me think, how could I come up with the points that I wanted to talk about and what to do about it, or how to go about it. So I went to artificial intelligence, ChatGPT, and I asked them, what should I present and how should I present the topic? And that was the answer. So they didn't know what to do, and they said, just go back to me and try to figure it out. So I took a second and I thought, let's start with a case. I had a smart resident once that was working with me, and it was a kind of a difficult case. We had a cerebral palsy patient. He was 17 years old with a history of a valve replacement on blood thinners. According to the family, they heard him falling down in the bathroom. They went, they picked him up, they brought him to the hospital. He was fine, complaining only of some hip pain. His blood pressure, when the nurses was checking it, was 88/50 with a pulse of 80. But he looked fine. The nurses was a bit eager to push him to the resus bed because of his blood pressure. But the patient was fine. So they came and asked me, what should we do? And this raised the question. I asked my resident to go and check the patient. She said the patient was looking just fine. Should we consider him in shock, or what to do next? So we're going to start approaching this case with what I think every one of us should be introduced to as a junior, or reminded of if you're a senior. Is the patient hypotensive? Whenever you see a patient that you consider the diagnosis of shock, the first question you should ask yourself, is this patient really in shock? And how do we define this? And this is really a problem, because the literature is telling us that at some point in the emergency department, 19% of our patients are having a low blood pressure, but only 3% are labeled as patients in shock. So where did the remaining 16% go? So I reviewed some of the literature. There is not much talking about it, but they said it either that the patient is wrongly measured because they use different size of cuffs. The patient is under the influence of some medication. This is his baseline. He has a pre-existing condition, but it doesn't mean that the patient is in shock. So reviewing the literature and seeing these statistics tells me that low blood pressure does not equal shock. So what is shock? Shock basically is that you have to have evidence that you have a decrease of perfusion. And how to know that the patient is having a decrease in perfusion? Rosen and Tintinelli have a very nice table that we go to. You have 6 criteria, you need 4 of them to be positive to say that the patient is having some decrease in perfusion. Either the patient is having symptoms saying that he's poorly perfused, having the change in level of consciousness, some shortness of breath, some chest pain, or patient is having a heart rate of 100 or a blood pressure below, a drop in arterial blood pressure, urine output is coming down. It's difficult to measure in the emergency, but at least it is there. An arterial base deficit of -4, or a respiratory rate of more than 20 with some sort of respiratory acidosis. So if you have 4 of these 6, it tells you that the patient is having some sort of a low perfusion, and this patient now is labeled as shock. So shock is not numbers, it's a clinical presentation. So you don't take one thing and say that the patient is in shock, you have to take the patient as a whole. So whenever you face this patient at the beginning, you have to check, is he really in shock or not, by fulfilling this criteria and checking the patient as a whole. In our situation, the patient was fully conscious. He had no symptoms other than the pain in his hip. His vital signs was mentioned, but he had no respiratory problems. And his base deficit was fine at the time. It was around -3 or -4. And he had no acidosis or something like that. So we thought that the patient is hypotensive. He's not in shock. So what do we do now? It doesn't mean that he's not having a problem. We just take a step back. We don't need to act immediately. We just need to think of what's going on. Later on, the patient became more drowsy, that same patient. And he started having what seems like a pre-syncopal attack. So the resident came and said, let's go back and see the patient. We went to the patient. His blood pressure was still low, but his pulse was raising up. We repeated his blood gas. His space deficit was increasing. So we're thinking, could it be the trauma? But now that family revealed another piece of information. The patient, at some point before falling down, he had some sort of dizziness. So it could be a medical kind of injury or a medical precipitated injury, not a mechanical injury. So now we have to step back and think, what is going on? It's not just trauma and hemorrhage. There are other types of shock. And this is the second question we should ask ourselves. If we establish that this patient is in shock, and now our patient is, so what type of shock is he having? Because each type have a different management, and we will come back to that. So how many types of shock do we have? Anyone? Is it 2? Is it 3? It's 4. Thank you. We'll discuss that later on. So we have 4 types of shock. We have distributive shock, meaning septic, neurogenic, or anaphylactic. We have cardiogenic, we have obstructive, and we have hypovolemic or hemorrhagic shock. Each of these shocks can be identified by having clear history and presentation. If you take good history and you do good clinical examination, you can find out what type of shock. But in the situation of the patient who we were seeing, the history is suggestive of many things. So how do we go about it? How can we know what type of shock, or at least get an idea of what type of shock he's having? And this is where ultrasound comes in. Now, with the RUSH protocol, you have to look at 3 things. This have been explained yesterday in one of the lectures, and they have talked about it in details. I'm just going to brush on it. You look at the pump. You look at the heart. Is there a problem with the pump? To check if there is a cardiogenic or an obstructive kind of shock. Then you look at the volume. You look if there is any fluid in the abdomen. You look if there is the vena cava having enough fluid or not. So you would say that this is a hypovolemic shock. Then you look at the vessels or the pipes. You look at if there is any signs of DVT. You look if there is any AAA and things like that. So we looked at the patient. He had non-significant findings. He had no fluid in the abdomen. The heart was fine. The vessels were fine. And he had some the vena cava showing mild hypovolemia, so we thought let's go back to see if this is a hemorrhagic shock or not. But the point is that this is a very fast tool that can tell us which type of shock or hints to which type of shock. And the reason why we need to know which type of shock, because you need to know how to manage it. And each type of shock had a different kind of management. At the beginning, when you go to the emergency department, when the patient comes to the emergency department, what we do is usually we resuscitate. So we start with everything and then we check, but sometimes you have to be more goal-directed. These 2 studies have been published recently, one showing that using the rush protocol or the ultrasound to identify what type of shock saves time. The first study tells us that it saves time to make better decisions for the patient care. But the second study looked at it from a mortality point of view, and there was no actual difference. And you will hear a lot of no differences in this lecture, and this created another challenge when presenting this. So now you did what you did, and you think that this patient is having a hypovolemic shock. So what you do next is try to fix or try to better resuscitate this patient, better perfuse this patient. And this is very important, especially for the juniors. Remember, this is what you're working on. This is the equation you're working on. Blood pressure equals stroke volume times heart rate, which is cardiac output, times systemic vascular resistance. Because these are parameters that is going to improve the blood pressure and improve eventually your perfusion. And you have many ways to do that. If you want to increase the stroke volume, you give some fluid. If you want to increase the systemic vascular resistance, you give some vasopressors. You can use ionotropes or chronotropes for heart rate and cardiac output. But which one works for which kind of shock? And this is where things comes interesting. If it's a hypovolemic shock or a hemorrhagic shock, you're mainly concerned about fluid replacement. You give crystalloid, you give blood according to whatever the cause is. If it's a cardiogenic shock, you're going to work on all three, but mainly systemic vascular resistance with epinephrine or epi and these kind of things. If it's a septic shock, again, you're concerned mainly, you're working on the systemic vascular resistance since it's a distributive shock, and you try to increase the volume. If it's an obstructive shock, of course, other than the obvious that you relieve the obstruction, you're going to work on the systemic vascular resistance and the stroke volume. So basically, remembering this equation and remembering how to deal with this equation will give you an idea of what to do. If you know what type of shock, you know what medication you're going to give and how soon you need to start them. So as we mentioned, these are the first three steps. Identify if the patient is in shock or not. Then try to identify what type of shock he's having. Last but not least, or before last, try to identify, try to give resuscitative measures to this patient. Now, you started with the resuscitative measures. A lot of people touched and go on many of these medications yesterday in their lectures. They said there is no differences between crystalloid and colloid. They said there is no differences between some of the vasopressors and others. A lot of things were no differences, but I'm going to tell you my conclusion later on. So what to do next? And this is, again, a schedule that tells you how to deal with different type. If you identify the type of shock, it's easy to know what to do next. Again, if it's a hemorrhagic shock, you replace the fluid, and this is guidelines on how to do that. If it's a cardiogenic shock, again, these are the things you need to do. And if it's a septic shock or a distributive shock, how to go about it. So this is found in Rosen and probably in Tintinelli. You can go back and go in details, and I'm not going to try to explain to you things that you're going to find in the book. I'm going to just tell you how you apply this in practice. So the first question and the fourth and last question is, what is the underlying cause and what will it take to fix it? So we have one or the other type of shocks, and you started your resuscitative measures, but the most important thing is to control the source. So if it's a hemorrhagic or a hypovolemic shock, stop the bleeding if you can, as soon as possible, and start to replace. And a lot of the people in trauma lectures yesterday talked about that, so I'm not going to go into too much details about it. If it's a cardiogenic shock, if it's an MI, do reperfusion. If it's an arrhythmia, do antiarrhythmic medication. And if it's a cardiogenic, if it's a heart failure, you just support the pump with the medication you have. If it's an obstructive shock, relieve the obstruction, whatever the obstruction is. Last but not least, if a septic or distributive, anaphylactic or neurogenic, give antibiotic, give steroids accordingly, and correct whatever the cause is. So this is a simple way to remember how to deal with shock. First, you have to make sure that this is shock, not hypotension. If the patient is in shock, you try to figure out which type, because figuring out which type of shock then you can identify how to resuscitate it. And we mentioned different ways of resuscitation, and this was mentioned in details yesterday in many of the lectures that was presented. Last but not least, correct the cause. So going back to our patients. So the patient, we assumed that he was a hypovolemic shock. We started giving blood, we started giving fluids. Then the patient wasn't getting any better. So eventually we found out that his INR was around 5. We did a CT of the abdomen. He had a femur fracture apparently when we did the x-rays. We did a CT abdomen. He had a very large retroperitoneal hemorrhage. It could be because of the coagulopathy. It could be because of the trauma. One way or the other, we had to not only give replacement and stop the bleeding, we needed to stop his coagulation problem and give fresh frozen plasma and other medication. Patient survived and died well eventually, but just this is an example of an undifferentiated shock that patient comes in and you go through this to do it. One last thing before we move to the next part of this lecture. There is a fifth type of shock for the people who said four types that we often forget. It's cellular poisoning. When you have CO poisoning, anything that needs an antidote. When you have something like cyanide poisoning and you need to give an antidote. So these kind of cellular poisoning cause decreased perfusion, and the treatment is different, that you need to give an antidote. Again, sometimes the patient presentation are a mixed type of shock, and this is usually related to toxins or medication. So you need to hit many things at the same time. Always remember that. Now, this is just, again, to give a way to the juniors to approach shock and to remind the seniors what to do. This is the first part of the lecture. Now, a lot of the things that was mentioned yesterday, I'm not going to mention again. We said in the evidence that you were going to hear yesterday and today that there is no differences between this and that and this and that. The only difference is, or that makes a difference, is acting fast. When you have a patient in shock, remember, whatever you do in the first 10 minutes makes a difference. So act fast, give fluid, give crystalloid, give colloid, start levofed fast, start epinephrine in the beginning. Act fast. This is the most important message I'm going to give you today in the management of shock. Now, there is a lot of myths and practices we generally, as practitioners in the emergency department, do, and I wanted to check the evidence behind it. Is there real evidence behind it or not? And this is the second part of the lecture, just to try to spice things up. So, when you're checking, and this is mainly used in pre-hospital setting or in triage setting, if you're checking the radial pulse, we're saying that the patient is having a blood pressure of 80 and above. If you're checking the femoral pulse and it's there, you're saying that the patient is having a blood pressure of 70 and above. If you're checking the carotid pulse, it's 60 and above. So how accurate is this? Anybody is still using these methods as a quick measurement? By show of hand, yes? Yani? No? Okay. So a few hands there and a few hands there, and the others I think are not practicing medicine because no answer was there. So we reviewed the literature. In 2005, the British Medical Journal published that 83% of patients with radial pulse had a blood pressure below 80. So you're still having a radial pulse and the blood pressure is below 80. 83% of patients with femoral pulse had a blood pressure of below 70. It tells us that it doesn't give you an accurate estimate of what the blood pressure is. And the authors concluded that peripheral pulses is not very helpful. It's helpful in one condition is, and this is where you practice, if you don't feel the pulse, it means the patient is severely ill and maybe futile. So the only way to use this is make sure that the patient is having a pulse. If he's not having a pulse at all, he's really sick. So act fast. Who's still using the tender bank position? Samhan? Anyone else? Who's not using it? Okay, more hands not using it. So it seems we're going the right way, but is there an evidence on using it? So the American Heart Association guidelines recommend that the patient be kept supine and there is no need to raise their legs. But a review that was published in 2012 showed that if you raise the legs or put the patient in Trendelenburg position, it will improve the blood pressure for 5 minutes. So that tells me that I can use Trendelenburg position as a diagnostic method rather than a treatment method. It tells us that the patient is hypovolemic if he responded initially. And after that, I will put him back in a supine position, and I will know that this patient will need some fluid replacement. So there is a use for it. It's not used for treatment. If you want to use it for diagnostic measures, if you have nothing else, this is a good way to go at it. Otherwise, don't put the patient on a Trendelenburg position. Who still believes in the golden hour for trauma patients? 1, 2, 3. Who stopped believing in the golden hour? So, from a pre-hospital point of view, and I have a pre-hospital passion and a background, if you stick to the golden hour, evidence is telling us that you're harming the patient, because you will have to push the patient to the nearest hospital, not sufficient to treat this patient to meet that hour. But if you ignore the golden hour and you just have a higher or a longer transport time to go to the trauma center, the nearest trauma center, evidence is telling us there is no increase in mortality and morbidity, and you're taking the patient to the right place at the right time at the right moment. So there is, again, it is important to act fast, but you can act as in the out-of-hospital setting, and the measurements that you take in an out-of-hospital setting is not increasing mortality and morbidity. Actually, it's helping the patient while you're going to the right place. So dressing. You're dressing a patient with a lot of bleeding, let's say a scalp wound, and it's causing him to have some fluid loss and going into shock, and the dressing is getting soaked. What do you do next? Do you remove the dressing or you reinforce it? Who reinforces the dressing? Who will remove the dressing? خالد انت ماشي صح اليوم. So there is a theory that when you remove the dressing, you remove the clot, and the clot causes more, when you remove that, it causes more bleeding. So a lot of people say reinforce the dressing. But if the dressing is already soaked, it means it's not really working. You have to do something else. So the evidence is telling us that removing the dressing, there is no evidence that it will dislodge a clot and cause more bleeding, but having a soaked dressing, it means that you're not controlling it well. So you have to have a better control. So instead of doing compression, what you should be doing is targeted compression. So instead of doing compression on the whole wound, do compression on the edges of the wound. And this is where the new clamps come in and the other measures. So you still need to do dressing. You can remove the dressing out. You don't need to reinforce it. And if it is getting soaked, do better pressure control, direct pressure control instead of just pressure control. So do you resuscitate based on vital signs? Who resuscitate based on vital signs? Show of hands. None. So what do you resuscitate on? So this have been studied early in the early 2000s, and they said if you resuscitate based on the vital signs, you're missing 50% of what you need to do. This was published in 2000. Then a registry of that went through for 18 years, they checked that moving from one stage of shock to the second only increases the blood pressure by around 7 millimeters, and the pulse never exceeded 120. So it doesn't tell you exactly what is going on. So resuscitating based on numbers of vital signs does not really help. What does help? It was mentioned last night, lactic acid and base deficit. It helps you identify the shock, and it helps you in resuscitation. So base deficit of more than -6 tells you that the patient is really in shock. That gives you confirmation that the patient is in shock. And if it is more than 11 or 12, you would say that it is 50% lethal, according to evidence published in 2005. And when you start resuscitating, you have to look at the lactic acid. And the clearance of more than 20% in 2 hours means that you're going on the right path. If it is not clearing, you're not going in the right path. So if you're resuscitating to identify shock, make sure that you look at the base deficit. Anything more than -6 is shock. Anything more than -11 and 12 is actually very dangerous. And you look at the lactic acid and you start checking your clearance. If you're clearing more than 20% each 2 hours, you're on the right track. So remember, don't resuscitate based on the vital signs, resuscitate on the lactic acid and base deficit. And I will know some people are going to ask, okay, what did you put the equation in the beginning? The equation is just to give you an understanding of what we're doing, not to give you a guide of what we're doing. So early fluid resuscitation, this was mentioned last night, yesterday in one of the lectures. And we still give crystalloids, but we have to now understand what's going on. If you give too much crystalloid, there is a lot of side effects. There is no harm-free procedure. You have hypothermia, coagulopathy, sometimes death, and bleeding patients. So ATLS moved from giving 2 liters in the beginning to giving 1 liter, then start thinking of blood and crystalloid, because if you're losing blood, you need to give blood, though there is no much difference in mortality. Patients with severe head trauma, you have to limit the fluid, and if you need to give fluid for volume expansion, you can give hypertonic saline. This is the evidence. I'm telling you the summary of the evidence. Last but not least, tranexamic acid. Again, a lot of evidence support giving tranexamic acid. It's a cheap drug that you can give and can give benefit to the patient. But evidence is telling us now that in many cases, the only time the patient will benefit of it if you give it early. So we have to talk about pre-hospital setting, and we have to talk about giving it as soon as the patient drops in the emergency department. Because if you exceed 3 hours, it doesn't really work as good as if you give it early. So it does work if you give it early. If you give it later, it might work, it might not. But its side effect profile is quite well, so there is no danger in giving it at the beginning. This is my talk. I hope I had some people change their minds about a few stuff, give you a guide of what you're doing. Thank you so much. If you have any questions, feel free to ask me. And if you want to contact me, this is my email address.
So thank you, Dr. Thamer. Very informative and intense lecture. Any question to Dr. Thamer?
So I usually say, if you have no questions, it's one of 2 things. Either you guys were sleeping and I was boring, or I did a great job. So which one was it? So clap. Hello?
I think it's no questions.
Okay.
All right. So may I ask Dr. White to come back to the stage, please, for a group photo?
Okay, I'll turn.
fantastic. بيننا تعال. Assalamu alaikum. Good morning, everyone. It gives me great pleasure to present Dr. Mary Tansky. Dr. Tansky is an associate professor and chair of her department, and she is the co-director of the Emergency Medicine Administrative Fellowship. Please join me in welcoming Dr. Tansky, presenting digital innovations to improve emergency care.
Thank you. Thank you. Perfect. Good morning, everybody. Thank you so much for having me. My name is Mary Tansky, and I'm the chair at OHSU, which is in Portland, Oregon, on the west coast of the USA. And I'm just so delighted to be here. Thank you so much for your warm welcome. I'll be talking about digital innovations to improve emergency care. So my goals today are to talk about how digital technology has really advanced rapidly, and a lot of this because of the COVID-19 pandemic that really pushed in the direction of digital care and technology. I'll talk about how some specific interventions impact each part of the ED visit, and also give some examples from my own institution about how we fundamentally changed access to care because of the digital world. In particular, I'll talk about virtual visit urgent care, asynchronous care, which is a pretty new concept, at least in the United States, where we're using more and more digital technology every day, and then hospital at home interventions and specialty care. And then finally, we'll talk about some efficiencies and predicted future of digital use. So early in the days of COVID, access to healthcare was markedly reduced. People that typically relied on frequent access to healthcare, including things like prescriptions, weight monitoring, frequent face-to-face visits with primary doctors, was completely cut off. And people were quite literally alone. And so the burden was really put on emergency departments who not only were standing there caring for patients with COVID and really sick, ill, critical patients, but also picking up the slack for the rest of the health care system too. So thankfully across the world, clinicians and the medical community are incredibly resourceful and immediately began planning and thinking and really kind of going outside of the box to think about how digital access can preserve that access for patients. The overarching goals in the digital care movement were to reduce transmission of COVID, maintain access for care, and also preserve PPE. It seems like a long time ago where we were thinking about these things, but it was really just a couple years ago. And as I mentioned, we'll be talking about these interventions today and how they impact the various parts of the ED visit, in particular, telemedicine, video visits, asynchronous care, like I mentioned. And broadly defined, DHIs, which we'll talk about, encompass all of this different technology that can be used. So DHIs, digital health interventions, can help increase access by removing the barriers of patients making it physically to a hospital. This can potentially keep patients out of the hospital altogether, or if they're already in the ED, can help expedite specialist care for them. They can help us look for trends in vitals, for example, remote vital monitoring, to see if a patient is doing well, or if they're starting to get worse and maybe they need additional access to care. And they can really help us move patients out of the ED or hospital to a more comfortable setting, which can help save the cost of emergency visits and inpatient hospitalizations. I really think that the sky is the limit when it comes to digital health, and the World Health Organization supports this too. They say they encourage countries to continue to develop DHIs for sustainable development and universal health coverage. So I lecture about boarding a lot, about throughput a lot. So you've probably seen this model before, the input, throughput, output model. I really like it because it helps us break down the ED visit into its most important parts. And digital health can improve every single one of these parts. So let's talk about input first. So I practice emergency medicine at Oregon Health and Science University in Portland, Oregon. And we're a little bit unique because we are the only academic center in the state, and we provide tertiary and quaternary care, not just for the state, but for the region too. And something very unique about OHSU is we're literally located on a hill Not just a small hill, but a mountain, a small mountain. So there's a tram that takes patients from the bottom floor where the clinic is to the emergency department and where inpatient care is. Even pre-pandemic, you can imagine that people had some difficulty accessing care as the only academic center in the state and being on a hill. And this is also compounded by the fact that in Oregon, there are not enough primary care doctors, family medicine doctors, or specialists to really care for the population. And so people need care and they need access. And many times they search for a PCP or a primary doctor, and they're told it'll be 4 months, 6 months before they can even be seen. So of course, in those cases, if patients need that care, they end up in the ED. So to address that, we thought outside of the box and stood up a virtual visits urgent care program, really with the goal of providing increased access to patients and avoiding unnecessary visits. The program allowed patients to log in from their computer or iPhone over a secure connection and spend 20 minutes with the patient and the clinician. We couldn't do things like lab testing or imaging, but it's surprising how many things could really be taken care of without being face-to-face to the patient. We could take care of allergies, urinary tract infections, sprains and strains, all of those things, as well as take care of some of the longer standing complaints, like refilling prescriptions, asking patients to monitor their weight. So it was really a reach from the emergency department into the community, as opposed to patients having to be in the community and come to us. We started this program in October of 2017 with very modest beginnings. In fact, in the first month, we saw just 6 visits. But slowly, word of mouth began to spread, and patients were willing to try this out. We reached about 80 visits or so through 2018, that's per month, and then in 2019, just under 200 per month. But then look at this. In March and April of 2020, when COVID finally made its way to Portland, Oregon, we spiked to 600 and 800 visits almost overnight. The need for access to care and the limitation of outpatient appointments, as well as the patient's willingness to try this, to try something new, really turned on overnight with COVID. And this volume has been maintained. This is a major success because otherwise these patients would still be trying to access care in the outpatient setting or end up in the emergency department. And our experiences are consistent with the CDC reports too, that say about a third of visits in 2020 were done by virtual care. Another major benefit of this virtual program was that our clinicians, again, could virtually reach into the community and help curb the pandemic. This is me at one of our COVID mass vaccination sites. And before the rapid COVID tests were popular and common and able to be distributed, our clinicians could give patients the results of their COVID tests by making that phone call, but not just that, they could also talk to them about what they needed to do for care, advise them if their family members needed to quarantine or if they needed to test or treat, and when to seek higher level of care. And then finally, when it was available, to prescribe Paxlovid. We also have a pretty large portion of immunocompromised patients in Portland, and they could arrange Uvishield prophylaxis when that was available and effective. So all of these are just, again, that virtual reach into the community that helped answer those questions and create that connection that we really needed that was lacking during COVID. Another great part about our virtual visits is they can support the ED environment by doing callbacks for incidental findings too. Between 30 to 45% or so, which is a pretty high number, of patients when they come to the ED have some incidental finding that was not known about on discharge. This can be things like missed fractures, a UTI with antibiotic resistance that we didn't know about, or even incidental findings like lung nodules. This can, of course, be a source of major morbidity and mortality and needs to be addressed. So the virtual team really wraps their arm around those patients to ensure that they are aware of those results and that they can find follow-up. And then finally, they perform callbacks for high-risk discharges. Pre-pandemic, when we had a bit more access, we admitted many more patients than we do now. We're really pushing the envelope and discharging patients that are relatively high risk, patients with trauma with minor injuries, pulmonary embolism, some chest pains. They would have been admitted previously, but now they're going home. So this digital connection can be used to check in on the patient more than during that one time in their ED visit, make sure they're doing okay, and if not, get them the support that they need during their home care. So this virtual connection that was set up as an idea from emergency medicine that had just 6 patients in the entire month of October 2017 was a game changer for COVID, and it helped keep patients out of the ED, support them, and support our community. And even though virtual visits and telehealth make the process of patient visits more convenient, we still found that sometimes patients had difficulties with technology and wouldn't show up for their visits. So one of the things we did was initiate a program called Smart Exam. This is truly an asynchronous type of care. It's a virtual visits platform. And what would happen is patients log in again, but on their own time, they could fill out a questionnaire targeted about whatever health condition they're coming with. Again, it's lower acuity type of care, urgent type of care visits, but they filled out the form online and they'd answer questions. And from there, the digital model would make recommendations about what kind of treatment was needed. The virtual clinician would then review the questionnaire along with the patient answers and decide whether or not they needed to be seen or if they could follow that asynchronous treatment plan. Again, the list of problems is pretty general: rash, allergies, headache, that type of thing. But Smart Exam was launched in October of 2020, and we've had almost 5,000 exams submitted to date. Of those, 2,400, so that's 49%, resulted in a treatment without a patient having to see a clinician. So that was truly asynchronous digital technology, not having to schedule an appointment or go to an ED. Around 1,400 or so 29%, the algorithm determined the patient needed a higher level of care. And so essentially they were screened and then advised to make a visit, referred first to the virtual platform. And then around 1,100 or 22% were referred to a higher level of care by the clinician. So they reviewed the answers, they had some type of concern and referred them into care. But this is very, very relevant because in our crowded ED system, these patients could get care on their own time, and every bed is so valuable, so it physically kept them out of the ED. I think it's really interesting if you look at trends of diagnoses that we continue to see through our ED and virtual care platforms, because around 378 patients per month have diagnoses that were Smart Exam eligible. So they could have used this program if they knew about it. So I think that this is going to continue to grow. And it's just amazing to think about how much capacity can be created in the system, whether the urgent care or the ED, by use of this to have the right patient seen, get the right care in the right setting. Okay, so we talked about virtual visits and Smart Exam to address the input. Now let's talk about throughput. This, oftentimes, it constitutes the bulk of the patient's ED visit. So again, I mentioned I'm at OHSU. It's an academic and teaching hospital, so we have many tertiary and quaternary care patients. And around half or more of our patients have a specialty consult in the ED. That's a lot. But again, it's all a problem of access. They're not able to get in with their primary doctor or their specialist in the clinic, so they come to the ED. And at the same time, we're all stretched, right? So the specialty services are stretched as well. There's a lot of pressure on them to be in clinic and seeing patients or be rounding. And so oftentimes from the ED, we'd call for a consult and be told, yep, we're happy to see the patient after clinic. And maybe it'd be 9 a.m. and clinic ended at 5. So it made no sense from a point of care and patient perspective to have that 8-hour delay in length of stay. So we reached into our virtual consults and digital technology to see if we could make a tangible improvement with patient flow. And our pilots were listed here: dermatology, psychiatry, and cardiology. So for dermatology, we looked at patients with skin rashes where disposition or progression was not clear. Dermatology was chosen because they're mostly clinic-based and everything is so incredibly visual. And in addition to not having to set up a virtual video right at first, we could take pictures, put them in the chart, and then discuss the exam and what's been going on with the dermatologist over televisit. After that, the dermatologist could review our images and then discuss with us the treatment plan and follow up with the patient in clinic. Patients loved this. Unfortunately, at the same time, because of COVID, the billing requirements were relaxed too, so you didn't actually have to see the patient in person. Almost immediately, we saw implementation of this process. All it took was uploading those pictures into the patient's chart and a quick phone call, and suddenly, patients who would be previously waiting for 8 hours for a dermatologist to come see them or for them to get back to the emergency department, their visits were basically slashed by 50% time. So that was a huge improvement, and it allowed us to turn over the bed and allow room for the next patient. The second phase is currently in process 2, where we're looking at punch biopsies, and if the ED physician can do a punch biopsy, give additional information to the dermatologist. Next is psychiatry. So we saw a huge increase in our mental health complaints in the emergency department during COVID, and at the same time, a reduction in the number of consults available. And even before the pandemic, this was again a challenge. So again, much of psychiatry is through talking, which is amenable to telemedicine and virtual care. So what we did was we started using video use with digital technology to have our psychiatrist connected with the patient in the ED. Previous to this, patients would spend literally days, sometimes weeks, boarding in the ED, waiting for a psychiatry consult, waiting for medications to get started, or if they needed inpatient, waiting for a bed. This allowed them to connect with a psychiatrist in a secure setting and get them on the path to treatment and disposition sooner. With this technology, we opened up 100 bed days in our hospital where patients were no longer waiting for care. So again, an overnight success with this program. And then finally, cardiology. Now, this is a surprising one because the picture of a cardiologist in most of our brains is somebody listening to the patient, listening to the heart and lungs, looking for JVD. But we found that patients that had obvious exam pathology, we could obviously assess that as an emergency physician and communicate it with the cardiologist. And again, so much of cardiology was visual. Can you help me look at this EKG? Or a communication process. Can you help me with a medication change based on this exam and labs? And we were lucky that at the same time, a new medical director started who was very into embracing this digital technology. So we started this from 8 a.m. to 5 p.m. with a reduction in consult times by 35%. Again, this helped with our forward flow, helped us get patients out of the ED and turn over that bed for the next patient. So these simple digital solutions that were not too hard to implement were embraced by the patient, were embraced by our consultants, and helped us get patients through their ED visit. So now we've talked about the front end and the mid end, the throughput. Now let's talk about disposition, the back end of the ED. So the main intervention I want to talk about here is called hospital at home. So I mentioned that OHSU is built on a hill. We have 575 acute beds, but we occupy about 95 to 100% of them at all times. For those of you who attended my boarding talk yesterday, you know that the optimal occupancy is around 85% to allow for that ebb and flow of patients and to really absorb anyone that's coming in. But we operate at way more than that on a daily basis. And so this means that patients that need to be admitted can't be because patients can't get out of the hospital. So it all kind of backs up downhill. So OHSU undertook a hospital at home program with the goal of providing the same type of inpatient level care in the patient's home. And the goals were to reduce hospital length of stay, to keep beds open for higher acuity patients, and then also to be able to monitor patients in real time to see if they needed more support that could be delivered at home. Additionally, secondary outcomes were patient satisfaction. Do patients like to be cared for in their home, as well as increasing and at least maintaining quality. So in our program, patients can be admitted to home directly from the ED or from a short stabilizing inpatient stay. And they have so much access, it's really incredible what's set up in their home. They have access to a nurse 24/7. Physicians do virtual video rounds with them just like they would in the hospital. They have pharmacy support. They have family caregiver support, a dietitian, all of these different things that can be set up when the patient goes home. I think that the most impressive part of this whole system is the digital technology that they receive. So they're set up with a full-time vitals monitoring system. The clinician can decide if they want vitals every 6 hours, every 4 hours, whatever they want, and those are documented. They're on a track board for the nurse to see at all times. They're also set up with a two-way audio-visual system on an iPad, and they have wearable emergency response system, just like a call light. They also have backup power and cellular power just in case Wi-Fi fails. So this is incredibly robust, and it allows that same level of care and monitoring as if a patient were in the hospital. Additionally, we have a setup where patients can receive IV antibiotics or medications. They can even get imaging and lab draws done in their home. So again, it really mimics being in a hospital. And the types of conditions treated vary. Home dialysis is really common, but so is pneumonia, cellulitis, COPD, CHF, and even post-op care, which was a new addition. We found that this is great for the patient, and it's great for the ED because we open up beds for our patients to move into. So since December of 2021, when this program was started, we've cared for more than 250 patients and have opened up 2,100 bed days to the home setting. And impressively, quality metrics are great too. We've seen reductions in catheter-associated UTIs, central line infections, surgical site infections, pressure injuries, and a reduction in delirium because patients are in their own home instead of being in a hospital bed. And additionally, a very impressive metric, our 30-day readmission rate was cut more than in half, from 15% to 7%, which is great for these complex patients. So I share this today because my experience as an ED clinician and administrator has truly been tangibly changed by digital health. And I think that continuing to have patients come centrally to the hospital is just not going to be a thing anymore. It's a thing of the past. We're going to be working more and more to bring care to the patient in all of these digital ways. This is applicable to health systems across the world too, and the healthcare industry here in Saudi Arabia as well. A market study suggested that the home healthcare industry is going to grow by 17% by 2028. That's huge. And the virtual platform too. Patients are going to have more and more access to virtual care, and I think that it's our job as emergency physicians to really embrace these technologies and push them to the max of what they can do, both to provide that access for the patient and to help them stay out of the ED, to stay healthy and to be cared for at home. So it's very clear that the COVID-19 pandemic kickstarted this digital health movement and that it's here to stay and will continue to grow. Sometimes I think the biggest barrier to using digital technology is just jumping right in. We found that many people, once sort of pushed, were willing to try this technology and embraced it. And our trends show that, again, it's here to stay. While there are some limitations, of course, I think that it can benefit patients at every part of their ED visit. And the asynchronous care is something that's new and growing, and I think is going to be a major satisfier for patients too. And finally, I think as ED clinicians, we have a major voice in the direction of digital health interventions to the future. We're on the front line. We see patients. We are able to dispo them quickly. We can tell when they need more access or when they need to be admitted or when they can go to a home care setting. And I think it's important for us to continue to engage with this digital health and push the boundaries to improve care for our patients. I'd love to take any questions. Thank you.
Thank you, Dr. Tansky. I think we're all embracing this in different sectors by different angles, and money plays a lot in this because it's expensive to introduce digital health. However, the outcome is very positive, and we all have different experiences. So do we have any questions for Dr. Tansky?
Thank you for this Khalid Abu Hamid, SASM board. We have interest in virtual care. Actually, we are very short of resources, and Saudi Arabia is huge and big. I have two questions in that regard. One, the organization of such service in terms of operation, structure, as well as organization structure and financial resources. Second, medical legal, if you can advise us on the implication of having virtual care in the emergency medicine. Thank you very much.
Sure. Yeah, so in terms of the structure, so the resources to start the program are not insignificant, but the benefit of keeping patients out of the hospital and really preserving inpatient care and specialty care for patients that truly need that type of care are huge because it opens up those beds and allows us to take care of other patients. In terms of structure, it's very difficult to get people on board with a virtual health platform. There's not a lot of standardization on what platforms host virtual care or how to integrate it into a medical record. So for us, our experience was we dabbled in this a little bit. There were several different departments, family medicine, internal medicine, who wanted to do it, but nobody wanted to go full in and open this up to the entire population. Family medicine and internal medicine, for example, wanted to open it up to only their patients, but it wasn't very effective because you can see in that first month, we only had 6 patients. And so we knew that we needed to open this up more broadly. So what we did was we tried to really own this as emergency medicine and say, you know, family medicine, internal medicine, sure, if you want to do digital access for your patients, go ahead. We're going to open it up to the community because our biggest need was resources of beds and we just didn't have them. So we took the lead and we kind of jumped in. We did do the financial investment in this, but we have found that the benefit of keeping patients out of the ED and staying off ambulance divert, being able to move them through, taking transfers as the tertiary and quaternary care center for the region far exceeded the initial startup costs for us at least. So those were some of the things that we we thought about before investing fully in this. And it's not perfect, certainly. You know, we only have 3 specialty consults that do this, which is, again, dermatology, psychiatry, and cardiology. But we could do this for other services too. They just haven't had the buy-in on their end yet. But I do think that this is the trend in the direction that we're going. For your second question about medical legal risk, it's a great question. It's one that we've thought about a lot. It's why we've kind of kept some of our virtual visits as relatively simple care. I don't think that there's ever a way to totally, you know, make this not a risk for yourself because, again, you're not examining the patient. So there's a relatively low threshold for people to be referred in for higher level of care if they need it. When the patient logs into the digital system, there's a list of signs and symptoms that they have. But again, we're blind without vital signs, right? But getting that sense from the patient, are they speaking in full sentences? You know, are they febrile? Are there things that they can do? Can they use their Apple Watch or other existing technology to tell us what their heart rate is? We've gotten pretty creative in trying to expand some of those processes to really push the limits for virtual care. And the second thing is, I didn't go through this because 25 minutes is a very short time to talk about such a broad topic, but some of the centers actually have an MA, a medical assistant, on site, and instead of the patient going all the way to the hospital, they can go to this area where a medical assistant can help look in an ear or listen to lung sounds or give us some very, very basic parts of the physical exam that help us feel less blind, you know, take a simple set of vitals. But it's been very interesting to develop the process and see that our referral to ED or in-person care has dropped as people have gotten more and more comfortable with using the technology. So, so far so good in terms of medical legal. I think I always try to think about risk versus benefit. And for us, being able to care for these patients is at least some access. And if there's a red flag or something pings in our brain that they need to be seen, we don't hesitate to refer them. But the fact that there's so many people using this now and that they would literally have no other option, and they might be delayed 4 months to see a primary doctor, or they might wait 12 hours in the ED to get care, that to me sort of offsets that as a benefit. So not perfect, but something that we're trying to do with the goal of improving that access for our population.
Thank you for this talk. We have an excellent experience at King Abdulaziz Medical City, Riyadh, similar to what you had in the beginning with the COVID, when we have the curfew and we were concerned about the patient. Suddenly we had too many calls, and we developed a call center where most of the cases were related to COVID. When the cases of COVID went down and we want to utilize the same resources, we decided to open a tele-emergency service. There was concern from the patient, what is the value for them? Will it replace the visit to the ER? Because we know that too many patients are visiting the ER just to access the health system. They are not really an emergency patient, so we focused on this group because they take about 30 to 40% of our visit. So most of the patients were calling just to access the healthcare system. There are some limitation because some of them, they think the visit to the ER is more useful for them because they can get medication, appointment. Sometimes they'll get specialty to see them. So it's not as we expected, but actually the volume are increasing now because they start to recognize some value for them. They can get triage over phone because we have staff who triage the patient before the physician. If they don't need to call a physician, they will not be referred to a physician to call them. If they need an appointment, they will get the appointment. If they have a question, they will get the question. Some of them, they visit the ER just to refill their medication out of, or they miss their appointment, and they will be served before getting to the doctor. So I think there is a value for them in for emergency department, but with time, probably the need will increase with time.
I think so too. One of the things that we saw is that the referrals to the ED from patients who called in was much lower because the knee-jerk reaction for many of the nurses, if a patient called a nursing triage line, was go to the ED. And so this gave people a second level of care where a physician or an APP could address them and do, as much of an exam or ask specific questions. And the knee-jerk reaction was, okay, let's wait a day, or let's have you get a visit, or, it really helped to reassure patients. And we also could prescribe some of those medications. And, we saw many patients who would previously wait for 4 months, be out of their blood pressure medications for 4 months because they couldn't get that visit. So we were able to refill medications right from the patient chart. So there's definitely a lot of benefit, and I certainly think it will increase. And I think patients knowing that they have another resource that they can access to ask questions or to, help get their care started makes a big difference for just a collective sigh of relief for the community when access is so limited.
Any other questions? So I would like to brush on the medical legal issue as well. We're embracing it in our hospital, and my kid's pediatrician has been doing WhatsApp consults for years now. And you just send him the picture or the question, even voicemail, and he answers back. However, we take this, the responsibility of the repercussions of this simply because I'm a physician and we know that physician. However, if you want to generalize it into a population, the medical legal aspect is very much a concern. And because it's not only because it's new, because we want the patient to be involved in that decision. We want to share that decision with them. And the way we're doing it right now, the way we're planning it is, number one, there's a disclosure where the patient has to tick certain questions. Do you have chest pain? Once he says yes, he or she says yes, then they're out of that virtual visit. And the other thing is the medical legal aspect coverage. So does the malpractice insurance cover you talking to a patient via video? Not without vital signs, without a proper ECG, without. And I think I don't know what the experience you have with this. I would be very interested to know, especially that medical legal aspect in the States is far more advanced than we have right now, but we are getting there. So I wonder if you can brush on that, just how do you do it? How do you make sure the physician is safe?
Yeah, that's a great question. So there's a couple layers that are built into the system. One of them is the self-selection criteria. So when you sign up for the virtual visit, it's for a very specific set of chief complaints. Of course, we all know that on Review a System, sometimes patients are like, oh yeah, I've been having a terrible headache and chest pain and back pain, all those things. Those patients would likely be referred. And so the first step in that self-selection process is low acuity complaints from a specific list. And honestly, a majority, I would say, are URIs. And you can see the patient. And, all of us kind of get that gestalt when you walk into a room. You're like, ooh, sick versus not sick. So that does help because at least that part is visual as opposed to just a picture, So that's kind of number 1 and 2, I guess, is the self-screening, then that initial virtual image. We actually haven't had any medical malpractice suits since the program's inception, and I think it's because the clinicians have a relatively low threshold of referring people in. But it is a self-selecting population because many people who, used it for allergies or a rash or COVID or something had a good experience, and when they need that lower level of care, they go again. So I don't want anyone to have the impression that we're taking care of, really severe sick patients or bad pneumonia or things like that. And of course, you don't always know that, but it does give you that connection to be able to help triage with that virtual view, as opposed to just the knee-jerk on the phone, say, go to the ED, So again, it's not perfect, but it does help. The other thing that's interesting is for televisits, they are reimbursed. There were some provisions during COVID where you don't have to have that in-person visit to both help with PPE, help access, all of those things. But you have to be within the same state. So for us, Oregon, Washington, and California are all very close to each other. Or sometimes it's a patient that lives in Oregon, but they're traveling in a different state. You have to confirm the patient's location to make sure they're in a state where you're licensed, which is kind of an interesting little caveat that we learned as we went. But to your question, I think the medical legal aspect is very real, but we've been pretty lucky in being conservative with patients that we think need escalation and still picking off, I would say these are ESI level 4s and 5s who really don't need that testing and don't need, they just sort of need that reassurance, maybe need some treatment, and of course good return precautions. If this happens, seek care. So I think that's how we are able to manage it pretty successfully.
Thank you so much, Mary. Great talk as usual. Very happy to have you here today. My question is, have you thought about doing this internationally? Like a lot of patients, they want to be seen by a doctor from a well-established system, and they're in a country where they cannot have that service. So have you thought, what are the possibilities of expanding this to an international population?
Yeah, that's a great question. I think it is possible. Again, I think the licensing component would be the biggest barrier because, again, I can get to Washington from my house in 10 minutes, you know, and if patients are in Washington, I have to have a Washington license to be able to care for them virtually. So I think that would have to be sorted out before you could open it up either, you know, throughout the country or internationally, is how does that licensing piece work? Because currently you have to be in the same physical state as a place that you're licensed to take care of that patient. So that's what complicates it a little bit.
So thank you so much. This is kind of interests me because with the progression of where EMS is going with mobile integrated healthcare, they have the advantage of being mobile. So instead, you can. My question is, did you think of integrating this virtual concept with their practice? So instead of like they moonlight or during their off time, they can go and see these patients and they can give you a clinical, at the end of the day, they're clinical providers. They can give you a sort of an assessment of what's going on. Then you would make more an informative decision through this. Would this be any useful, or do you think this is going to be causing more expense rather than saving money?
Yeah, no, that's a great question. So actually, one of our next pilots is with EMS. We have a new EMS medical director who's very interested in virtual care. And so that's on the way. We actually also have a new EMS fellowship that's just accredited for this year. So that's one of the first things that we're going to be working on. The challenge in Portland right now is our EMS system is very, very stretched. Our call times are increasing. The number of patients accessing EMS care is really high. So we don't really have the capacity right now to do check-ins on patients who maybe access virtual care. But the goal is to have EMS be able to connect with a physician to do home care and not have to transport a percentage of patients because they can use their clinical assessment. They have vitals. They, could reliably transport them if they needed it. So that's coming down the pipes. I hope that it. That sounds perfect.
Thank you for this important talk. In terms of cost effective, how is the digitalization affecting the revenue of the emergency department and the hospital in terms of the cost and revenue cycle?
Yeah, great question. So I think the benefits from cost for the patient, it's a set fee for our virtual visits. So if you have insurance, it's covered. If you don't, it's out of pocket, same price for the virtual visit. So it's very cost effective from the patient standpoint because, again, we saw so many patients who could access this virtual care going to the ED and getting thousands of dollars of visits as opposed to this inexpensive price for a virtual visit. Secondly, the benefit the cost to set up the program was not insignificant. We had to license a virtual platform, have people get their licensing, set up a schedule. We have 12-hour shifts. So all of those different things, having a clinician available, were important. But we added to the number of things that the virtual clinician does, including those callbacks, including giving people results, to make sure that their time is being used well. And then secondly, the other part of the cost analysis we did is what is the benefit to the whole system of keeping patients that don't need higher level of care out of the ED. So again, previously we would do things like go on ambulance divert. Well, we know that the cost of diverting an ambulance is extremely high because 40 to 60% of those patients end up admitted. And so if we can't get them in the door because we've hit our threshold and there's physically no place else for that patient to go, they go to a different hospital, that's lost revenue for our hospital. So we tried to look at it holistically and make sure that it's benefiting the entire system as opposed to just looking at the program in and of itself and thinking how much revenue does it bring in. So not only does it bring in a modest amount that actually covers the clinician's time It provides that care to the community by doing callbacks and check-ins and incidental results, which is very necessary, especially in our day and age. And it saves money from other things down the line that are less, concrete and maybe a little bit less obvious, but keeping patients off divert, having the ability to transfer patients that need OHSU-specific care into our system as opposed to them waiting for days or not coming at all. So that's how we were able to sort of justify the investment in this. And, some of the things I didn't talk about but that are also important, the volumes have been high enough that we've added a second physician shift. So, it is certainly been a benefit not just for the program, but also for the entire system as well.
Thank you, Dr. Tansky. With the obligation of time management, we would love to hear more. We do have a coffee break for a short period, and we all have a lot of technical discussions and questions. Maybe we'll do it during the break.
That sounds great. Thank you very much.
Thank you so much. Thank you all.
Hello, and thank you so much for having me at your conference in Jeddah. Sadly, I can't be with you, which is a great shame. I was out in Jeddah in 2019 for the SACEM conference. I had a fantastic time with wonderful people. I learned loads, and I really hope you're having a great time at the moment. I've got the next 20, 25 minutes or so to talk to you through some of the really interesting evidence and papers that have come out in the last year. So quite a lot to get through. We'll crack on and see how we go. So you don't need to write anything down. That's the most important thing. There is a blog post with all of the information and the links to the papers and more critical appraisal in depth if you follow this QR link. And you'll see this as we go through. It's on the St. Emmeline's website, which is our blog and podcast we run here in the UK. So don't worry about the detail. I'm just going to give you the headline facts, the things that you need to know. So paper number 1 is the PATCH trial. Now the PATCH trial is a really interesting trial. It's about tranexamic acid in major trauma, and this has been a bit controversial. There were some big studies, the CRASH-2, the CRASH-3 studies, which suggested a mortality or certainly a benefit for those patients who were bleeding. But it was criticized because it wasn't necessarily all the patients in high quality trauma systems. And people said, well, actually, maybe it's just an effect in low and middle income countries. And so the Australian group got together and said, well, we'll do a TXA trial in Australia, Germany and New Zealand, and we'll look at a high quality system and find out whether it works for real in our environment. And this may be very relevant for you in Saudi Arabia and the Middle East, where, healthcare is pretty good. So published in the New England Journal of Medicine, severe trauma patients and looking at TXA or placebo. So yeah, Australia, New Zealand, Germany, 1,300 patients recruited, and they either gave them TXA or they gave them placebo. And their outcome measure, interesting one actually, they looked at the Glasgow Outcome Scale Extended of a score of 5 or above at 6 months. That's kind of interesting because TXA is really about solving a bleeding problem rather than an outcome problem. But, that's what they chose to do, and they got some interesting results. So let's have a look and see what they got. Well, firstly, what is a Glasgow Outcome Scale Extended of 5 or above? It's here, it's the middle column. So it's a lower moderate disability. In this study is considered a positive outcome, and anything below that is considered a negative outcome. So an upper severe disability, which actually only needs partial assistance in the activities of daily living. And I think there's a question there about whether that's a correct sort of outcome for what we're trying to test with TXA, which is about a bleeding to death issue from major trauma. So in my argument, probably early deaths is probably a better way of looking at it, but that's what they looked at. So let's see what they found. So TXA versus placebo, followed the patients through 1,300, and at 6 months later, when they looked at their outcome scores about what they were able to do, there was no difference. The TXA group and the placebo group, exactly the same proportion of patients who had a positive outcome in their opinion. But if you look at some of their secondary outcomes, and the one which I'm most interested in is mortality and survival, there is a difference. It's about 3%. So if you give people TXA, you are more likely to survive. So there are more survivors at 6 months, but the additional survivors are those who have additional disabilities, so the lower scores, the 4s and the 3s. Now, I think there's a bit of a philosophical thing here about whether or not you consider that to be a negative outcome. For me, there is no great surprise that if you save more people with very severe trauma who would otherwise have died, then there will be more disability. And at 6 months, I'm not sure that that's long enough for us to really know what the outcomes are for things like head injury and neurorehabilitation. So for me, the message is quite clear here. I think, yes, it's absolutely in keeping this trial with all the other trials that we've seen around TXA. So if you look at the number needed to treat against the risk, the more severely injured you are, the better TXA seems to work in terms of mortality. So the PATCH trial, you can see there, it's quite significant mortality in this thing. So for me, quite clearly, give TXA if you want your patients to live, but accept that some of those additional survivors may have disability, and there's more work for us to do in making their outcomes better. So let's keep going with that and see what you think. Your opinion, I want to know what you think. Get in touch via the blog. Paper number 2 is on also a tranexamic acid one. I thought this was quite an interesting study looking at whether or not we have differential prescribing and differential outcomes for TXA in our major trauma patients depending on their gender. So What this study did is it took the data from the CRASH-2 and the CRASH-3 trials, those very large randomized controlled trials of TXA across the world, and they reanalyzed it of 32,948 patients, specifically looking at whether or not we did things differently for men and women. And it's a study in two parts, really. The first part is they looked at whether or not there was a difference in the clinical effect of TXA between men and women. And although there was a little bit of a difference in terms of the relative risk of survival between the two patients in the relative risk of the advantage of TXA between men and women, it wasn't statistically significant. And in fact, it's pretty reasonable that we can pretty much assume that men and women benefit from TXA equally across these studies. And the data that they put in there was against the outcome data from these CRASH trials. So it works. So if the outcome data, the effect of TXA is the same for men and women, we should be prescribing it equally between men and women. I think that's a fair comment, isn't it? So what they then did is they went into the UK TARN database. The TARN database is the database of all major trauma patients who come into hospitals in the UK. And they looked at all of those patients with an ISS of more than 9, so moderately and severely injured patients. And they looked at the TXA use between those two groups, and they found quite a substantial difference in the prescribing between those two, suggesting that we do things differently for women as we compare to men. And actually, there's a lot of evidence that we do this in many other conditions, like pain relief, that we do it in terms of access to PCI, we do it in terms of thrombolysis. So I'm not really surprised at this data, but perhaps for major trauma, it's something that we should look at. Now, there are differences between men and women. They have slightly different trauma injury patterns, and women tend to be older. And there's proportionally slightly more patients in the older age group who've had low falls, so fall from their own height, who still get those injuries. So you say, well, maybe they're more difficult to spot. So they did another analysis on the data to look at whether or not there was any effect on how severely injured you were, and whether or not it was because we were missing TXA in the slightly less seriously injured patients. And what this graph shows is that along the bottom there, you've got the BAT score, which is basically a measure of how severely bleeding these patients were likely to be. And even with very high BAT scores, you can see a disproportionately fewer women are being prescribed TXA. So this seems to be something about prescribers. Think about it. I don't know whether it happens in Saudi Arabia. This is a UK study. I suspect it probably does, because we've seen these kind of effects all around the world. So have a think about your gender bias in trauma, about imaging, about TXA, about all of those kind of things. Really interesting work. Now, paper number 3, where are we going to go next? We're going to have a look at, I think this is a game changer of a study. It really is. Now, Delphi studies are consensus studies, and this is a consensus study about how we extricate patients following a motor vehicle collision. Actually, it's the summation of a lot of work which has been done over the last 10 years looking at how we get patients out of entrapped vehicles. It's something called the EXIT project, and it's been running it in the UK. And the reason why this is important is there's a balance. So if you have a patient who is genuinely trapped in a motor vehicle collision, there is a balance between getting them out of the vehicle without potentially worsening things like a spinal injury, which is what we've been all told that it's a terrible thing, that your patient in a vehicle may have an unstable cervical spine injury, and if you move them by more than 3 millimeters, their cord will be damaged and you will be sued and it will be terrible for the patient. Actually, the data doesn't really support that. So we've done a lot about minimizing spinal movement and taking people out on spine boards and cutting roofs off cars. But the other side of that balance is that patients who are entrapped in vehicles are often very seriously unwell for other reasons. They may have bleeding injuries, they may have a splenic injury or a chest injury. We can't really treat that in a car. And the longer they stay in the vehicle, the longer it takes them to get to definitive care. So there's a balance to be drawn there. And arguably, we've been too far on the side of minimizing spinal movement. And in fact, the data shows that if you actually ask somebody who can get out of a car to mobilize themselves versus you take them out with a fire crew, you actually get less spinal movement if the patient does it themselves. So there's a lot of evidence that goes behind this. But what they did is they brought it together. They got 60 international and UK experts. They did a 3-round Delphi, which is a technique of organizing consensus into statements. And they looked at entrapment RTCs. What did they find? What did they decide? And what's changed? Well, there are a number of recommendations. I will not tell you all of them here. But the game changers are, The evidence shows, the experts agree, that if you can self-extricate or minimally assisted extrication, maybe just by putting a cervical collar just to help people get out of a car, to follow instructions from somebody about how you get out without moving your spine is the way to do it. We don't need to cut people out of cars if they can get out themselves. And what we're looking for is somebody who can manage their own weight, who doesn't appear to have clinical reasons for why they cannot walk. Really important. We've also got to be mindful that all patients with evidence of injury should be considered time dependent, and therefore we've got to get them out. We should not leave them entrapped unless we absolutely have to, or we cannot get them out. We recognise that we can't do really good clinical care during entrapment, so that's another reason to get them out, to get those necessary interventions. And there's also some really good work there about the patient experience and the fact that for patients it's terrifying, and maybe we should allocate somebody to look after them. But that number one point about self-extrication, we do this now. It's made a real game changer for my practice working in HEMS and pre-hospital care. So the line I want you to remember is we need to extricate to resuscitate. We cannot resuscitate our patients while they're trapped in a vehicle. They often have time-critical injuries. The incidence of spinal injury is quite low in this group. It's less than 1%. So do your best, get them out, do the right thing. Paper number 4 is about video laryngoscopy. Oh, this debate's been going on a long time. Should we use a VL or a DL in the emergency department, in the ICU, to intubate our patients? And the technology has moved on. There's been various different things. So the evidence from 10 years ago is already out of date here. So there's been a new trial published in the news looking at VL for critically ill, unwell patients, the sort of patients that we see in our emergency departments. So what did they do? They did a multi-center RCT in the ED and the ICU, over 1,400 patients, and they randomized to either VL or DL. Now, there were some exclusions about patients in whom they said, well, we've definitely got to use a VL for this patient, but it was reasonable. And the outcome measure was first pass success. So did you get the tube in first time? A lot of trials, it's okay. It's a reasonable outcome measure. So what did they find? Well, quite interestingly, the first pass success was considerably greater if you used a VL. 85% versus 70%, which tells me two things. One, it's better with VL. Two, that's a really low first pass success rate. In my service, we expect a first pass success rate of more than 95%. The reason is because A, they had a very strict measure of what first pass success was in this study. And the second reason is a lot of the people who were doing it were quite junior clinicians. So they were learning as they go. And I think this is a really important point about VL. And they published some data, I don't think it's in the full paper, but they presented it to show that the difference between a VL and DL was really proportional to how many intubations you've done before. If you're a new learner, VL is so much better than a DL. If you've done more than 100 intubations, there's probably not a big difference. What does this mean for me in an academic center? It means that when I'm teaching, when I'm learning, when I'm getting people to be better at their laryngoscopy and their intubations, I am going to use VL. So it's now part of my practice, but when I teach people, I use the VL, we use a McGrath, and I tell people to first practice DL, so they learn to do DL, and then use the VL, so they get both skills as they practice. And that will depend on which type of laryngoscope you've got. But yeah, give it a try, go for it, see how you go. Paper number 5 is looking, this is another game changer. This has changed my practice. It's changing a lot of people's practice around the world. And this is about refractory VF defibrillator strategies. So what happens at the moment is if you're in VF or VT, we shock you and we in the anterolateral positions. And if that doesn't work, we keep doing it. We keep going. And it doesn't, if it's not worked after 3 times, it often doesn't work ever. So this study looked at whether or not we should go from an anterolateral to an AP, or whether we should do what was dual sequence defibrillation. So we have 2 defibrillators on, and we do one and then another one 1 second later. So we change those pad positions, or we put an extra defib on. In Canada, they looked at 405 patients in refractory VF, which is defined as they'd already had 3 shocks. And they did one of 3 things. They carried on as standard. They did what they call vector change. So they went to AP, or they did the DSD. So they put 2 defibs on, shock, 1 second apart. And what did they find? This is a game changer. Survival to hospital discharge. If they carried on doing the same thing, 13%. If they changed pad positions, 21%. And if they used 2 defibs, 30%. That is huge. That's a massive effect. And I won't bore you with the statistics, but the AP and anterolateral, maybe the difference isn't as great statistically, but the difference with the dual sequence is huge. So now in my practice, if I go to in HEMS, or if a patient comes in, they've already had 3 shocks, my go-to next thing to do is to go for dual sequence defibrillation. Bottom line, don't keep doing the same thing. After 3 shocks, do something different. If you only got 1 defib, change position. If you've got 2 defibs, dual sequence. Paper number 6 is major incident triage. I've been interested in major incidents for years, and triage is really important. But the problem we've had is that a lot of triage scores are quite complex, they take too long, or they require quite a lot of training. And they may not really be particularly evidence-based, and it's complex because you've got to deal with different ages and different types of incidents and different providers. And so there's been quite a bit of development, and certainly in the UK, there's been some really interesting stuff of late. And this is what they've come out with as the final thing, which is the 10-second triage thing. I'm going to take you through it in a second. It's based around answering the questions of how do we spot not just patients who are severely injured, but those who might benefit from intervention. And that's a really important distinction, because in triage, I'm not interested in spotting everybody who's going to die. What I want to know is which are the patients who I can stop from dying, and that's different. So I'm also interested in age, usability, and speed. And they've taken really good evidence from studies such as the MIT study and the MPTT24 studies, where they derived physiological and practical factors from military databases, which helps them identify which groups of patients can benefit from early intervention. What did they find? This is really good because it can be taught very quickly. It doesn't require any specific medical training, and it's easily available. So this is now taught to all fire, police and ambulance services in the UK. So as a major incident, we've got lots of people who can do this. Very easy. If they're walking, P3. If they've got obvious severe bleeding, pack it or put a tourniquet on it, they're P1. If they've not got severe bleeding, they're talking, but they've got a penetrating injury, high risk, P1. If not, P2. If they're not talking, can they breathe? If they can, P1. If they're not, well, that's a group of patients who we need to decide whether or not we've got enough resources to do CPR for them, yes or no. So still decisions to be made, but this is quick, it's easy, it's teachable and rapid. So I can see this going across, certainly across the UK. I think it's going across NATO. I can see this going around the world as a first line triage tool. So very good. Paper number 7, getting there. More on RSI. Now, fentanyl, in the UK, certainly our standard recipe for RSI in critical care patients and the ED and HEMS is fentanyl, rocuronium, and ketamine. And generally speaking, we've been going to a 1-to-1-to-1. So milligrams per kilogram of ketamine, milligrams per kilogram of rocuronium, and micrograms per kilogram of fentanyl. But there's always been a bit of a risk about fentanyl. And we found in quite a few observational studies that it can be quite effect on your blood pressure. It's supposed to be fairly cardiac stable, but in the kind of patients we see, they're often pretty labile. So gone to Ket, Rock, Fent, but concerns about lability of fentanyl with your blood pressure. So an RCT, great to see, 290 patients looking at fentanyl versus placebo, and they match the ketamine dose. So if your patient was going to get 80 milligrams of ketamine, they give 80 micrograms of fentanyl or placebo. And they looked at the blood pressure, because that's really what we're trying to control. And they were trying to keep it in the band 100 to 150 millimeters of mercury, not going too high, not going too low. What did they find? Well, the first thing is it makes a difference. If you get fentanyl, it has a big impact on your blood pressure. So if you give it, you're more likely to get hypotension than if you give placebo. So it does have that hypotensive effect. So you've got to be careful with it. But it also prevents hypertension. So you're less likely to get hypertension if you get it. So this is quite difficult, isn't it? It doesn't tell us exactly what we need to do. For me, what it tells me is that there is an effect. You can see it in the graph here, that there is a definite effect with fentanyl. I need to be quite careful about what I do. So now I'm tailoring what I do. I'm not giving fentanyl to everybody. For my isolated head injuries, where I really don't want them to spike a high BP, and they're already at a high BP, I'm definitely giving fentanyl. For my head injuries where they're quite low BP to start with, and I'm really worried about hypotension, because hypotension is bad for my head injuries, I'm not giving it. So the thing is, you've got to be mindful about this. You've got to think about your fentanyl dosing, because it does have an effect. Right, paper 8, thrombectomy or thrombectomy with thrombolysis. So our stroke patients, a lot of controversy about thrombolysis, about whether it works, but thrombectomy, the data is looking really good for. But if we're waiting, a patient comes in with a stroke and we're going to send them for a thrombectomy, should we thrombolyze them first and then do the thrombectomy? Or should we just wait and do the thrombectomy? That's a good question. And we didn't know the answer until this year. So they've done an RCT, non-inferiority as it was, Canada and Europe, 400 other patients, and they compared thrombectomy alone within 75 minutes, or thrombolysis and then the thrombectomy. And they looked at the modified Rankin score of 0 to 2, which is a good score, at 90 days. And they were expecting maybe we'd find no difference. They actually found quite a significant difference between these strategies, a 10% difference, which was statistically important. So this is a real difference. So it means that we should probably do thrombolysis and then thrombectomy. And why that's interesting is it opens up quite a few possibilities, particularly if you're thinking about networks for stroke, because not every hospital can do thrombectomy. But what this means is if you go to a hospital down the road, maybe you should have your thrombolysis there, then get transferred for your thrombectomy. It opens up the possibility of doing interesting thing with stroke networks, and that's always a good thing. So start thinking about how you're doing that, speak to your stroke physicians and see if that's a strategy you want to adopt locally. Good paper. Number 9 is another out-of-hospital cardiac arrest study looking at eCPR, so ECMO or a CPR, invasive CPR, putting people on VA ECMO for their cardiac arrest in refractory shockable rhythms. A great study. So this was looking at this, it was done in the Netherlands. So whether you go ECMO or you ECNO, that's my little joke for the day. Lots of interest in it, not a lot of evidence. 132 patients randomized to this using their HEM service. And their outcome was favorable neurological outcome at 30 days. And actually, they found a difference. It was a 4% difference. It was statistically not significant, not as much as we've seen in other trials. But actually, if you dig into the data here, there probably is an effect. There are a couple of things. They were still in the setup during the study, and actually only a third of the patients in the eCPR group actually got it. So what this tells us effectively is, even when only a small number of people get eCPR, it's likely there's an effect. But the evidence isn't quite there yet. So I think we need a little bit more evidence. Are we ECMO? Are we EC don't know? Or are we ECNO? At the moment, I think we're EC don't know. But watch this space. It's a really interesting study. Definitely read it if you're thinking about setting up an ECMO service. And then lastly, just for a bit of fun, age and clinical outcomes. Now, you all know that the older your patient is, the less good their outcome. That's not what this paper is about. And this is a very sad paper for me as I get older. This is about how old your doctor is, how old is your emergency physician, and does the age of your emergency physician change the outcome of your patients? So this is bad. So they looked in the US at patients aged between 65 to 89. They looked at the Medicare system. They took 20% of the patients in that system, and they looked at the 7-day mortality of the patients compared to how old their treating doctor was. So it's a big database. 2.6 million ED visits, 32,500 physicians. And what did they find? They found there's a difference. So these are big numbers. They're not big differences, but actually big numbers. These are statistically important. The older your physician, the more likely you are to die. So please don't get old. Now, there's lots of reasons why this may be, and the study can't tell us that. My personal belief is it's about making sure that as we go through our careers, we keep as up to date as we possibly can. So CPD, coming to a conference like this, talking to your friends, learning new things, staying in the lectures, exactly what you guys are doing now, I think is the solution to this. But I don't really know. But I just thought I'd leave you with that. And please be kind to us older emergency physicians. We need all the help we can get. So please don't get old. So where did that leave us? 10 things. Conclusion. Give TXA. It saved lives. Look for your gender differences in trauma patients. Extricate to resuscitate. In refractory cardiac arrest, VF shockable rhythms or VT, change to DSD or change your paddle positions. Learn how to do triage and major incident in 10 seconds and teach other people to do it. Use video laryngoscopy to teach and learn the skill in the emergency department and ICU. ECMO? Maybe. Be careful with your fentanyl dosing in RSI. In stroke, consider a strategy of thrombolysis, then moving to thrombectomy. And please, don't get old. I thank you so much for your time. It's been wonderful to be here. I do hope I can come and join you again in the future in the wonderful city of Jeddah and meet some old friends and make some new ones. Thank you for your time.
So I think that was a very enriching evidence-based medicine in our specialty. I'm sure everyone sitting here is probably going to look first on the last topic he mentioned, right? Maybe some people are already Googling where's the full article. So having said that, we're going to move to our next session, which is, I have the pleasure to invite one of our great colleagues, Dr. Anas Murad. Dr. Anas is an emergency medicine consultant and residency training program director at King Abdullah Medical City, Makkah. He has many years of experience in disaster management and medical education. So we'd like to welcome Dr. Anas to please tell us about some myths in the use of antibiotics. Thank you.
So thank you, Dr. Aftab, for the introduction. Yes. So mythbusters in antibiotic. So I used to present this talk last month. Then unfortunately I didn't recognize that it is an area that we need to focus in. Especially in the last 10 years, this area become an interest for to direct and to limit the abuse of utilization of antibiotic in the emergency department. So, antimicrobial agents are among the most common frequently prescribed medications in the emergency department. And among physicians who don't recognize the harmful administration of antibiotic, they are more likely to prescribe antibiotic than the emergency physician who think it is harmful. So 20% of hospitalized patients receiving at least 24 hours of antibiotic therapy developed an antibiotic-associated adverse event, and 20% of them, they found they don't need an antibiotic from the beginning. So some of the stuff are logic, but it is good for junior residents. Some of stuff, it was new for me. So this is a case. So it is about 55 female. She is a typical patient from where I work, from King Abdullah Medical City, a cardiac center. So she is a diabetic, hypertensive, ischemic heart disease. So the summary that this patient has a pneumonia, and the physician decided to discharge the patient on levofloxacin. So the pharmacy call you back that leave is not available. So the junior resident suggests, so it is a fluoroquinolone. Can we use the Cipro? So it is common to use classes to imply for a specific coverage for that class in the emergency department. For example, aminoglycoside is good for gram-negative, beta-lactam for gram-positive. So can we use fluoroquinolone interchangeable? So these are the three antibiotics commonly prescribed in the clinical practice of the fluoroquinolones, Cipro, Levo, and Moxi. So they are not look like brothers. And if they are brothers, they look like as they are brothers from different parents. So severe differences among coverage. So if you want to see this, the Cipro, so Cipro does not have a coverage of gram-negative. So this is the reason that we don't use the Cipro as a monotherapy for management of pneumonia, because the strep is missed. Anaerobes is not covered by Cipro, although it was covered partially by Levo, little bit better by Moxi. Pseudomonas is not covered by Moxi. Difficult to memorize it. Please, if you want to prescribe fluoroquinolones, go back and check for the coverage of the intended fluoroquinolone before you discharge a patient on fluoroquinolones. Moxifloxacin, because we see a lot of patients, we discharge them with Levo and Cipro, but we don't use Moxi, because Moxi does not have a good concentration in the urine, and it does not cover a lot of gram-negatives that is common with the UTIs. Okay, so second case. So this is also another KMC, King Abdullah Medical City patient with multiple comorbidities, and the most important is the ischemic heart disease. A patient has a picture of UTI. You want to discharge the patient in Cipro. Again, the attending consultant said no. Cipro is dangerous. Use Bactrim. So is Bactrim safe? Yes, safer, and it is the first line antibiotic. But it, as an antibiotic, it has, or another any medication, it has an adverse effect. So Bactrim, especially the trimethoprim, because the Bactrim is trimethoprim and sulfamethoxazole. So the trimethoprim with spironolactone, which is a common medication with the cardiac patient, has a risk of hyperkalemia and sudden cardiac death. There is also 12-fold increase in the risk of hospital admission with hyperkalemia in elderly patients who are taking spironolactone with the Bactrim. If you compare it with the patients who are receiving amoxicillin with the spironolactone, 7-fold increased risk of hospital admission for hyperkalemia in patients who are taking ACE inhibitor or ARBs with the Bactrim if you compare it to the patient who discharged with the amoxicillin and ARBs, amoxicillin with the antihypertensive and cardiac medication. Another consideration for Bactrim, the frequency of hypoglycemia is more if you discharge a patient with Bactrim and sulfonylurea. Believe it or not, the behavior of supratherapeutic INR with Bactrim is worse than the Cipro. If you give it to the patient who is receiving a warfarin, the behavior of supratherapeutic INR with the Bactrim is worse than the Cipro. Okay? Again, Bactrim is the first line treatment of patient with UTI in the emergency department, but please, so what can we take from this case? Please educate the patient, ensure close follow-up, communicate with the patient that the potential side effect, ensure that the patient has an access to come back to the emergency department, okay? So this case is a 55-year-old male, medically free. He has a controlled hypertension. So he has a picture of cellulitis. WBC was 12. Discharge diagnosis was a cellulitis. You discharge the patient on an antibiotic for 10 days. So again, this is one of the messages from this lecture is to introduce the emergency physician among the huge changes, even in the Ministry of Health, toward minimizing and optimizing utilization of antibiotic, and in the emergency department, especially because we are using an empirical coverage to the stewardship, antimicrobial stewardship program, and how to utilize antibiogram. We will come to that. But one of the things to minimize the utilization of inappropriate antibiotic is the duration, okay? So this is the myth. It started maybe almost 100 years. And I think most of us heard about that side effects of antibiotics since childhood, that infection relapse is associated with shorter duration of antibiotic. Antibiotic resistance can be prevented by treating beyond the symptom resolutions, and longer antibiotic course are more effective, okay? So, no studies support continuing antibiotic past resolution. Signs and symptoms of infection reduce the emergencies of antibiotic resistance. And the studies showed that shorter course of therapy has resulted in less emergencies of resistance and, for sure, less complication. So this is some of the common acute infections in the emergency department. We can utilize shorter duration of antibiotic, including cellulitis, instead of 7 and 10 days, to use 5 or 6 days. Acute otitis media, community-acquired pneumonia, 3 to 5 days. Cystitis, depending on the antibiotic, but ranging from 1 to 5 days. Complicated cystitis, not to 10 days, and 7 days. And it is a common say that in antibiotic duration, 7 is the new 10, and 5 is the new 7, and 3 is the new 5, okay? So shorter duration is good in terms of less resistance, less adverse event, and non-inferior in terms of the efficacy, okay? So shorter is better. Okay, so this lady, this child, he has Rocky Mountain spotted fever and Lyme disease. I'm not going to discuss this uncommon infection, but what is the antibiotic of choice in pediatric? Even in rosin, we know that doxycycline is contraindicated in pediatric. And if you had a student or resident and you read the infectious disease in rosin, in Rocky Mountain, you can read that doxycycline is a first line management for all age groups, including pregnant and pediatric. And if you go to Lyme disease, I think the one who wrote the chapter, that he missed that new evidence that is stated clearly by the American Academy of Pediatrics, collective data from the highly impacted area with the Lyme and Rocky Mountain, and they found that the myth about enamel hypothesis in the teeth and dental staining is not an issue for doxy, and the doxycycline is recommended to be the first line management. Okay. So this is another case about 35-year-old female, medically free, diagnosed with community-acquired pneumonia and discharged on levofloxacin, presented to the emergency department again with the same complaint, no deterioration in the clinical condition. And because she came back, the physician was thinking that he might admit the patient with an IV levofloxacin. So oral versus an IV. So why should we concern about oral versus IV? IV is associated with a lot of complication, and one of the most devastating complication of an IV antibiotic is the development of the C. diff. Even one IV dose of an antibiotic is increasing the risk of the C. diff. Okay, and one day administration of an IV antibiotic increasing the risk of the C. diff infection by 9%. Okay. So oral antibiotic has many advantages: less hospital stay, early discharge, less side effect, low cost and workload, less IV-related infections. So one of the things that we have to think is the oral bioavailability. Oral bioavailability, to make it easy for you, for example, if we see here the oral bioavailability 90%, that means 90% of the orally administered antibiotic reach to the bloodstream. So it is similar to the IV in terms of the efficacy, okay? So many of the emergency department prescribed antibiotic has a good bioavailability. Levofloxacin, clindamycin, fluoroquinolones, doxycyclines, all these medications has a good bioavailability, and just admitting the patient to the hospital and switching from oral to an IV antibiotic with good oral bioavailability is not a good choice. Unless you are going to admit the patient for another reason, IV antibiotic, resuscitation, patient is septic, patient looks sick, this is another story. But if you are going to admit a patient, we defer of admitting patient just because of an IV antibiotic that has a good oral bioavailability. And even there is an ongoing study that showing that oral antibiotic, even with highly resistant and difficultly accessed infections like osteomyelitis, showed that oral antibiotic alone can provide a good outcome. Okay. So this is a 42-year-old male. He is medically free, borderline septic shock. He has a penicillin allergy. So this is a common myth in the emergency department, because just labeling patient as a penicillin, we cannot give tazocine and ceftriaxone, which is almost more than 90% of the prescribed antibiotic for the critically ill patients, making us going to more advanced and escalation of antibiotic to monobacter. So let's talk about penicillin allergy. Penicillin allergy is almost 90% of the patient who has labeled as penicillin allergy, they actually does not have an allergy. And the true rate of allergy, even in the last study in 2020, showed that it is almost less than 10%, almost ranging from 1 to 6%. And this because of mislabeling, and sometimes because the allergy had gone or lost after years of avoiding that penicillin. And most of the allergy is related to the IV administration rather than oral administration. So penicillin allergy is not that issue, and we have to implement in our electronic medical record delabeling of the ability of delabeling penicillin allergies from the system if we found that this patient is not allergic to penicillin. So what about cross-reactivity to cephalosporin? Because we don't prescribe penicillin, we prescribe cephalosporin. So again, it is common to know that it is 10%, and accumulative data in the last 10 years showed that it is all the cross-reactivity does not exceed the 3%. Okay, and especially because especially with critically ill patient, if we want to prescribe cephalosporin, we go to the ceftriaxone or the fourth generation cephalosporin. And the cross-reactivity among ceftriaxone with the penicillin is almost less than 1%. Not only the penicillin and beta-lactam. The cross-reactivity is less than 1%. So it is comparable to the monobacter. Okay. So carbapenem has a cross-reactivity of less than 1%, so it is a preferred medication for patient labeled as penicillin allergy. But again, we mentioned that third and fourth generation cephalosporin, recent data showed that cross-reactivity is also less than 1%, so you can utilize third and fourth generation cephalosporin. By the way, one of the common first generation cephalosporin is called cefazolin. Cefazolin does not share the side chain of the penicillin, so also cefazolin does not have a cross-reactivity with the penicillin, and you can use cefazolin safely for patient who has penicillin allergy. So if you have a patient he labeled as penicillin allergy, this is really an issue. Patient might go for admission for a prolonged period, exposure to and risk for resistance. So please go to the patient. Ask about the symptoms in detail. What type of allergy? When he get exposed to the penicillin, use the graded, this is one of the issues, if you are really concerned, just use the graded challenges dose, just give the 10% over 1 hour, then continue the remaining dose after that. The skin and oral test, it is written frequently in the CDC and IDSA, but it is not applicable in the emergency. Okay, so if you just want something that to take it home and easy, not to bother yourself with these studies, so third and fourth generation are good for if you have a penicillin allergy. Cefazolin, we mentioned that it is good in the if you have a penicillin allergy. Just consider first and second generation if the patient has a real anaphylaxis. Okay, 7. So patient, and in case of non-Hodgkin lymphoma, fever, post-chemo, tachycardic, and he's in septic shock, you decide to give the patient a tazocine and vancomycin. Tazocine 4.5 gram and vancomycin 750. So suboptimal dose of vancomycin. So suboptimal because most of the time when we give the patient a vancomycin, we are giving vancomycin to really critically ill patients. So we don't want to put patient in risk for suboptimal dose, because suboptimal dose might impact the outcome of the patient. At the same time, suboptimal dose will affect the resistance to the medication. So use weight-based dosing for vancomycin. 20 milligram per kg for patient who has an indication for vancomycin, and you can exceed the dose to 30 to 35 milligram for patients who are critically ill. And call the ID if the dose, weight-based dose, is more than 3 grams. The first unloading dose of vancomycin is not associated with nephrotoxicity, and this is based on the accumulative data that when they compare, because some patients who required more than 3 grams, when they look up to them in terms of the nephrotoxicity, it wasn't an issue for the loading dose, okay? So this is a 55-year-old male. He is a known case of metastatic colon cancer, recent admission to the ICU, and febrile neutropenia, admitted to the ICU, and he came now to the hospital with fever. He is tachycardic, tazocine and vancomycin given an IV. So is that enough? Patients who are frequently coming to the hospital, they are liable to have multiple resistance, including those commonly prescribed medication. So empirical double coverage of an antibiotic is indicated or not. So it is not about, just talk about that, the double coverage is increasing the likelihood of coverage. This is the myth, and reduce the risk of resistance. But there is a risk of double coverage, more side effects, resistance, C. diff infection, as we mentioned from the beginning, and the drugs interaction. And this is what I would like to highlight in what we would like to highlight in this case. Just an introduction to antibiogram and the stewardship program. The antimicrobial stewardship is the aim is to get the maximum benefit of the antibiotic, and with the narrowest covering of the intended organism. Okay. Those patients has many problems with the antibiotic, and the resistance is high among them. And this is what we see in the textbook about the coverage of antibiotic. Definitely the coverage advantages start to shrink with frequent administration of antibiotic, especially with patients who are frequently receiving an antibiotic. So this is the new thing that we have to look at it, which is the antibiogram. It is a tailored and coverage of an antibiotic in a specific area. And this is a huge work of the infection control, IDs, and at the level of the Ministry of Health to have an antibiogram to a specific area. So when you want to cover a patient who has a possible infection empirically, you have to introduce yourself to the antibiogram. When you look at the data and read the textbook, for example, they mentioned that fluoroquinolones in this specific area in the United States is not has a high resistance area for fluoroquinolone. So in this area, fluoroquinolone is not the first choice of antibiotic in this area. So in the coming future, we are expecting to see this commonly. So better for us to have an idea about what is the antibiogram, to get used to use it for our patients, and also for our community as well. So the take home, antibiotic is not a harmless medication, and always review the spectrum of antibiotic before prescribing an antibiotic to your patient. Avoid IV antibiotic as much as possible. Shorter is better. Be familiar with the antibiogram. Thank you.
Thank you very much, Dr. Anas. I'm sure it was very, very beneficial for all of us. I think we have 2 minutes, so maybe we can take a couple of quick questions. Anyone would like to ask Dr. Anas any questions, please? I think there are no questions. So in case you have any question, we are all here around. You can ask at the end of the session as well. So thank you very much, Dr. Anas, again. Thank you. So let's move to our next session. It's a very important topic, trauma in pregnancy. And here I have the pleasure to invite Dr. Ibrahim Amrani. He's a very hardworking, team-oriented, and reliable emergency physician with very clear communication skills and sound clinical judgment. Dr. Ibrahim has great interests in disaster management, EMS, and medical education. So please welcome Dr. Ibrahim to teach us about trauma in pregnancy.
Assalamu alaikum wa rahmatullah. I'm Ibrahim Al-Umari. I'm ER consultant at King Abdullah Medical City. Today we will talk about approach to trauma in pregnancy. So these are our objectives for the lecture. Some introduction with epidemiology, physiological changes during pregnancy that matters in trauma, fetal assessment and radiation risk, specific treatment and last challenges. So trauma occurs in approximately 5% of all pregnancies, and MVA is the most common cause of trauma. After MVA, we have falls, assault, and it's coming after MVA. Orthopedic injury like fracture, dislocation, and strain, most common type of injury during pregnancy. So those are the hemodynamical changes that matter during pregnancy in case of trauma. We have the heart rate, cardiac output, blood volume, all of them will increase with each trimester. But regarding the systolic blood pressure, initially, it will decrease in the first and second trimester. And in the third trimester, it will come back to normal levels. As any trauma case, we'll start our assessment with the primary survey. We'll conduct our primary survey starting with the airway. So the airway, by definition, it will be a difficult airway, and in some literature, they said it's more difficult, 10 times more difficult than non-pregnant lady. And this is secondary to the soft tissue edema and obesity. Surgical airway, if you decide to do it, it will be more difficult. And there is an increased risk of aspiration, secondary to increased intra-abdominal pressure, delayed gastric emptying, and loose esophageal sphincter. And if you decide to intubate the patient, it's recommended to do early decompression of the stomach. Regarding breathing, the oxygenation part, the functional residual capacity decreased during pregnancy. So the pregnant lady, she has a short apnea time, so they will rapidly desaturate. Ventilation, they have an increased tidal volume. That means hyperventilation with mild respiratory alkalosis is normal during pregnancy. We have a decreased thoracic compliance, secondary to breast enlargement and increased intra-abdominal pressure. And this will reflect you during the clinical job by difficult bagging. If you decide to put a chest drain, either chest tube or pigtail, we have to use one space above. So the recommended space will be the third and fourth intercostal space, as the diaphragm is higher to avoid intra-abdominal organ injuries. Circulation, the maternal blood expands about 45% during pregnancy, and the cardiac output will increase by 30 to 50%. So a pregnant lady, she can bleed 1.5 liters without any manifesting symptoms of shock. Supine hypotension syndrome or inferior vena cava compression syndrome, it decreases the cardiac output by 1/3. So, and usually it happens at 24 weeks of pregnancy and more. How can we avoid it? We can avoid it by placing a wedge under the backboard to tilt the bed 15 to 30 degrees to the left, or manually uterine displacement to the left. Fetal assessment. Fetal assessment usually comes in the secondary survey, and the viable fetus, we consider the fetus is viable since the pregnancy starts to 22 to 24 weeks, and CTG monitoring is recommended for minimum of 4 hours for all pregnant lady coming with trauma. Then we can move to ultrasound to assess the fetus and to assess the placenta. Fetal distress can occur even even if the mother has a stable, and if the mother is stable and she has only a minor trauma. So 4 hours of CTG monitoring can be extended to 24 hours if we have more than 3 uterine contractions per hour, if we have uterine tenderness, vaginal bleeding, or membrane rupture, and serious maternal injury. Most cases of placental abruption after maternal trauma are detected within the first 4 hours of monitoring. Rh negative mother should receive ROGAM or immunoglobulin in case of polytrauma. The recommended dose will be 50 microgram if the pregnancy is less than or equal 12 weeks, and if it is more than this, the recommended dose will be 300. But according to the latest ATLS guideline, the dose will be 300 for all stages, regardless of the gestational age. It should be given within 72 hours. BTK test should be done in ER, and it is only to determine the amount of feto-maternal hemorrhage. The result, it's not important in the ER, as we will give the first dose of ROGAM empirically. But we need it if the mother needs an extra dose or more doses of ROGAM. Radiology, fetal exposure to low-dose radiation defined as less than 5 rad or 50 milligray. It doesn't increase the risk of fetal or infant death, mental defect, or growth retardation. IV contrast is safe both in pregnancy and breastfeeding. So this is the estimation of fetal radiation from CTs. So we can see CT head, chest, abdomen, all of them less than 50, which is the safety margin. But when we do CT pelvis or CT angio of the aorta, we can reach that limit and exceed it. Tetanus vaccine, provide tetanus prophylaxis if indicated. Tetanus antibody crosses the placenta, so it will decrease the risk of neonatal tetanus. So all pregnant women should get the vaccine between 27 and 36 weeks of each pregnancy. This is according to the American College of Obstetricians and Gynecologists, with or without trauma, should be routinely given during each pregnancy. Tranexamic acid, we know that tranexamic acid reduces the bleeding and transfusion requirement during cesarean section, and it's one of the line of management of postpartum hemorrhage. CRASH-2 trial and MATTERS study, both of them mentioned that it has decreased mortality and mortality benefit. But during pregnancy trauma, there are no studies on the administration of tranexamic acid for massive hemorrhage from trauma in pregnancy. But generally, tranexamic acid categorized as category B, so it is safe. So it is, if it is indicated, we can give it safely. Intubation. In non-crashing patient, RSI is the best choice as any other airway management. The paralytic agent, we have SAX and rocronium, both of them the most common used in ED. But when you review the literature, they mentioned that rocronium, if you have Sigma-Dex, which is the antidote, is the preferred agent to be used. As we mentioned earlier, they have difficult airway with rapid desaturation. So you don't want to stick with paralyzed patient that you couldn't intubate. Induction agent, as any other medication, but we have MIDAS Also in the literatures, prefer to avoid it if delivery is expected soon because it's rapidly cross the placenta and it can cause neonatal hypoventilation and apnea in neonate. Post-intubation sedation, we have Brisidix, fentanyl, propofol, ketamine, and ketamine is the best choice as if the patient is hemodynamically unstable and it has both sedative and analgesic effect. Ventilator setting, there is no special ventilator setting is required, but it's reasonable to increase the tidal volume to have the normal respiratory alkalosis. Resuscitative hysterectomy or perimortem cesarean section. Even in the latest ATLS guideline, it should be done within 4 minutes of maternal cardiac arrest. But when you review the literature, now we have more cases that reported that fetal survival reported up to 30 minutes after cardiac arrest and maternal survival up to 15 minutes after cardiac arrest. If you have code OB in your institution, you should activate it before you have before doing this procedure. If you not have it, maybe it's wise to discuss with your chief or your head of department that you should have the code OB. It's simply that when you announce code OB, you will have a neonatologist with 2 nurses from NICU and 2 obstetricians with 2 RT that are expert in dealing with a neonate. ED vertical incision should be done. If it is less than 20 weeks, emergency hysterectomy is not indicated. 20 to 23, it's indicated for the resuscitation of the mother only. More than 23 weeks, your purpose will be changed to save the mother and fetus. The defibrillation, we have defibrillation that's safe to be done during pregnancy and has been done in all 3 trimesters, and it doesn't increase the risk of preterm labor or increase the risk of fetal injury. But it is advisable to monitor the fetal heart during maternal cardioversion. Seat belt, as we see in this picture, the correct placement of seat belt, we have to put the shoulder part above the abdomen, over the chest, and the lap belt below the abdomen, over the symphysis pubis. Discharge criteria, if decide to discharge the patient and the patient doesn't require the admission, we have the resolution of contraction, reassuring fetal heart tracing, intact membranes, and no vaginal bleeding and no uterine tenderness. Challenges, we have specific challenges here in Saudi Arabia that majority of MOHED, they don't have obstetric service. We have a special maternity hospital designated for obstetric or pregnant lady, but they don't have a trauma code or trauma service. So all trauma patients will be taken to trauma centers, and these trauma centers, they don't have obstetric service. So ED physicians who are working in general or trauma centers, they are not expert in dealing with pregnant ladies, and no trauma courses designed for pregnant women, and still we have fear of radiation exposure, both healthcare provider and patients. We have a huge distance from peripheral hospital, especially on the highway, to the nearest trauma center, so we need more air transportation. Take-home points, fetal survival is dependent on the maternal survivor. Therefore, resuscitation of the mother always takes priority. It's a difficult airway, so prepare yourself with 2 setup. Chest tube should be placed in the 3rd intercostal space or 4th. Avoid IVC compression syndrome by tilting the patient to the left or manually displace the uterus to the left side. CTG monitoring for viable fetus more than 22 weeks. All RH negative mothers should receive ROGAM within 72 hours of the trauma. Attempt to minimize the fetal exposure to radiation as much as possible. Do not withhold imaging that is necessary for the mother. Consider eclampsia as an etiology of seizure or altered mental status in pregnant lady coming with trauma. Administer appropriate medication to the mother without over concern about adverse effect on the fetus. Monitor the patient for preterm labor or abruption of the placenta after minor abdominal trauma, and please screen for domestic violence in pregnant patient presented with trauma. Any questions?
Thank you very much, Dr. Ibrahim. It was very great session. So we have time for questions. If anyone would like to ask Dr. Ibrahim any further on how to deal with pregnant women and trauma. If not, then please, I think there is a question. Yes, please.
Sorry, who was asking the question?
Assalamu alaikum. Thank you, Dr. Ibrahim, for a great lecture. Just ask about the CT with pregnant lady. It's preferred do with the contrast. Usually with the trauma, we need to see if there is any hemorrhage. There is any concern about the contrast or no?
Trust is safe during pregnancy, so if it is indicated, please go ahead and give it. It will not harm the fetus as per the evidence. But if you don't need it, why you do it? Why you endanger the baby or the mother? The contrast itself, it has side effect even for the mother, that it can cause kidney injury, it can cause interstitial nephritis. We have a lot of complication of contrast per se, but when dealing with pregnant lady, they don't have an extra caution or extra complication from contrast.
Thank you, Dr. Ibrahim. So, can I please ask Dr. Ibrahim to be on the stage? And on behalf of SASEM, would like to present a small token of appreciation. Sorry about that. Please request Dr. Anas to be with us on the stage for a group photo for this session. Thank you. Thank you very much again. Thank you. So by this talk, we conclude this session, and I believe we will meet at 12 o'clock again. Thank you.
في كراسي كثير في الناحية هذه، لو تجوا على الناحية ذي ممتاز. ايوه بالضبط. كم الساعة؟ طيب ان شاء الله 2 more minutes and we will start. بس نستنى الاخوان يدخلوا على القاعة. البرنامج حيكون فيه عندنا الان الكينوت سبيتش او البلينري سيشن بالدكتور جميل، وبعده اللانش بريك ان شاء الله. على اليسار هناك مليان كراسي، تعالوا على الناحية الثانية. نحن 12:05 ولا كم الساعة؟ كم الساعة؟ أي ممتاز خلاص. طيب بسم الله الرحمن الرحيم. It is my pleasure and my honor to announce our next speaker, Dr. Jamil Abu Al-Ainain. Dr. Jamil Abu Al-Ainain, he is a friend, a brother, and a mentor to me personally. Dr. Jamil, he is the General Supervisor of Emergency and Disaster at the Ministry of Health. He is the General Supervisor of the National Health Emergency Operations Center. He is also the President of the Saudi Society of Emergency Medicine. He is, after all of that, an emergency medicine consultant and an assistant professor at King Abdulaziz University.
Thank you, Ahmad. طيب. Good afternoon, everyone. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد أشرف الأنبياء والمرسلين. It's always nice to give the lecture before lunch, so people will be excited for an upcoming positive event. And I promise you my talk won't last more than 23 minutes, inshallah, and it will be fun. And please, let's make it interactive. I know and I can see at least 7 or 8 disaster experts in the room. So if you want to shout out or have a question, don't wait till the end of the session. Just raise your hand or interrupt me at any given time. So we will talk about Hajj preparedness from a disaster point of view and the role of the National Health Emergency Operations Center during Hajj. Hajj is very close to our heart, and we feel honored and we feel it's our duty to serve in Hajj. So I'm sure everyone in the room and every physician in the country feels honored when he participate and come to Hajj. And I'm sure all Muslim physicians around the globe would love to come and serve in Hajj, inshallah. So what we're going to talk about today, first I'm going to mention to you briefly so you understand the background and the context and how things work in Hajj, about the National Health Emergency Operations Center and how it's connected with the Regional Health Emergency Operations Center. Then we'll speak a little bit about risk assessment during Hajj, as well as the efforts in assessing hospitals in terms of preparedness and ready for dealing with any potential disaster that can happen. After that, I'm going to talk about something that I love and everyone knows in the room, simulation and training for Hajj. And we're going to end with how the National Health Emergency Operations Center supports the hospital and what kind of services we provide during Hajj. We'll start with a brief video just to tell you a bit about the National AOC.
يعتبر مشروع إنشاء مركز
الصوت only in the laptop.
يعتبر مشروع إنشاء مركز إدارة الأزمات والكوارث مشروعاً استراتيجياً لتعزيز العمليات المتعلقة بإدارة الأزمات والكوارث الصحية في المملكة العربية السعودية على المستوى الوطني والمحلي، وبالتالي رفع مستوى التنسيق بين الإدارات المعنية في الوزارة وشركاء الاستجابة وأصحاب المصلحة والجمهور. تم تصميم وإنشاء مركز إدارة الأزمات بناء على أحدث المعايير العالمية المتبعة الهندسية منها والوظيفية، وبالتالي تم تجهيزه بأحدث المعدات من شاشات عرض جدارية وأجهزة تواصل وإنشاء مركزي لبيانات تخدمها بنية تحتية تقنية صلبة. تم تطوير نظام ويب EOC لأتمتة عمليات إدارة الأحداث بناء على المفهوم العملياتي الموحد في الوزارة، حيث يعمل النظام على جلب ومعالجة وتحليل وعرض البيانات الخاصة بالحدث ويوفرها لمتخذي القرار لمساعدتهم على القيام بالإجراءات المطلوبة في الوقت المناسب، وبالتالي إعطاء المشغلين تعليمات دقيقة عن كيفية الاستجابة. ويستعرض النظام المعلومات ذات العلاقة المجمعة بشكل حي من المنشآت على منصات خاصة ضمن غرفة عمليات المركز، حيث يمكن الوصول إليها بأي وقت. وعبر تلك المعلومات التي يتم جمعها وتبادلها يتم توفير إطار عمل موحد ووعي لحظي لتطورات الحدث، لتصبح إدارة الأزمات والكوارث أكثر فعالية ودقة. يعتبر إطلاق مركز إدارة الأزمات والكوارث خطوة أساسية على طريق تحقيق مبتغى الوزارة في توفير الخدمات الأمثل التي تتوافق مع رؤية المملكة 2030، لأننا متأهبون لصحتك.
So I hope this gives you some background on how and what is the National Health AOC. So basically it's the emergency management unit at the Ministry of Health. We focus on mitigation, preparedness, response, and the resilience of the whole system. The National AOC is connected to the 20 health regions around the country through regional AOCs. So each region has an AOC. Jeddah has a regional AOC. Mecca has a regional AOC. At-Taif has a regional AOCs. In the health sector, we look at them as 20 centers. And we will talk a little bit about how do we communicate with them. So pardon me, the slide is in Arabic, but I'm going to explain it in English. So we start on the right side. Every hospital in the kingdom within Ministry of Health. Every laboratory center, every primary health care has an access to Ta'ahub, the web AOC. I'm going to talk about it later. So they connect to their regional AOC. So an instance for many regional AOCs at the cluster level. So how the system works, each group of hospitals represent one cluster. Sometimes the city would have more than a cluster. Riyadh has 4 clusters. Jeddah has 2 clusters. Mecca has 1 cluster. So the cluster represents the EOC, the Emergency Operations Center, for these hospitals. Then that regional AOC in the middle is connected to, the clusteral AOC is connected to the regional AOC, which is under the supervision of the General Directorate of the region. So Riyadh has hospitals, and they're divided into 3 clusters. Each cluster has its own AOC, and the 3 clusters talk to one AOC. It's called Riyadh Regional AOC. And that Riyadh Regional AOC is connected to the national AOC. Why we're doing all of this? In disaster, communication is key. Communication would decide how fast the information will pass, how accurate the information, and how would the response be. So to ensure that the whole chain gets notified, not activated, you activate as needed. So if the incident is contained within a hospital, only the emergency and disaster in the hospital will deal with it. However, the next level, the cluster level, should be standby. They won't be activated. If it exceeded that hospital capacity, then they will interfere. Let's say it exceeded the cluster's capacity, the region will take over. And the National Health Emergency Operations Center will be notified along the whole process. It's too late for us to know about the incident the next day. I should be notified the moment an electricity shut down or a small fire starts in a hospital. Doesn't mean I'm going to do anything. I'm just going to make sure and observe what's happening. This is important to know our role in Hajj. These are the stakeholders that we communicate with as well. Private sectors play a huge role with us. Also, the other governmental non-MOH hospitals, Defense, National Guard, the King Faisal Specialist Hospital, as well as the Saudi Red Crescent and other stakeholders with us. This tells you the progress and how the National Health AOC jumped over the last 7 or 8 years from paperwork to semi-digital to a full digital system to a center that's been recognized by the WHO. Then now we have around 22 centers around the kingdom, 2 in Riyadh, a main center and a backup center as well. And alhamdulillah, around 18 months ago, we've been recognized by the WHO as the first center in the Emru region that is recognized by WHO as a collaborating center in emergency management. So moving to Hajj specifically, it says, الأمير محمد بن سلمان قال واجب أي ملك للسعودية, it's the duty of any kings who rule Saudis, بل من واجب كل أبناء الشعب السعودي. Moreover, any citizen who lives in this country, خدمة هذين الحرمين الشريفين وخدمة زوارهما, to serve these 2 holy cities as well as serving whoever gonna visit to these cities. So it's a huge duty, and as I started with, everyone in this country, from the health sector or other sectors, feel honored when he serves in Hajj or Umrah. Moving forward to the risk assessment. How do we do the risk assessment in Hajj, specifically for hospitals? So again, we talk with each other, national, regional, and hospital. And we use the HVA, Hazards Vulnerability Analysis during Hajj. Basically, we look at the impact of any possible identified hazards plus the impact and probability. Then it gives us a matrix. Based on that matrix, we can identify the most things that we should be worried about, and it tells us if there are any gaps we need to address, and then we build our improvement plan and our readiness according to such assessment. And The good thing, these tools are all digital, are all in the Web AOC. Web AOC is the system that I showed you in the video. We call it ta'ahub. Ta'ahub meaning be ready. So it makes sense for us in Arabic. And every single hospital in Saudi nowadays have an access to that system. So they just fill in the gaps, then they develop their plan. This plan at the hospital level gets reviewed by the regional AOC. As well as during Hajj, we review it specifically, and we sit together to ensure that we're all on the same page, to make sure that they really identified the potential and possible risk during Hajj season. Then we can move to the next step for approving their plan. Then hospital emergency preparedness assessment. We use something called a HEPA tool, identified locally at the General Directorate at the National AOC. The HEPA tool is standardized assessment tool specifically designed for evaluating hospital emergency preparedness. Looks at infrastructures, look at resources, staffing, communication systems, response plan. Basically it says, do you have emergency plan? Are these plans approved? Are these plans reviewed? Are these plans really covering all the hazards that have been identified? And so on, it goes into details. And on the past, we used to look at quantity. Yes, they have a plan or no. Nowadays, we're moving forward. We really want to know the quality of these plans. We just don't want to copy-paste plans that just exist to get the score and say we're passed, because it's serious during Hajj. We're talking about 3 million people in very restricted area, and they're all in a specific time moving together. So we really have to take it in a serious way and make sure we are ready. And this also goes to the different assessment things we've mentioned. Talks about infrastructure, talks about method of communication, talks about are they conducting drills or no, and how frequent they do these drills. Then we move after that into the gaps. So we've identified potential risk that may carry high impact, as well as gaps that exist in the system. How do we cover this problem, or how do we address it? Through training, through drills, with all the different types, from tabletop exercises to full-scale simulation, to drills, to even computer simulation, to online session with them. And we focus to ensure that we are educating the whole chain, starting from the minister himself. The minister attends with us every Hajj, that Hajj training session, with all the deputies as well as the minister assistant. And we ensure that this also happens at the level of the region, Mecca, Jeddah, Al-Madinah, Al-Taif, the cities that takes care of Hajj, as well as the hospital level or the cluster level, or with the buses to the holy cities hospitals, as well as sending them back. It's a huge effort, and I really, from this stand, I thank and appreciate all the people who are behind the scene are working. I've seen familiar faces with the people who participated with us during Hajj. It also covers the medical transportation. For the people who are not familiar with the ambulance services in Saudi, it's basically from Medina to Mecca, with taking all the precautions necessary to ensure their safety, and they're okay to be transferred. And they had a full medical support during route. We have our DMAT team, we're on call with them, reviewed the case, and if anything happens during transportation, helicopters were available, as well as medical control and advisory were available for them. And I think many of you saw that car. So it just shows you that we have a 50-bed field hospital, mobile, can be mobilized and activated within, nowadays we can do it in less than 48 hours. Our team is well trained on it. And their training and expertise really were handy last year when we had to call our colleagues in the civil of defense, and we utilized around 300 beds through 6 of their field hospital as well. So Saudi DMAT, the Saudi Disaster Medical Assistant Team, what is it? And I guess we have people from the team who started. Now, I see the faces of the Saudi DMAT. Anyone in the room were part of the beginning of Saudi DMAT? Dr. Jalal, Al-Uwais, and Fahad, and Nofel? No one. Okay, so we have the current Saudi DMAT team. So it is basically a rapid response medical team, qualified, that act during crisis and disaster. The beauty of that team, it has to be mobile, has to have enough skills, equipment, communication tools to reach specific place, to address specific needs during a specific time for a short period of time, then they can be relieved. For it to be successful, it has to be able to cover the whole kingdom as well as international, if you want to say. So currently the team is located in Riyadh and few cities. We're looking forward to increase our team. We have a good database. We included all the people who worked on the 350 bed field hospital during Hajj. They're all in our database. And soon Dr. Adil Khoja and our team will release the link, and it's going to be completely digitalized website and also an application for anyone who wants to sign to be part of the Saudi DMAT team. So who can be part of the Saudi DMAT team? Physicians with any background, nurses with any background, technicians, paramedics, pharmacists, even admin people. It's basically a small health system. Can be as small as 6 or 7 people and can be as big as 200 people. So anyone with interest can sign up his name. They will receive specific training. It's going to be not hard training, and they will be listed in our database. They can be activated if they're available at the time that we need. Vision, to be pioneer model for emergency medical teams that can respond during disaster. Scope, as I mentioned already, and part of that scope is operation of the field hospitals and the ability to treat different medical problems with different subspecialty as available. Classifications, there are 3 or 4 types: type 1, type 2, type 3, and subspecialties. Sometimes they call it type 4. From their names, type 1 deals with lower acuity cases. Type 2, you increase the cases, you can do minor ORs. Type 3, no, you're like a full hospital with all the subspecialty on the field, can operate and can work. Currently, we applied already to the WHO classification. They are visiting us after tomorrow. And I think we qualify easily for type 2 classification. We said we'll apply for type 2, then within the next 6 to 12 months, we can move to type 3 because we're already proven, and they, during their Hajj visit, the WHO team saw the field hospitals. The guys, you're ready. You just need to fill some forms. We'll be the first approved and recognized WHO EMT team in the region. So we're looking forward to get such classification in the next few months. So with that, I show you some pictures of our Saudi DMAT team during this Hajj, their different functions. Sometimes they go and relieve any area that obstructed. If the Red Crescent needs help with a lot of influx of patients and they can't transport, they were huge relief for them this Hajj, and their participation and help with the field hospitals. And even this Hajj, they were on call and helped and supported every hospital in the holy cities في المشاعر المقدسة by being available for them. If any problem happen, they will just call one of the disaster expert and ask them, I have a situation, what's your recommendation? This is what I did. So they start with them from 1st of Al-Hajj until 15th of Al-Hajj. So it's like private tutoring to each hospital. We give them 1 or 2 experts in disaster to take them through the Hajj journey. And this is some pictures. This was the Minister Main National Health AOC during Hajj في مستشفى من الطوارئ. And this is some of the activities we had during Hajj. So many lessons learned. I'll just mention few. Collaboration and coordination were key. You can have the best disaster experts with you, but if not the whole system work together, none of the things that I mentioned would work. You need every single person to work with you, to see the value, to buy in, for you to be able to fill in the functions. Preparedness is essential, and I can't say enough. Prepared, prepare, prepare. Specialized expertise is invaluable. Really, I'm not an expert in disaster, but working with 12 people who are expert in disaster with different background, with different interests, really makes your life much easier. You feel comfortable, and you really feel that we are a rich country in talents. Flexibility and adaptability are crucial. You know, disaster will not choose your favorite time, favorite place. It will always come in your unexpected, unseen time and place. Continuous evaluation and improvement. So even the risk assessment that I showed you in the beginning is done before Hajj. It is continuous because things change. The risks and hazards change during Hajj. So many things happen, and not a single Hajj was like the Hajj prior to it. Every Hajj during Al-Hajj, from day 9 or 10, we start to see new possible disasters that might happen, and we need to have to be prepared for such disasters. And one more thing I learned during Hajj. I learned to ride the Spider motorcycle, and it was a fun ride. Thank you very much, and I hope you guys enjoy your lunch, and I'm more than happy to take any questions.
Thank you, Jamil. Do you guys have any questions? While we're preparing, I have a question for you.
Advanced cardiac life support, pediatric advanced life support. We think disaster basic life support is essential for everyone, and then we move from there. So having a venue for them like the Saudi DMAT team will address all this. This is a platform for everyone to apply, and nothing is mandatory. You can have your training, you can have your name listed, and if we need...
Question really. I feel privileged
Dr. Abdul Salam is one of our Saudi DMAT team.
I feel privileged and proud of working with this an expert team. Always we have area of improvement. So always this is a basic and disaster lesson learned from the previous year. So at the end of Hajj, we are sitting together, doing briefing, what we can do in the future. So here in SASM, I think the emergency physician, he is a unique leader. So he can participate in the disaster drills, education, and even leading the disaster. Thank you.
And the amount of knowledge that any emergency medicine physician needs is very, very, very little to be knowledgeable about disasters. Completely different than other subspecialty. We have the advantage. So anyone with any information about disaster, believe me, in 1 week you can really be in a good shape in disaster.
I would have asked when is my next promotion if you're a part of the team. Go ahead.
Really something amazing that have been evolved over the time to being the first disaster to be approved by the WHO was a dream. I think we are ready to lead. I think based on these efforts, I think disaster first aid courses is one of the things that I think the DMAT can adapt and lead. There is a big need among the community participation to inject the volunteer program, into this huge responsibility. Congratulations for the excellent work. I would love to be part of this
It's an honor,
marvelous
Dr. Khaled.
team. My question is simple. Most of people are looking at us for what we call the health policy generating bodies. We have experience in Hajj. I think transferring the experience into policies that can be implemented, within the GCC and also within is something that I think is important after those tons of years of experience. What do you feel?
Such activities. And when we see the president of SASM is working in Ministry of Health, they should take advantage of that, and we'll be more than happy to support any policies.
We'll take 2 more questions, and then we'll have to go to break. Dr. Abdul Hadi here. Okay. Go ahead.
Thank you, the Ministry of Health, National Guard,
Yes.
military hospital, but I don't see it.
Come to the surface during COVID out, says all other sectors have to send their data on daily basis to Nizam Ta'ahub. Specifically, the King mentioned Nizam Ta'ahub, so sector has an access to Ta'ahub and is required to input their data. If at the national, when I present my point of view in any possible disaster potentials, plus we ask you guys and the other sectors to have some proactivity towards, like King Faisal Hospital, specialist hospital came to us, we said, we are only integrated and we just send bed numbers. We need to do more. We said, well, more than welcome. Al-Jami'i for Riyadh, the University Hospital for Riyadh. He says, we need to move more. We can't go inside the other sectors without them opening us the door. We're required to get one piece of information, the bed numbers. To do more, I usually ask my regional directors or the regional AOC directors to be proactive and go and speak with the other leaders and the other hospitals. Believe me, they will open their doors. So I think it's a homework for both ends. We need to talk more, we need to sit more, because we have a lot of room to collaborate and to support, and we do have the manpower and the expertise to do so with you. But we need collaboration from.
One thing you missed in your presentation is that you, over the years, that when DMAT started until today, you were able to change people's mind, the way people think. Initially, when DMAT started, I can see, while working with the others, I can see how they react to the disaster. I'm going to say it in Arabic, وسامحونا على الكلام. في المشاعر are outside from there. They are good ambassadors back to their hospital. There is a plan to teach them, to make it mandatory course.
Yes, it is what I just mentioned, the basic disaster life support course, equal to the basic life support. Every physician who participates in Hajj at least should take that course. That will prep them, so when we come, the gap is closed. Our colleagues from the Saudi DMATs, usually when they go and do the teaching, the gap is huge. So they have to go down. So the time is not utilized in the best way. So at least they need to be prepped. As they give them the infection control course. No one can participate in Hajj without the PEXs, it's called, I can't remember the name of it, Hajj infection control course. So we should require basic life support, basic disaster life support course for them.
Last question from Basri.
So Jamil, assalamu alaikum. Thank you so much for this wonderful and amazing work. And it appears that it's progressing and it's growing, and hopefully, inshallah, in the future, we will see it mature, inshallah, bismillah. Now, what was, if you can specify, what was the single biggest challenge you're facing in terms of developing this model? And at the same time, how are you trying to orchestrate and organize the different sectors collaborating together and communicating together? Because I think this is one of the areas that can help progress the project.
Sure.
Thank you.
So part of the answer is what Fahad just mentioned. he believes that the culture started to change. And no culture would change if you don't have a buy-in and support of the leadership. So the minister, when the minister attend a 4-hour workshops for me, what would the others do? Year after year. So this sends a message for everyone. So the leadership are very supportive when it comes to disaster. They see the importance of disaster, and they see when people are trained and they have a lot of drills, they will respond way better. And this Hajj, the minister, when he visited the hospitals, he asked specifically about, you guys, they killed you with drills. They said yes, but he said like it's very important. So that's why we have such a culture. The single challenge, I believe, was the coordination. So to coordinate all the multi-sectorial stakeholders takes a lot of effort and needs a good communicator. So I spend a lot of time do so. However, I don't want it to be based on a person. So when I leave, the system already exists. That's why we're growing our Saudi DMAT team, and we assign such tasks for them, and they will go and speak on behalf of the team. So we really handpick the leaders on the team. So they're all good communicators. They can talk and sit in any venue with any sector, even if it's in non-health sectors. I didn't have enough time to show other pictures with the civil defense, with the Ministry of Education, with the Ministry of Transportation. They would know what's our mission, what's our value, and what's our objectives.
Thank you so much, Jamil. This is a small token from your society to you. No, واحد ثاني.
طيب. يديك العافية. شكرا. And sorry for keeping you guys from lunch. أيمن. مشكلة تعالى. لعيب. خلاص شكرا.
Thank you guys. See you after lunch.
راحوا الغداء. في أحد من الديمات بندر عمر يبغى صورة كده مع دكتور خالد.
Ladies and gentlemen, welcome to the afternoon session today. It's my honor to be your moderator on this session, and my honor to introduce the first speaker, Dr. Saad Al-Asiri. Dr. Saad is a consultant of emergency medicine and consultant of trauma. He's corporate medical director of emergency medicine department and Gulf regions at Sulaiman Al-Habib Medical Group. His Arab and Saudis and Jordanian board certifies. He's holding master's degree in medical education as well as the health administrations. Dr. Saad has been member for different committees as a national levels and international. His interest in health administration to improve the healthcare in Saudi Arabia. He will giving the interesting topic today to us, and welcome Dr. Saad.
Thank you so much. Assalamu alaikum. As a start, I would like to welcome all of you in afternoon session, and at the same time, happy National Day. وكمان حابب أشكر الزملاء في الساسم على هالتنظيم الرائع للمؤتمر، اللجنة العلمية، اللجنة المنظمة، أخوي الدكتور جميل وكافة فريق العمل معه. دائما سعيدين أن نتقابل في هالإيفنت. أشكر اللجنة العلمية على هالتوبيك اللي أنا ما أعرف بصراحة وش راح نتكلم فيه اليوم. هل نسوي سحب على سيارة؟ هل نسوي سحب على فيلا؟ يمكن طارق راح يساعدنا شوي كمان في عملية السحب. It is very interesting topic. I'm happy we are actually in SESM. We're going for such topics about business and how to conduct business plus the medical perspective all together. This is actually the trend, and this is what's supposed to be. We started this from last session, and we are actually in this session, we are opening this topic, and hopefully we're going to expand in this because this is what's going on in the markets in the real life. Now, how we're going to speak about emergency medicine and business, this is what we're going to talk about. So making money for the department, not for you, but hopefully we're going to learn something how to make the departments rich. So at the end, we're going to be rich at the end. But if we take it actually by numbers, let's go over these numbers, and I'm going to tell you why I'm putting here. The number of population is increasing to almost 37 million. And also, of course, the beds for 10,000 is actually variable between 22 for the governmental sector to 5.2 for the private. Number of the hospitals, almost 500 in the governmental and 159 in the private sector. When you go to the total beds across the country, which is actually, we are almost like 30 plus in the private compared to the governmental, and the emergency department and the Ministry of Health across the country above 5,000. And when we go to the emergency visits, it is almost between the emergency and private and the Ministry of Health, it is almost close to each other. This is indicating what? This is indicating there is a big demand. There is a big business there. There is a big opportunity there because number of visits high compared to ratio for the beds inside the hospital or beds inside the emergency departments. And this is actually big indication for the big demand of the service. Now, in any kind of healthcare sector business, there is actually insurance companies. And insurance companies, if we look actually on the left side of the screen, which is actually on your right side, which is actually the trend for the insurance company. And it is going toward big improvement, big expansion, which is until 2030. And that indicates there's expansion in this kind of business and emergency because it is expansion in the healthcare sector. Now, who gonna to pay for the hospitals, which is the insurance company? And this is actually big increment. There is booming, which is expected. And in this actually analysis, there are actually two types, which is actually conservative and also the optimistic scenario. If we look at the ages, we know that the majority of the age, which is actually the middle age in the country, not the geriatric, but still the number of the geriatric is increasing. That means the demand for the healthcare sector is increasing, including the emergency, which is our side. So this is another factor indicating that demand is increasing. Now, how to think from business perspective? This is actually a guideline for you. If you think to lead an emergency in a private sector, you need to think about these things. You have to know what kind of vision, mission, and scope of service in that emergency department correlated to the institute which is you are working at, and what kind of community you are working at. So in such a way, you know your direction. Now, after that, you know your limitation and threats, internally, externally, because this is going to be a threat for your work, for your performance. And accordingly, you cannot actually grow up in that business. So this is internal and external analysis. You need to know about it in details before you start. Now, strength and weakness, it is important because you need to work on your strength. This is going to boom your business according to that strength. That weakness, you need to have another action plan, how to improve it. Weakness financially, resources, weakness in the manpower. You have to define it before you start. About the opportunities, what is the meaning of opportunities? If you are working in a place, in a city, and that city in a shortage of one of the services, an emergency, that is your opportunity there. But is that matching your strength? Is that matching your limit, or there is a limitation for it? This is why we put actually the limitations, the threat, before you start to go for that opportunity. And that's actually consequences. And after that, you need to know your resources. If you have the resources and you have that strength, and you know that opportunity, which direction you go for, you can actually proceed for it. And from there, you're going to boom in your business. And of course, from the first two slides, it is very clear for us there is a big demand in the market in our country. So first of all, you need to start by choosing your team. Choosing your team, it is not about only the skills in emergency and the knowledge. It is also they believe in that kind of business. They believe in that vision. They believe in you as a leader, so they can push that. Because it is challenging, especially when you are talking about private sector, when you start any kind of business, especially in emergency. We know that our department's working with everybody, interacting with everybody. It is 24/7, a lot of challenges. So your team, you need to be changed that concept, and you have to choose them very well. So in such a way, they're going to push with you, because there are many challenges. We're going to see it in the coming slides. Financial planning. Mandatory from the beginning. You have to have many shoulder-to-shoulder meetings with the finance team to know actually what kind of budget, what kind of limitations for you and the resources, and where are the threats, and when you need actually to put the limits in your business. And that frequent meetings with the finance, it is very important, especially in the beginning of any kind of project or any kind of establishment of emergency medicine in the private. They're gonna to put you in the right direction. So your finance, one of the important team to start to meet with them in the beginning, not lately. Or don't wait, actually, they send you a report. You start to proactive. You sit with them. Let them know what is the meaning of CTAS. Let them know what is the meaning of the work in emergency. Trust me, that's going to change a lot of concepts. So it is very important to align with the finance department, because they are a very important pillar in the equation. Number one, you need to think about streamline and how we're going to think about the streamline in the medical operation. Streamline to make actually the journey of the patient smooth. We know that. But we need to think when we're going to think about that streamline. The journey of the patient, starting when? I'm asking, what do you think the first point for the journey for the patient to the emergency, starting from where? What do you think? Okay. From the barking, thank you. So from the beginning, you need to think about the access to the hospital, the parking, how's the patient going to come in, what is the process of the triage, escorting the patient until to be seen by the physicians, and you continue the whole process. So streamlined, it is very important to have the full analysis for the patient flow, the full analysis for every single piece of the process, and that leads us to the lean principles. You need to have that thinking yourself and your managerial team working with you to think in that concept. If you think about that and you take it from that perspective to smooth and to make actually that patient journey very easy, you're going to achieve actually better improvement. And this very clear study is showing actually the effect of the lean going to improve actually the bed capacity, the turnover, and also the waiting time, which is actually very important in any emergency department, not only from private sector, not only from the from business perspective. Put yourselves in the shoes of the patient. When I'm going to the emergency department, what I need as a patient, I don't want to have waiting time. I need to have easy access to the hospital, to the parking. I need someone actually to guide me to go. This is my first time. I'm coming in panic, high anxiety. So if that streamline, if that patient journey going smoothly, this is first hit. This is the very important part actually you achieved from the beginning. This is one of the study which is related to that principle when you are putting actually the lean principle part of the discussion and part of the operation in daily basis. Just 1 hour, if you reduce it, so that means you're going to improve actually the financial perspective between 9,000 to 13,000 US dollars, which is actually because you're going to prevent lift without being seen, and at the same time, actually the divergence of the ambulance. This is one simple thing, just I put it as an evidence. When you think about the analysis for the process, from the parking until the patient is leaving the department, including your connectivity with the lab, with the radiology, with the inpatient, that approach gonna to actually give you big improvement from financial perspective because the patient, they are happy. The other thing, which is the patient experience. I said the patient happy because actually patient, when they feel you are taking care of about these small process and you're going to make it actually fast, you're going to make a big difference. And word of mouth, this is the best marketing tool because the patient going to speak to you, to speak about you in the community, and that's going to be very positive on you. And this is one of the important tools in any marketing or any private sector, which is actually the patient opinion, because it makes a big difference. Communication is the key. Communication with the patient inside the department, communication with the patient, what is the process, communication with the patient after leaving the department. Keep that communication with the patient, you're going to see actually the patient satisfaction sky high. And that correlated with any business growth, especially in emergency, because it is very difficult to satisfy everybody in emergency. And we know that better than anyone else. Of course, patient-centered approach, which is actually connected to any healthcare institute, any department. But in emergency, it is mandatory because the patient actually going in the middle between emergency, between different actually departments. So we need to put that patient in the center, and we need to take that actually as a message from leaders to everybody in the department. You need to put it actually in the mind of every single staff working in your department. That patient, all of us, our responsibility. Not only physicians, nurses, paramedics, admin, housekeeping, technician, everybody working in that department, they are actually around the patient, and we need to keep that patient in the center. And this is actually well known for us, but we need to give it more focus. For example, if we are talking about physical comfort, the patient needs to be comfortable in the bed. So what's the quality of the bed? What about the lights? What about actually the air conditioning? So this is one example, which is we need to go to the minor details to make actually that patient more comfortable, including the privacy, including actually the good communication by the emotional support from the team. These things, which is when we're going to put the patient in the center and everybody around the patient dealing with that comprehensive approach, that's going to improve actually the patient satisfaction. That is the mouth of the word going to spread, and that's going to attract for you, which is I call it actually more clients, and I call them guests. They are not only patients. So we need to build that relationship with that approach. Optimizing coding and billing. This is one of the most challenging things in any private, which is actually who worked in the private. We know actually what is the difficulty and the challenges in this. So it is, you need actually good training for the physicians, for the nurses, the good communication between them and the admin staff working on this. And this is actually very key part in any kind of business, an emergency or non-emergency inside the healthcare sector, because this is our relationship. This is the language between the hospitals and also the insurance companies. So if that actually is not going well, trust me, you're going to have a big issue and big hit in your business. It will not grow. And you're going to have actually a lot of money is leaking and a big loss. Now, how are you going to improve it? The best thing, which is actually the training for your staff and the good communication between you and the insurance company. And of course, you need actually someone in the middle from your actually hospital, like a business office, they're going to handle it. But this is actually very crucial. You need to keep an eye on it as a leader. If we go for insurance verification, which is you need to clarify which insurance level you're going to cover in your hospital and how you're going to deal with, for example, cases outside that level of insurance. This is very, very crucial because, again, this is connected to the previous slide, and this is your link with the insurance company. And when I mentioned in the beginning, the number of the insurance companies is expanding, becoming bigger, and they are actually becoming bigger even in the data and the connectivity from electronic perspective. So it is very important to make big pressure and emphasis for your staff about the billing, the coding, and of course there is dedicated staff for it, not the medical part. But you need to have that harmony between them. And at the same time, they need to know what kind of insurance covered in their hospital. Now, we know that sometimes challenges with other subspecialties to admit cases, to deal with cases regarding the follow-up. But when you have that strength and that relationship, this is actually strength for your department. How that's going to improve your business, because the patient, they're going to see and they're going to feel that continuity of patient care. If that patient end up in your department, excellent management, excellent approach, they are happy about the communication, but there is actually a big delay to admit the patient, and there is miscommunication to follow up the patient as outpatient. Still, they are going to blame part of it for the emergency. So this is very important thing to close the loop in the cycle, which is actually with the subspecialties as admission, to make it actually very smooth and very easy, and to give the privilege more to the emergency consultant to admit the patient or the physicians, and try to prevent that bottlenecks, the resistance to admit cases when it is needed by medical indication. So make it actually very smooth. That's going to reflect actually big time in your business. Also related to the outside services, which is the OBD. It needs actually to be connected well to close that loop of patient care and to have that continuity of patient care. This is very crucial and very important regarding the patient satisfaction, and they're going to feel that safety. This is an important topic and very sensitive because you need to have that balance. And this is the difficult part of the equation. How are you going to keep that business in emergency with high quality, high safety? From the other hand, you're going to think about cutting the cost. This is why from the beginning, from the start, I told you, you need to have that alignment with the finance department. They're going to help you. They're going to guide you. You are not working alone. Now, cutting the cost, but in one condition. I'm always saying that we are actually the one who's taking the lead in emergency. Don't allow patient safety and quality to drop because of this topic, but you need to have that balance. Now, how you think about it in a smart way, this is actually based on how to keep that efficiency in the department, which is the main key here, and at the same time, to think about optimizing actually the staffing. Optimizing, that means you need to look at, during 24-hour, what is the patient flow inside the department? There are times you don't need all the manpower, 100% operational. You need distributed during the days, during the weeks. We know actually the peak times. So how you're going to control actually the payroll expenses. Also look at different actual expenses management. including the utility, including the maintenance. As a leader, when you are requesting actually any equipment, please double check about, this is one of the things you need to think about it. If you are working in a business and working in private, what kind of maintenance, how gonna that to keep that continuity inside your department? So in such a way, you're gonna to avoid actually the frequent malfunctions and big loss of money, and this is very high cost. So again, this topic is important key, how you control the cost for the staff, for the equipment, for the maintenance, for the utility, and at the same time to keep the high quality and the safety from medical perspective, which is our actually rule. So that means you need to have that excellent connection with other departments, finance, clinical engineering, IT, etc. So in such a way, they're going to help you to build that, cutting the cost. So your staff is the key. Take care of them. And you have to have that close communication with them. And at the same time, you are actually the representative for them with the higher management. You are actually the one who's responsible to, you will be the voice for them, their demands, their issues, their complaints. And at the same time, what is bothering them from good work environment. It is your responsibility. We know that. But when you are working in the private, it is very important because when they are happy, your patient is going to be happy. And accordingly, the cycle will continue. And at the same time, make sure about the staff retention. Let's go to any HR department and ask them, do you have staff retention program? I found the majority, they don't. And it is very important part because staff retention, it is big concept, not only when they don't want to renew the contract or they decide to resign, it is about how to keep them going smoothly in the work environment, and they are overriding the challenge, how they are supporting the staff. This is very important topic if you want actually your business to grow up. So that means you are taking care of your staff. Of course, this is our major benchmark in any kind of business. But I put before this slide your staff to be happy. So in such a way, your patient gonna to be happy. If your staff, they are not happy, trust me, your patient will not be happy. So everything will continue in the wrong direction after that. Now, you need to have actually for this, dedicated staff, excellent in communication with the patient, and better to have background from medical perspective. So when they hear actually the issues, they know how to filter it, to categorize it, and they submit it to you as a leader. So in such a way, they're gonna to be your eyes, your ears, to direct you as a management, where are the problems? So in such a way, we're gonna to improve it. And this is need to be actually, you know, to categorize it to sometimes red flags. Red flag, you need to act on it in the same day. Because I'm telling you from the real experience, patient from the other side, if they felt like 1 day or 2 days left and nobody called them, they take it, you ignore them. You ignore their problems. Trust me, they're gonna that trust bond between you and them gonna to be lost. And this is gonna to affect you. One single patient unhappy, that's gonna to spread to 9 to 10 patients outside in the community, and it will affect you badly. So this is very critical part, and you need to choose the people working on this task. Marketing, do we need it? Yes, it is very important. But I indicate here the online marketing. If we go to the majority of our population, they are actually in the middle to young age, and they are actually online all the time. So the online marketing, it is the key, and it is the best. And that actually connected to community engagement. It is not about sending marketing and messaging and about offers, etc. No, it is about sending the right message. It is actually also engaging with the patients and the community and the families physically inside the community by attending with them, for example, the International Day about breast cancer, which is actually in October. So you're gonna to work on it and you're gonna to engage with them. You give them the feeling, I'm taking care of you. And at the same time, trust me, they're gonna to have that trust from the other side to you. And the same time, which is the orientation, sending the orientation messages from medical perspective. So engagement plus the online marketing, it is very important tool. You need to think about it and to keep it in your mind. This is the responsibility of everyone, which is to keep the quality high, to keep it actually continuous, and the project of the quality to be actually shoulder to shoulder between the leader of the emergency and the quality department. But you take the lead and ask the quality department to go in the direction which you need, not the opposite way. This is actually important key to improve the quality and the safety in your department. And they're gonna to help you in such a way you're gonna to keep the balance between the quality and the safety and good patient care, and also cutting the cost from the other side when the finance start to hammer you. So you need to keep the balance between both teams, quality and the medical, and the finance team. And this is based on this continuous improvement in the relationship with the quality department. Of course, you need actually to hear the feedback from your staff. It is very important because they're gonna to guide you where are the defects, need actually quality improvement, and this is gonna to make a big difference in the work inside the department. There is no good, excellent emergency department without big investment in technology. And I know it is very expensive, it's worth it, because it will guarantee for you the proper data. It will guarantee for you actually good relationship between your department and other departments, and also very smooth patient flow inside the department with top-notch technology. So this is very mandatory, but it depends on what kind of resources you need to match the type of cases and the quality of cases coming to your department. So this is also a very important part to match it with cutting the cost, because really it is very expensive when you to ask for something you are not utilizing, and that's going to reflect bad on you. Take home messages, which is I think you need to define what exactly you want from that business, what exactly your direction, and that this is number one step you need to do it. And at the same time, you need to have full knowledge about the strength inside your department and the institute, and to work on that strength and to look for that opportunities accordingly. Lean Six Sigma, I believe this is actually very important and magical tool. You have to implement it in the daily operation with dedicated team for it. Gonna to actually cut the cost, improve the work with the same resources. Of course, the quality improvement, it is actually non-stop operation and process, and it needs to be all the day, all the times, and from all the staff. Patient-centered care approach, actually this is the key in any healthcare institute. Of course, when it is about private and business, it is actually very crucial and very important. And technology, of course, it is actually needed in any business, and it needs to be top-notch and gonna to make you distinguish from the others. Thank you so much.
Thank you, Dr. Saad, for this amazing topic and speech. So the floor now open for the questions. I think a lot of questions will be coming. Okay.
شكرا سعد. very interesting talk. صراحة يعني الشيء الكويس اني شايف تقريبا 50% من زيارات الطوارئ رايحة البرايفت. with all this insurance this is يعني a good investment plan for us إن شاء الله. لكن أنا سؤالي عن population. Now with all cultural change in the country and the number of population, are you concerned that the middle sector, the young, when they grow up, this large number, and they become older and they get more disease, will this affect the income and the profit of the whole health system?
Thank you, Dr. Mohammed. It is an excellent question. Maybe I will agree with you, yes, but if you look at the same time, currently a lot of big campaign actually about the lifestyle and how to improve the lifestyle and how to encourage the sport. healthy food, etc., etc., to prevent, which is actually the geriatric cases, a lot of diseases, etc., in the future, because it is very clear in the chart. We have actually the middle age, which is the majority. They're going to move forward to actually geriatric, which is actually very expected to have actually more need and demand for the healthcare sector in general and emergency particularly. So it could be both sides, but I think still, even with the lifestyle change, with this big campaign, the demand for emergency is increasing. We see it now. And we are expecting that to come in the coming 5 to 10 years will be more in all the levels, which is the EMS, including the emergency departments, all different departments or sectors under emergency department, adult, pediatric, OB/GYN, etc. So yes, I'm in favor. The demand is increasing and expected forecasting to be increased, because if you look from the other side, the number of insurance company is increasing, and the plan to until 2030 going to be actually increased big time.
Thank you, Dr. Saad, for this amazing talk. This is like a 25 mini ER operations course. يعطيك الف عافية. Now, many organizations, they do look at the ER department as the revenue loss and a big risk at the hospital because it's an open gate and it's not controlled. So how to change that mindset to the higher admin that the ER is not, it's actually a revenue generating department compared to a loss and a risk department?
Thank you, Dr. Abdullah. First of all, we know that emergency department is non-revenue generating department. It is not actually about revenue perspective. And if you look actually in any analysis from financial perspective, and this is why today I didn't go for a lot of economics, a lot of financial terminology, because it will confuse everyone. There is no way you take that direction of discussion in this direction, because you're going to lose. From medical perspective, financial people, they have the power if they go from revenue and non-revenue. Emergency department, very high cost, and definitely there is actually a lot of things which is losing money. This is why I told you there are many defects in any emergency department. You need to close it, related to coding, billing, related to relationship with the business office, which is the contact person or the contact office with the approval and the insurance companies. Now, how you win in that debate, it depends on what kind of mission and vision and scope of service the top management they are looking for. The other thing, which is I'm saying always, okay, if you are losing money, close the department. Nobody can work without emergency department. Nobody can work without EMS inside the hospital. But it is actually your role as a leader in emergency department, how you keep that balance between actually high patient satisfaction, your staff a little bit happy, of course they will not be all happy, and excellent cutting the cost or optimizing the cost. I prefer call optimizing the cost rather than cutting the cost. You need to look at what kind of strength. You need yourself and your top management sit down and look where are our strengths as an institute. Go for that strength, work on it. And I'm sure they're going to see actually at the end of the year actually a big difference. But again, you cannot make the change and after 1 or 2 or 3 months you're going to see the difference. It takes a while. So it depends on the other side how they're going to actually take that debate.
One more questions? And the last questions.
You mentioned that the team and the staff are the key. So what is your, let's say, hiring philosophy when it comes to hiring? Let's say, what are your 3 must be in an applicant to be included in a team, and 3 traits that will exclude him from being one of the team?
So you are if I understand the question correctly, you are saying if I'm going to interview 6, so 3 to be accepted, 3 non-accepted?
No. What are the main traits in an applicant that must be existed to be included in the team?
Well, it depends on what kind of hospital and emergency departments. Not every single emergency department.
No, just I'm talking about yours.
You mean in our institute?
Yes.
Well, in our institute, we are looking for the best quality and how they are actually more expert regarding working in the private, how they are excellent in communicating with the patient, and how they are caring about the patient. So it is not only about actually the skills, about the knowledge, it is also about your skills in communication, how to deal with difficult patient, and how you keep that balance between actually good patient care and quality, and from financial perspective from the other side.
Thank you.
You're welcome.
Thank you, Dr. Saad.
Thank you. Take care. Thank you.
Sorry.
Our next speaker is Dr. Basim Al-Ghamdi. He's a trauma and emergency consultant, Saudi Board of Emergency Medicine, trauma fellowship from McGill University. He's currently the deputy chairman of emergency department at King Abdulaziz Medical City, the Ministry of National Guard Hospital in the Western Region area. His talk is going to be about conflict resolution. Dr. Basim. Is he here? Is he?
السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Ahmed, for the introduction. And apparently, guys, you're lagging behind, so I'll promise I'll put you back on track. In terms of times, of course. My topic, the one that I've asked to present, is navigating conflict in the emergency department. And a little bit of a disclosure here that none of we're going to see in the coming 15 or 20 minutes is a new science or something that you haven't heard of. It's more of shedding lights on mental set and way of conflict, dealing with the conflicts and making yourself more comfortable looking at the conflict from a different perspectives. So these are our objectives. We're going to go ahead and define what conflict is. Conflict is the state of discord caused by an actual or even perceived. So most of our fear of conflict, that is our need or interest, or that can intersect with somebody else's needs, intention, or interest. These thoughts or opposition might be actual or might be even perceived. Going to this case, we have Mr. Khalid, who's 60 years old. Mr. Khalid came with his son to the emergency department due to blood sugar being uncontrolled. After you have seen the patient, you examine him, you did your assessment, your lab, you end up deciding on the patients that Mr. Khalid, he doesn't need to stay in the hospital anymore. So you came in and you you explained the plan of care, and your decision was to discharge the patient. Mr. Khalid and his son refuses your treatment plan, and they want to stay in the hospital to be admitted for a 24 hours observation for their blood sugar. One other recent example actually happened last week in our department, where the 42 years old patient who is post-renal transplant came to the emergency with history of neck pain for about 2 weeks. The attending physician has examined the patient, given the fact that he's immunocompromised, so they elected to go one step further. They ordered a CT neck to make sure that they're not missing anything. They found a neck abscess. They have called neurosurgery, general surgery, ENT, and spine surgery also. They have all seen the patient, yet they have signed him off, and nobody took ownership of the patient. And the patient is staying in your department for about 16 hours. Those feelings, when we see these cases, what are the feeling that we have, or the feeling that crosses our minds when we are encountering such a difficult or conflictual situations? Frustrated, irritated, undermined maybe, or hopefully not disrespected. So, touching on the rate of intra-physician conflict and conflict at workplace and the link of burnout. This is a study was conducted actually quite recent. It's about published this month of September 2023. They have interviewed 18 staff, physician, and resident from emergency department whom have go through a conflictual situation, and how these conflict situations translated into harm in terms of their professional career and also in terms of their personal level, and how they felt undermined, undermined, and have felt and how they have felt some decrease their professional attribute and their also professional status, which all lead to increased burnout in our career. So conflict is inevitable. But the battle is optional. So we need to embrace these conflicts and change our mindset and the way that we deal and view these conflicts, and be more comfortable dealing with them, and have the mindset of going through them without any prior assumptions or trying to narrate a previous experience. Embracing a conflict. So since the conflict is natural and it is part of our day-to-day business, especially in our kind of hostile environment in the emergency department, where there is a lot of consultations, 24 hours business, focusing on the problem, not the person. We do tend to have a certain conflictual situation with a certain department or certain physician who's been on call in the other side of the line, or certain nurse or colleague whenever they work side by side. When we take that focus from the person and we focus on the problem itself and how we can reach a common ground, that definitely would help. One more concept is distincting yourself personally from the post that you're presenting. Being the nurse, being the physician in charge, being the medical or the emergency residents, you have a post that you're presenting in that shift. When you're distincting yourself personally from that post that you're presenting during your professional career, definitely this make you visual the conflict and visual the issue without any emotions involved, and make a clearer view. Communicate your point assertively but not aggressively, minding your tone, minding your posture, minding your voice, and also choosing the word definitely will help in the conflictual situation. Peace is, this is a saying from the Ronald Reagan, saying peace is not the absence of a conflict, it's the ability to handle the conflict in a peaceful means. Early phase of conflict. This is where the most of the issue arises. Is either we can go and address the conflict in a peaceful and more productive way, or things can get escalated. First of all, recognizing your body emotion, because our body definitely does not lie, and they act and translate our inner mind and thoughts. So having a control over your emotions will translate into better presentation of yourself, and presentation of your problem, and addressing and more vision to the problem. Asking reflective question. Having your emotion being controlled, your vision is more clearer, and you can have more objective assessment to the situation rather than being clouded by emotion. Reflective questions in terms of what I'm not seeing in this issue. How can I move from the certainty that I'm 100% right to the curiosity, where they're coming from, what is their point of view, is there anything that I'm missing, so I can have a common ground with the other party where we can start some sort of a discussion. Avoiding assumption. Most of our conflictual situation, either in the emergency department or in life, started with some sort of assumption. When we try to train ourselves to take that assumption part out and we try to deal with the fact as they are, that definitely helps our understanding and help our resolution to a better common beneficial option. Finally, listen and listen and listen. And there is nothing can be lost or undermined by listening to the issue completely without jumping into the comeback, since having more comprehension on the issue, more comprehension on the other person's background and their argument. Since we often tend to have a better, and that happens almost all the time, whenever we're in a conflictual situation, a day or a couple of hours later, when we re-narrate that scenario, we come up with a better argument, with a better understanding, with a better solutions, with a better understanding of the other party. Because when we are ignited in our emotions, these emotions take over our clearer judgment, and we end up with suboptimal decisions. These are the 5 styles of addressing a conflict, and it ranges between being so assertive or so accommodating and flexible. So it's the balance of between these two spectrum. You don't be that uncooperative, avoiding, unassertive, running away from each and every conflict, and you don't be also that rigid, firm, sticking with your mind. So we need to navigate these conflicts based on conflict to conflict to make sure that you reach to the appropriate mutual agreement. These are a couple of mindset cycles that you need to be aware of in terms of a conflict, so to make sure that you don't get trapped into this type of vicious cycle. Let's say an example of a phone consultation with subspecialty. You have unmet needs or threats. The first minute that you sense a rejection over the other line of the consult, this unmet needs and threats translate into frustration. Frustration leads to anxiety. Anxiety increases your anger, and then you fail to communicate since you're already destroyed by emotion, or your thoughts are clouded by your emotions, and you go back and forth in this. This is the avoidance also. It's just simulate the same. Having knowledge of these common cycles help you stepping away out of it, especially in the early phase of a conflict. Equanimity. Equanimity, it says in Arabic, rabatatul jash, which is having a mental calmness, composure, and evenness of temper, especially in a difficult situation. And this is a very difficult trait. Having these traits helps in life, plus the day-to-day business and situation. And the main goal of this is controlling your emotion, because having the emotion controlled gives you a clear picture of the situation, help you understanding the other party, and having and being ignited and high in emotion clouds your vision, and also having them control you. So, what mindful response to a conflict could sound like? Getting back to the things that we have mentioned earlier, it's acknowledgement that there is a conflict. Acknowledgement will translate respect to the other party on the line. Acknowledgement of the conflict, then clarify what the conflict is about, moving from certainty that you're 100% right and there is no way that you can discuss the other party's opinion to what am I missing and what's the other alternative and what's they're coming from. Listening with a beginner mind. Actually, this is very easier said than done because after years of work and having most of our tasks being conducted by our subconscious, having that interest into getting to the deep of the things and try to navigate an issue that's happened every now and then is difficult. But training yourself on that would definitely help. Separate the problem from separate the person from the problem, also having an objective assessment regardless who's the other person in the line, whether you have a history with, whether there is that particular on call that you don't like to deal with. It's just having an objective assessment of the problem rather than the person. Be aware of appearing superior or condescending, because first of all, you would like to establish a common background to discuss a mutual situation and benefit. And having either one of this will definitely will not reach to that sense you would like to deal with him partner to partner. And then looking for mutual benefit, beneficial option. Back to Mr. Khalid. Mr. Khalid and his son, the one who had a hypoglycemic attack and he refuses to go after observation. The attending came and talked to him. Apparently, this Mr. Khalid has a hypoglycemic attack last week, which led to situational trauma by the family, and he was rescued. So he was concerned that he might go into that hypoglycemic attack. This is why he demanding his stay for 24 hours observation. So the physician has talked to him and tried to explain to him the fact that how hypoglycemia works. But then he compromised because the patient would like to have something also to be gained out of this conversation. So he compromised that 2 hours and the patient stayed for 2 hours, then he was discharged. The neck abscess guy, the attending physician definitely felt frustrated because the patient was here 16 hours. He was endorsed from shift to shift, yet the patient stayed without any resolution or a disposition plan. So issue was escalated and the patient was admitted administratively without any confrontation or argument. Can a conflict be positive? Well, of course, yes. Anything in life can be positive depending on how you look into it. But conflictual situation definitely can help you exploring the other party. Having more understanding on the background and their thought process. Also helps in building the cohesiveness of the team and working toward a common goal and achieve them. And also result in issue clarification. Things to remember, mind your thoughts. Your thoughts, although they're within you and it's somehow hidden, nobody can see it, but definitely it will be translated in your emotions. And your emotions will be seen. And the way that people see your emotions and your body language definitely will translate into how they react to you and to your arguments. Distinct yourself from your post, and that will give you a better visualization of the issue without being clouded by emotion. Choose your fight wisely and don't get provoked by each and every conflict or each and every argument that can be turned into a conflict or combat. And of course, let go things. We have a lot of things that we address during our daily shift, but these things are trivial and we can overlook them without any patient compromise or self-respect being lost. Respect the other party's opinion, even if that is not something that you agree with, because that's established a common ground where you can start to discuss things and move forward to mutual options. Be assertive and not aggressive, and like what happened in the neck pain, in the neck patients, the neck pain patients escalate when needed appropriately. And from our Prophet Muhammad sallallahu alaihi wasallam, the saying is that a strong man is not the one who is wrestler. Rather, the strong man is the one who is holding himself whenever he's angry. Thank you so much.
Wonderful, Dr. Basim. It's a great thing, actually, about something that is undoubtedly happens in every emergency department or any hospital. We have the floor now open for questions for Dr. Basim.
Please.
Well, thank you so much for the informative presentation. A question that I have, do you think unifying the policies for across the country with emergency departments in general for the admin admission or the safe admission that people they're calling sometimes in different hospitals will solve a good percentage of the conflict in the emergency department?
Absolutely. Having a written policy that's been agreed upon within intra-departmental hospital definitely would help lessen these conflictual situation. But down the line, you cannot having everything written in policy. Developing some resilience on addressing these conflicts, it's a talent or a skill that you need to have in your back pocket.
Any more questions? Well,
thank you so
I
much.
could only say thank you so much for your presentation. It was great. Wish you all the best.
Our next speaker will be Dr. Abdullah Basnawi. Dr. Abdullah, he's graduated from the Qura Medical College at University. He's obtained his residency in emergency medicine at Baylor Medical College at Houston, Texas, followed by the fellowship in emergency operations. Dr. Abdullah currently right now he's the chairman of the emergency department at IMC, International Medical Center, Jeddah. He will talk about one of the core concept in health transformation, which is the health value-based medicine. Welcome, Abdullah, and go ahead.
السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على رسول الله محمد صلى الله عليه وسلم. Thank you, organization committee and scientific committee, for giving me this opportunity. I am really thrilled to be here today to talk about the concept of value-based healthcare and how most of the globe is shifting from the old concept, which is a fee for service or a specific service, to a global kind of concept, which is value healthcare. Now, what's value? Value, in its simple definition, is an outcome that matters to the patient compared to the costs that have been spent. Now, there are many ways also to look at value-based healthcare. Is not only from the cost, but also from the outcome. The outcome here is really an important thing for the patient, the relatives, and the organization as well. It does also incorporate collaboration between different sectors, between also different providers as well. It focuses on the patient and the journey of the patient. Now, there are different models since the inception of this idea or concept that many organizations try to experience and try to implement as well. And these different models have been going through trial and error throughout time. Now, for providers, there are many benefits for healthcare, for a value-based healthcare. It gives you more time with patients when you reduce the number of visits to the ER or to also the clinic as well. And the reimbursement systems will be more efficient and make sense to providers as well. And it will help collaborate between different healthcare providers. Now, for the patients, it does give them an opportunity for a better access to care. And also, this type of care is tailored and it's specific to the patient itself. And, of course, improve satisfaction. Now, as an overall benefit for the patients and for everybody. For patients, low cost and better outcome. For providers, better satisfaction rates, better care efficiencies. For payers, more stronger cost control and reduced cost. For suppliers, there is alignment of prices. And for society, reduced healthcare spending overall. Now, there is a growing traction and attention for a model that delivers a better outcome for the patients with lower cost. Now, we spoke about a few points that are an advantage for a healthcare, for a value-based healthcare model. But however, also there is some challenges. It's complicated to implement and monitor, usually requires significant allocation of resources, and also can create a lot of pressure on the system as well. Here in Saudi Arabia, as part of Vision 2030, is we transform and we shift from a fee-for-service model to a value-based model. That starts with the Center for Innovation, for Improving Value in Health. It's an independent organization where it focuses on knowledge, policies, and also capabilities that can provide to build the infrastructure for this kind of model. Also, in the private sector, the Center for Health Insurance, CHI, has many strategic programs and goals as well to achieve this kind of model, and it already started. We will touch base on it right now. To transform and to shift from a fee-for-service model to a value-based model, there are many areas that we have to keep in mind and many challenges that we need to take into consideration. First one is building an infrastructure, a technology infrastructure, where you have data that you can analyze and you can utilize to help you navigate. You need to develop a system where you can benchmark between different areas in the system. Payment models, this is the key. Developing a payment model that help you develop and also exchange the finance throughout the system. And also the delivery organizations where they actually collaborate and ship into this kind of concept. Now, many payment models, the payment model is the key tool, and there are many payment models, but trying to find out the most efficient payment model is the key tool in any kind of reform that you will do in any health systems. Now, before choosing the payment model, we need to ask ourselves a few questions, Like, are these payment models in line with our objectives in the system? Is it based on evidence regarding an effective health system or not? Also, is it inclusive of all the services and delivery components of these services? The type of payment models, there's a breadth of payment models. There is, like, from the far left or the right of the screen, the fee-for-service, and that's where we are today, to that's unbundled kind of service, to a bundled kind of service, like the block budget service. And now, not any single payment model is efficient and important. A mix of payment models usually serves the goal, but however, we need to keep in mind a very careful selection of the payment model. With the different payment models, there are risks, of course. And for example, if you can see where we are today for fee for service, the risks are there and the value is low. How can we move from a low value with a high risk to a higher value area and try to find the balance and the sweet spot for this kind of payment models? Now, the work is going on, and it started by the CHI back in 2019, where it has to be segmented into phases, and also it has to be kind of planned over few years. This is not something that we can build overnight and decide to roll out with. So the CHI has decided to divide it into 4 phases. And the key step here is phase number 1, or the first phase, where it can actually understand the system, understand the day-to-day transaction. So what happened is we developed, or the CHI developed, a data health exchange system called Nafis. Maybe most of you heard about Nafis, which is a health exchange platform, where here in phase 1, it's a phase where we collect data, understand the market, kind of developing a coding system that's standardized coding system where everybody can talk through this. And benchmarking, classifying organizations, deciding which organization falls into which category. Also understand the payment system that's going on and the billing system, and try to get all the organizations engaged in this direction. Now, the last phase where we are hoping to get to is the phase 4, which is having an electronic health system that kind of connects all different sectors together. And at the same time, these systems are driven by clinical decision rules to support it, and also that at that time it will help us roll out the first bundled payment model. This is the timeline. Now in 2013, we're already here, 2023, we already here have kind of a cost comparison metrics that's going on through submission of the billings throughout through the Nafis health exchange system. And also here, the first, by the year 2025, the first value-based bundled payment and system will be tested at that time. And multidisciplinary teams and outpatient care, everybody will be connected together. That's it, short. Any question?
Thank you, Abdullah, for this amazing talk. The floor open for questions. Dr. Saad.
يعطيك العافية دكتور عبد الله. It is a note and question. So yes, Nafis is the platform. This is what is actually currently in the private. And it is important topic which you mentioned because we are really heading to that direction, which is completely changing the game regarding the what kind of patient care and what kind of payment methodology going to be between the private and the insurance companies, and going to change the whole market. It is a big challenge, and that actually it is very clear in Dubai healthcare system by the DRG, and it is really challenging for everyone. So if we are not actually ready, it will be late because it is going to be changed from next year. I want to emphasize for all the emergency departments working in the emergency in healthcare sector as a private to work in that direction with the CCHI and the fees, because the full process between the hospitals and this platform and the CCHI completely going to be changed, starting from the triage and what kind of patient care given to the patient, and that going to be linked to what kind of claims going to be collected. So it is a big shift. This is as a note. Regarding as a question, how do you think our emergency medicine in the country can cope with such big shift and big change, and how we can match that value-based?
Yes. So many of our emergencies, they do focus on the patient, and maybe they do have the gunshot approach, like you can order anything you want, order all the labs, because there is no kind of engagement in terms of efficiency. Now, this puts a lot of burden on the system when you follow this kind of model. When you don't consider what really matters for the patient and what really doesn't matter. Do I need to order this test or not? Do I need to do this intervention or not? Now here we're talking about time. And time is money, of course. And we're talking about the cost for the patient itself. For emergency physicians need to keep in mind that to reach this step is to really order and be within boundaries of the necessity and what's necessary for the patient itself. Maybe some clinical decision rules can help that as well, and some guidelines in the ER can help navigate the physician in terms of what really is needed and what's not needed for that kind of service. Thank you for the question.
Any questions? So while we are waiting, Abdullah, I have a question. Now for this kind of period for transitions from the free service to value-based.
I'm sorry.
The transition period right now from the free service to value-based, what is the biggest risk for this shifting?
In this shifting from the current model
to value-based.
To value-based. Now, is the biggest challenge is that not knowing exactly what's the real infrastructure that you have. That's the problem. So that's why, as you can see, the majority of the time is being spent on developing an infrastructure and a database. The database is not only through the Nafis Health Exchange system, but also it's through patient experience, because here we're talking about the patient. So the patient experience, the patient outcome, surveys, feedback from the patient, all this takes some time. So data collection, data gathering to know exactly where are you heading, that what will take some time. Because every decision you will make afterwards in terms of choosing which kind of financial model you want to implement, it depends on the data that you have. So collecting the data across different sectors, that's what will take some time, and that's the biggest challenge. Because you have here different, you have governmental, you have non-governmental sectors, and you have military sectors. So all these, trying to collect the data and connect all these together, this is what will say take some time, and the biggest challenge.
Dr. Abdullah.
Thank you.
Before I leave, just a quick question, and I hope that you would probably highlight on it. Now, the value-based healthcare system, if isn't it would be of beneficial to the community and to the patient experience and to the payers and to the things that you have mentioned in your talk, that you designate centers to provide certain services instead of having the patients going around and fishing in every hospital. Would value-based care help in that matter, where it could really designate, for example, King Fahd is the trauma and all patients will go there, and would that be not part of this?
So if we think about it as a concept itself, where we would like to have the best outcome means in terms of medical outcome and patient experience outcome as well. If we want to have the best outcome with the lowest cost, there are many different, so this is the main concept of value, right? Then many examples have developed of this, concept. Like for an example, how can we develop a cancer center where the patients, when they go there, they have the best outcome because it has the best expertise, the best equipment, and the whole cancer center is focused around the patient itself. Also, for example, like for geriatric homes as well. Home healthcare services, moving the patient care at home instead of at the hospital. So these are different examples of a value-based concept. So yes, you can have this kind of concept in a different forms. However, it boils down to what's the outcome in terms of experience, in terms of patient satisfaction, and also the cost itself. Yes. Good question. Thank you.
Abdullah, sorry, just one last question, if you
Yes.
don't mind. Do you think this looks sexy and appealing to the private sector? How do you think the private sector will approach this, in keeping in mind that you want to give the best you can to your patient, but at the same time see it as a good opportunity to invest in such a model and improve it?
Now, of course, in terms of now, how can this will benefit the private sector? The private sector will, when we think about this model, of course, it will improve the patient satisfaction and the outcome. So that's what many of the private sectors are, thriving to achieve, is patient satisfaction, patient outcome, and at the same time, it will help them run their day-to-day business efficiently and more lean. That means that if things are being spent on beneficial services, this kind of cost can be directed to different services. They can open new services. They can purchase new equipment. So yes, for the private sector, it's a very good model as well and concept. Yeah.
Okay.
Thank you.
Thank you, Abdullah. Our fourth speaker for this afternoon is Dr. Sausan Hanafi, who is a consultant in emergency medicine in the Ministry of National Guard Hospital, King Abdulaziz Medical City, Jeddah, and she is an assistant professor at King Saud for Healthcare Sciences, and she is the Director of Quality of Care, and she's boarded, or the Director of Quality of Care Board at the Ministry of National Guard Hospital. Please welcome Dr. Sausan Hanafi for her presentation on quality improvement in ER.
Assalamu alaikum wa rahmatullah. It's actually my pleasure being here presenting in SASIM, and extra pleasure for me to be introduced by Dr. Rabri, who was my mentor and the head of department. I learned him a lot. So I was thinking about how to improve the quality in emergency department is a very big topic, and it's rich as well. Many of you as leaders, they know about a lot about it. But I think I choose this topic as moving from safety 1 to safety 2 with the causality credo mind, because it's a growing approach, although it's underused and commonly unused in our quality practice, especially in the healthcare system. It's used very well known in other systems like engineering, but in healthcare system, which is the most complex, is not widely used, not widely understood, and is very helpful in emergency department. So what's usually known about safety? We are looking at the systems are perfectly designed and well maintained. It's basically safe and very well protected. Procedures are comprehensive, complete, correct, not deficient, and up to date. And the frontline staff, we are expecting them to they are expected and trained too. And designers have expected every contingency and equipped the system with needed capabilities to respond. But are these the actual reality? Look at this picture. What you can see? Different types of tomatoes. If you have a recipe, it will tell you use 1 piece of tomato. So all of them will fit the same for each recipe? What do you think? Absolutely not. If you are expert in cooking, you will know that the small cherry tomato will fit the best for salad, while the soft, juicy tomato will fit for the cooking rice, like kabsa and bukhari. The solid tomato is fitting best for stuffed part of tomato, mahshi part. It will not be written in the policy or the recipe. You are the one who choose. You are the one who adapt the conditions according to your need. There is a general safety riding rule mentioning that the cars have to drive in the middle of the road, and all hikers and bikes have to ride in the sides of the street. This is a general, well-known safety rule. But is it actually a safe rule here? The conditions are not allowing this rule to be implemented here. Am I right? So the safety one has 2 main blocks, working by 2 models. we are thinking that the systems are decomposable and working in two functions, two modes. The systems are decomposable. It means that the processes can be broken down into constituents. People who are the source system can be decomposed into their parts by departments, specialties, by teams. And events can be understood and simplified in time frames. And functioning is bimodal. If the work is done as imagined, it's success. It's considered as a success and functioning correctly. And if it's not worked as expected or as we thought to be, it means it's failing or malfunctioning. So how is safety one displayed? It's looking at what goes wrong. We are looking at the adverse outcomes over the risks, harms, and errors. So we are indirectly defining safety by its absence. How does this safety one operate? By the causality credo. Globally, we believe that incidents comes from as a result of something went wrong. And we have to look for the causes of those incidents to fix it and treat it. So it's, generally speaking, is a find and fix approach. We are either having error or risk, we investigate the causes of error, and we apply appropriate solution for them. If we are having the risk, we identify the hazard, and we try to eliminate it or contain it. But despite all those efforts for years and years over the quality and patient safety, there is a global agreement that we are not moving as fast as we expect to or we wish to. They thought maybe because of lack of accountability of people or staff. They thought maybe because lack of evidence-based medicine surrounding the quality and patient safety. But this is not the actual happening. We are accountable. We are adherent to policies, even though we are failing. We are still failing sometimes. So we have to think, we have to change our mind of thinking and approaching the safety. So how we discussed today, we believe that the systems and clinical processes cannot be broken into meaningful way, especially in a very complex healthcare system. And the system don't operate in two modes, either success or failure. And human performance variability is the source of acceptable and adverse outcome. As I show you two examples, we have the humans and we are the staff. We have to adapt ourselves to the surroundings. We have to overcome and have some solutions for unpredictable surroundings, especially in our emergency department. So not all adverse outcomes result from malfunctions. Others can result from accumulation of performance variabilities. So we have to look at frequency rather than severity. Rather than spending a lot of time in fixing and trying to find the cause for an adverse event, we have to spend some time to explore the regularity of frequent events, to have a vision about our healthcare performance variability. So this is the safety one approach who's looking at the function, if it's functioning as imagined as a success, and if it's not worked as imagined in the policies and procedure, it means it's a failure. While in safety 2 approach, we are looking over everyday work in our system with its success and failure and try to learn from them. So here, the safety 2 comes. The building block of it is performance variability must be a must. We have to adjust our performance. according to the need of work. And variability should not be judged negatively as in performance deviation, violation, and non-compliance. And finding out adjustment and learn from them. So how it's being displaced? All the acceptable outcomes. Looking at what goes right in our daily practice rather than looking on what went wrong, on the harms. So safety 2 operate basically not like the safety 1 old system on causality and linear propagation, cause and effect, like in Henrik domino model and in Swiss cheese model. We have to look for the cause, and we take out the cause, eliminate it, then we'll have a good outcome. But rather, the healthcare system is a very complex, dynamic, interconnected, nonlinear system. We have multiple causes. We cannot find one cause or two causes only. And there is emergence in everyday practice, emergence thing. We have to adapt with it, and we have to learn for them. And the COVID pandemic is a very good example on that. We face something that we don't know about it. We don't have any previous experience with it. And we face it, we handle it, and we have a very successful story with it. This is a multi-center study done in 2000 about the human factors in cardiac surgeons. Surprisingly, the surgeons with best result has as many as untoward events as those with the worst results. But where is the key? What is the difference? The good surgeons had better means of detection and a greater response toward those complications. So they adapt with the situations they are dealing with. This is a very famous big study by Ghafiri in 2009 in collaboration with NSQIPS, the National Surgical Quality and Improvement Patient Safety. It studied the hospital with lowest hospital variation mortality in surgical inpatient wards. It included more than 83,000 of patients. And the result were that hospitals with lower mortality has as many complications as those with worst mortality. But what is the difference? They had an earlier recognition and better responses of complication they are having. So the response, adaptation to surrounding atmosphere is the key of success. This is an overview summary of safety 1 old approach and safety 2 new approach. In safety 1, it's defined by as few adverse outcomes as possible. But in safety 2, we have as many acceptable outcomes as possible. So the safety 1 is actually reactive. We look backward from the incident, backward to its possible causes to try to fix it. But in safety 2, it's a proactive mechanism. We continue monitoring and predict the possible improvements and risks. What about the human factor in both of them? Safety 1 sees the human factor as a possible contributor to adverse events. He's a harmful person. But actually, the safety 2 sees the human factor as a crucial resource for flexibility and resilience. So how is being investigated in safety 1? By analyzing the failure or malfunction to look backward for its causes. But in safety 2, by understanding things usually done on daily basis and how it went right. What's the hidden causes for it to be right? So it's assist in safety 1 by possible causes, identifying possible causes and risk, while in safety 2 by performance variability. This is a very good chart to show us, convince us to change our mind. If we have one harm or one error or one incidence, how many events we are daily having? If we have 10,000 events, it means that there is one event, one harmful event in 9,999 non-failures. So we are tunnel vision and focusing on the accidents and disaster. We are missing very good opportunity of learning from our safe practice. So how to adopt safety too? Looking for what goes right every day. Focus on the frequency of events rather than spending time on the severity. And remain sensitive at the same time to possibility of failure. Be thorough as well as efficient and invest those in safety. How we can tackle incidents in safety too if we are just looking at good things? How can we do that? By safety observation, day-to-day observation in the practice. We introduced tracer rounds in our hospital. It was very beneficial. There is a weekly round among the emergency department, inpatient wards, and ICU. We interview the physicians, nurses, patients as well. And we got we discover a lot of things that was not discovered by years of practicing quality by only looking at harms. And debriefing. Debriefing is an old, well-understood tool of measurement and assessment in simulation science, but it wasn't used in other types of sciences. It's now newly introduced in the safety practice. We debrief our good work. We do safety investigations. We investigate as well the adverse events, as well as we add to them investigating our ordinary work and exceptional performance. Why, if we have a daily update about our census, why this shift went exceptionally well while we are having the same registration of patient, same number of boarding, and there is no DNA, for example? We have to look for the hidden causes of its outstanding performance. What makes it a good shift? And safety assessment. Safety assessment the best for this is functional resonance analysis method. It can be done with the help of quality specialists looking for input, output, cost, time, resources, and requirements. This study shows that debriefing is a very good tool to be included in safety practice as well. So my take-home message is that looking at frequency of events is more important than looking at severity to understand the better of system performance. And learning from good practice is as important as learning from mistake, if not better even. And performance variability is a must to adjust to surrounding conditions. Safety 2 is a complement to Safety 1 and doesn't replace it. And this is there is a new thinking to combine them both in what we call it Safety 3. These are my references. Thank you for listening.
Excellent talk, Susan. Good explanation, and thank you for this lecture. The floor is open for questions from the audience. Anyone wants to ask Susan for the new shift in quality improvement in ER? Now we're going to look at the good things, not looking at what SAC score 1 or 2. We're going to look at different thing now. So if you have any questions, please go ahead.
It's a new and not well-known approach, huh?
Dr. Susan, yes, thank you so much for this amazing Salaha talk. how we can promote the culture of the quality and the safety in the Department of Emergency Medicine.
In the Department of Emergency Medicine.
Yes. So I think it's about cultures, about to keep it, to maintain it, and to promote that. How?
Yeah. So as previously said, very important thing to improve the quality of the department is the department to raise their quality concerns rather than an instructions coming for the quality department to you. You are the one who raised it, as Dr. Saad mentioned before. And you work with the quality team in collaboration to improve this. Tracer rounds are very useful because, as I told you, working on harms and errors doesn't show that maximum benefit. Mortalities, morbidities, patients complain are very good, but we are looking only on a small part. We are looking on the good side, how we perform very well in our practice, why we manage the calls very well, why we sometimes don't have DNAs in the shift, why sometimes we are having a reduced length of stay in some shifts, even during evening and nights. If we have a good learning opportunities from those.
Yes, excellent. So while you're talking, I remember one experience we have it in my department. So I promote the culture of quality sometimes by get people educated, get well educated about the quality by taking courses like CBHQ or SQA. I have many persons right now qualified and attending these courses and certified. So gradually starting talking the same language, taking the same initiative and creating initiative. And as you said, we're creating the culture from inside the department, not from the quality department.
Yeah.
Which is a good tool for that. Thank you.
Absolutely.
I think what you are doing is really amazing. I've been in the hospital morbidity for chairman a long time and member in mortality, and they always look at the adverse events. They don't look at the side that you have discovered, which is the bigger size.
Yeah.
You did not deny the fact that we still need to look at this particular bad outcomes. However, we need to look at with the new concepts of safety in practice. We have to look at the overall performance. And I think it's probably a great encouragement to the staff and to whoever works there. But I think it's going to be a great task to really go and let the hospital know. The hospital is still in the understanding of the old culture. The new culture needs time to be established.
Yeah.
However, efforts of people like you who are energetics and others who are sharing the same ideas of yours might be beneficial, but you need to really stand strong for what you believe.
Inshallah.
Thank you very much.
Inshallah.
Great talk.
Thank you, Dr. Rabban. Thank you all.
So I will ask all the speaker to be in the stand to receive some appreciation, and we'll take a photo. Speaker.
of day 2 of SASM 2023 here in Jeddah. This section we have very distinguished speakers who will engage the discussion and share with us a lot of fruitful informations. First of all, let me introduce myself, Abdurrahman Sabbagh, emergency consultant, King Fahd Medical City, ودكتور خالد أبو حامد الأحساء القابضة. حياكم الله جميعا. طيب, we'll start if the first speaker ready to start. I think they are arranging the mic. So we'll start with Dr. Muhammad Shiha. He has a topic about radiations. He's a Saudi and Arab Board of Emergency Medicine Medical Toxicology Fellowship from Emory University, Atlanta, Georgia, United States. He's interested in radiation toxicology and business development. Please welcome Dr. Muhammad. Floor is yours.
Assalamu alaikum. Thank you, Abdurrahman, for this introduction. And as Dr. Abdurrahman mentioned, we'll talk about radiation today. I was pleasure to do my fellowship in Emory University, where they have like an excellent course where they present for participants a good insight about radiation toxicology, the decon procedure, and the disaster response. So I will try to share with you today some of those experiences that I had over there. Today, our objectives, we'll talk about, in the first, we need to be familiar with some terms that they use in the radiology ecosystem when it comes to toxicology, some basic physics, a little bit interesting part for some of us. Then we'll talk about clinical data and psychological impact of those events. From movies, if you remember The Incredible Hulk, this guy, he was working in a lab and got exposed to some gamma radiation, and this turned him to that beast that has this immense power. He can go there and smash tanks and climb on walls. But is that real? If we get a certain amount of radiation, will our DNA change to something super natural that we can have those powers? Actually, not really. This is not really the reality, because radiation will change your DNA. We'll talk about this in a minute, but mostly it's in a bad way. First, we need to define the radiation. What is radiation? Radiation is like emission of power through space, emission of energy through space to hit another distance from point A to point B, energy emission. The second term that we need to be familiar with is the radioactive decay. So some elements that has radioactive properties, say uranium, they decay over time. And decaying means that the nucleus, hope you can be, to see the nucleus here, start to shed some particles out of the center. Different kind of particles, alpha, beta, gamma rays, and each one of those has a different size, different kind of energy, and with we will see how these differences of sizes and energy will affect the clinical presentation. We have two main types of nuclear reactions. The first one is the old-fashioned one, the one on the left, which is the fission, or like splitting. What we do here, we will shoot a particle, usually a neutron, to a heavy or like a large element. Here we have uranium, which will split this atom into two parts, and it will release some energy and other parts like neutrons here. Pay attention to this picture, so it will explain a lot in our coming slides. So each reaction, it will produce energy and other particles, neutrons here. The other one is the newer version, which is fusion, when we use a lighter elements like heavy water, like deuterium and tritium, and we fuse them together to make a helium atom and the neutrons as well, and the difference will be energy. What does that mean? Does that mean if we have this kind of reactions, if we have like a flying uranium atom and somebody shoots a neutron on it, will it explode? We will have like a nuclear bomb in our streets? Not really. We just need to have the enough amount of material, let's say enough uranium, enough energy to have a nuclear chain reaction. And the nuclear chain reaction is like a continuous sustained reaction. It's like in the reactor in the nuclear bomb, where if we start here, if we see like in the top figure, they shoot one neutron to the blue part is the uranium, let's say. So the chain reaction, the reaction will trigger. Each atom will produce 3 neutrons, and those 3 neutrons will go and hit other atoms. But if the mass is not large enough, what will happen? Some of those neutrons will leave the mass, and some of them won't find other atoms. So the reaction stops. If we have a larger mass, if we have a larger amount of uranium or whatever, what will happen? A chain reaction will be triggered. So each atom will start to split another 3 atoms, and the 3 will split another 3 to be 9, and etc. To make this even better, we can put a reflective surface, like a mirror, where like when the neutrons try to escape that mass, it will just hit that surface and come back inside. And this is what they call it, the critical mass. Mass is not like, it's a misnomer. It's not like a mass, like an amount of, or the weight that we need to have a nuclear bomb or nuclear reaction. It's just the way that we can trigger the nuclear reaction. How to trigger it? We have 2 ways. The conventional gun type assembly method, where we have a conventional explosive on the top one, and 2 semicircular, let's say, bodies with uranium inside it. Once we explode those chemical explosive, they would just shoot one half to hit the other half. Then the reaction will be triggered. The other one, which is the impulsion assembly method, you can have a condensed core of plutonium usually, and you have the explosive all around. And then once you explode those explosive, they will shoot neutrons inside, and they will trigger the reaction. How to trigger the reaction? There is multiple methods. One of them, what we said, what we just mentioned here, is the mechanical trigger. When you move things, if you change the temperature, if you increase the mass, many other ways. And this is what happened in Chernobyl, in Ukraine, Russia, at that time, Soviet Union, where the cooling system got disabled for a reason or another, and the temperature kept increasing, so the reaction didn't stop, and the reaction went beyond control. And this is the picture of the core of the nuclear reactor in Chernobyl. It got melted because of the reaction. This reaction and the energy, it will shoot 2 kinds of waves and particles, ionized and non-ionized. The non-ionized one is like the one that we see in cell phones and radio waves, and the ionizing, which is the particles and the waves, alpha, beta, neutrons, and the waves like X-ray and gamma ray. And usually those waves and particles, they go into a spectrum. If you look at the left side, the non-ionizing radiation is starting from the optical spectrum, if we say, where we can see it. Then the infrared, the microwave, And most of the newer technology that we are using in our life, it goes in this spectrum. If you see down here, the power lines, the AM and FM radio, the TV, the microwave that you use in your home, all goes in the non-ionizing radiation. On the other side, the ionized one, which is the ultraviolet ray. This is why we keep saying, when you go to the seaside, when you go to the beach, put sunscreen. If you get exposed to a lot of ultraviolet rays, this is an ionizing radiation. It might cause skin cancer. The tanning booth, it gives you the tan, but it's not in the DNA damaging zone, which is more than the first couple of millimeters of ultraviolet radiation. So, non-ionizing radiation, despite the claims, there's no clear evidence that they have healthcare harm. You might hear your mom saying, like, don't you put your phone next to your head when you're sleeping, things like that. There's no evidence for that. Even like if you go to industrial and telecommunication companies, you will see those signs all over the place trying to warn people about the radiation. No evidence. What we care here about is the ionizing one. When those kind of radiation hit your body, they will damage and will change your DNA structure and the water structure. And from there, you will get the clinical outcome. The cell sensitivity, they are different according to the organs, but usually they affect the high dividing cells, like it affects embryos and blood forming organs like bone marrows, and it goes down all the way until you find the most resisting ones, the central nervous systems and muscles. And those particles and waves, they have different penetrating abilities. If you look all the way in the top, the alpha rays, the one with the biggest or largest mass, they have the highest energy, but it can be stopped easy by a paper, just a paper. It will be enough to stop those particles. Then the beta, where can be stopped by a thin wooden plate. Then we have the X-ray and the gamma rays, where you need a thicker or different material like lead, iron plates. This is what we see in hospitals when they lead the walls, so the radiologist won't get exposed to the tech. And the last one, the neutrons. They have the longest range, lowest energy, and you need something like concrete or water to stop them. And this is all based on their masses and their energy, as you see on the left graph. How to measure it? Different names. We have on the left side, we have the European names like Gray and Servet. And on the right side, we have the American counterparts, which is Curie and Rad and RIM. But what does those things mean? Just for us as a healthcare providers, we should be worried more about RADs, because RADs and Gray, they express the amount of energy deposits on the tissue per gram, and this is what will give the most of the outcome. So when we talk, usually in clinical settings, let's focus on Gray. If you focus on Gray, you will be good. Sorry. There's something that we call the background radiation. You're not working in an industrial area, you're not working next to a power line, but you still get exposed to radiation. Like consumer products, industrial releases, radon and thoron, that they use it in a lot of chemical nuclear reactors. But the one that we really care about is the medical procedures ones. According to the NCRP report in 2006, the medical radiation that we as physicians start to introduce to our societies become almost as much as the background radiation in the community, comparing 1980s to 2006. There's two main types of radiation exposure: the external radiation and the internal radiation. The external, usually when the radioactive material stick to your clothes, to your skin and your hair. And they can produce a range of symptoms starting from subclinical all the way to CNS and death. Those are dose dependent. So if you get exposed to more radiation, more grays, more rads, you will have worse symptoms. We'll discuss those one by one in a fast fashion. The prodrome, nausea, vomiting, headache, no diarrhea, usually starts from 2 grays, and as high as you get radiation doses, as worse cases and early symptoms you will get. And you can use vomiting or like the starting of symptoms as a triaging method in the disaster. So people with more than 4 hours onset of symptoms means that they can get a delayed care. People with less than 4 hours, they need an immediate care because it means that they get exposed to more radiation. The hematopoietic syndrome starts immediately. In the first 24 hours, you will see the lymphocytes count goes down dramatically. In the coming days, the neutrophils and platelets will follow, and the most resistant to the RBCs. It's a sensitive indicator. Low lymphocytes means those people, they got exposed and they have the hematopoietic syndrome. And how to manage it? Basically, you need to manage the complication, the infection and the bleeding. And everything rotates around it. You need to treat the infection by starting antibiotic even before the fever, reverse the isolation, and for the bleeding, give IV fluid, give blood products, some advanced measurements like colony stimulating factor, and you should consider stem cell transplantation with your hematologist. The local radiation injury, basically, mostly it's because of exposure of alpha particles, where the radiation will hurt your skin. And it has multiple levels and layers. It starts with ablation, which means body hair loss. It appears 2 to 3 weeks after the exposure. Then you have the erythema, different stages, dose dependent. 3 grays will appear in 3 weeks. But if you go from 6 grays and above, it will appear within 48 hours. Dry desquamation, where you have dry, peeling skin, more than 10 grays. And what's worse than that is the moist desquamation, which has blistering and peeling skin with the higher doses. And the end of that spectrum is the skin necrosis, where usually it's 50 grays and above. And if you notice, people with the cutaneous exposure, they can handle higher dose of radiation, higher fatal dose of radiation. The gastrointestinal syndrome, the difference between that and prodrome is the diarrhea mainly. Treatment is supportive, bad prognosis, and then the CNS manifestation with like more than 20 grays. It has a bad prognosis. Those symptoms, they come because they happen because of seizure, brain edema, and they can lead to death and coma, and nobody survives that. This is an incident happened in Japan, in Takamura, where they have a nuclear reactor in 1997. And for the first time in 5 years, the Takamura nuclear plant needed to make nuclear fuel, okay, after they opened it. So one had been, the number one, those people, they got a training how to do it, but with a feeder. But there was something wrong with the feeder that they put the nuclear or the radioactive material in. But instead of that, the workers simply start to bring buckets of radioactive material and to throw it inside the reactor, instead using the feeder. And you see here 3 workers in the room. I can't read their names, Hichi Osho, in number A. And his body was, as you see, dropped next to the reactor. And then number B, Mr. Masto, stood on the ladder to dump the material. And number C, Mr. Yakuta, he was the supervisor. And he was supervising the process from 4 meters away in his desk behind the wall. So as soon they added the 7th bucket, what happened? The critical mass of uranium was reached, and they reported seeing a blue flash and a gamma radiation alarms went off. So patient A, he got exposed to around 8 to 13 grays, vomited within 5 minutes. He became unconscious for 2 and 3 minutes, started to have diarrhea in 1 hour. Then he started to develop severe hematopoietic symptoms. Whole body had wet discoloration, GI symptoms, then organ failures, and died within 83 days. B, Mr. Patient, he got exposed to 7 to 8 grays, vomited within 60 minutes, a little bit longer, and also developed hematological symptoms. He went to multi-organ failures, but died a little bit later, in more than 200 days. Patient C, he only received 1.6 grays. He had nausea, but no vomiting, developed mild hematopoietic syndrome, and he was discharged home within 82 days. And this is like a clear case how the doses of the radiation can affect the outcome in those incidents. In fact, the internal radiation, it happens when you ingest radioactive material, and there are different radioactive material. Your goal here is to block absorption of those radioactive material. And each one of those radionuclide has its own treatment, like an antidote. So if you have an iodine, radioactive iodine ingestion, you should use potassium iodine. Tritium, you can use water. For uranium, you can use sodium bicarb, and etc. And basically, the treatment is supportive, long-term monitoring, the chelation therapy, as we mentioned 2 seconds ago, and always contact the authorities here in Saudi. We will contact Ministry of Health for more resources. One of the classical examples of radioactive material internal contamination is iodine and thyroid. So what happened basically, the radioactive iodine will go and will sit in the thyroid gland. The goal of the chelation therapy or the antidote, you give the patient enough iodine so the thyroid will be saturated with that, and it will start to push the radioactive ones away and say, I'm done, I don't need you. And you need to start it early. Potassium iodine, it has the it's mostly effective in the first 24 hours. After that, it has no role. Some about psychological impact of those kind of incidents. This picture in 2006 in China, where people were trying to reach supermarkets and stores to get iodine salt, because some news came out that China might go, some certain area in China might go into nuclear fallout. Also in Brazil, because of a similar incident, they were like having international teams from CDC checking kids in the schools and people in their houses. And this is because radiation, it has a strong sense of fatalism and social stigmata. People are really concerned about it. Takamura, the city in Japan, it's a regular checkup in schools, in gyms, in malls. They start to check kids and adults for radioactive deposit in their thyroids. And this is the picture of Takamura 1 week after the incident. People, they were seeking shelters. Nobody wanted to leave their home. Everyone was afraid that if they leave, they will get exposed to radiation. So our summary points from our talk, the ionized radiation damage cells and DNA. Ionized radiation include alpha particles, beta, gamma rays, and neutrons. People are exposed to background radiation all the time. The cutaneous radiation syndrome usually is delayed in onset, and supportive care is the key. Here's some helpful resources. Thank you.
Thank you, Muhammad. It's a pleasure to present our second presenter, Dr. Mubarak Al-Harthi. He's an emergency medicine and medical toxicology consultant at King Saud Medical City. He's the medical director of the Toxicology Consultation Service at the National Appointment and Referral Center, Ministry of Health. He's going to enlighten us about desert envenomation. So welcome, Dr. Mubarak. Yeah, we will take questions for Dr. Shiha at the end of because we have few questions for you. I hope we will have the time to do that. Meanwhile, welcome Dr. Al-Harthi.
Thank you for having me back in Sasan for the 5th time actually in a row. And it's always about snake envenomation and desert envenomation in general. So we have talked about this topic for a couple of times, and now we want to do some updates here. We will start with some statistics that we had in 2022 about the envenomation in general. So snake bite, we had 264, and the scorpion stings 580, and centipedes, which is 44, we have 41 cases over 2022. Generally speaking about snakes, and I think we went through this back in 2018, and our colleagues started a workshop the conference, and they talked about the different species with the live demonstration of snakes. Just a quick review here. We have the we have the Atractaspedidae, which is Aswad al-Khabith. We have Macrolobidota, again in the same family, Atractaspedidae. And we have the other family, which is the Elabidae, the Najahaj and the Walternesia aegyptia. The third family, which is the Vibridae, the hematotoxic one, Cerastus, Omijneb. The other one here is Coloratus, Echis coloratus, Sujad al-Sharqi, Echis carinatus, al-Minshariya, Buff adder, which is Beta saritans. So these are the major venomous species that we have here and families we have here in Saudi Arabia. Other than this, we have like 55 species. So in our statistic, we found out that male is more than female when it comes to envenomation, which it goes consistent with international statistics for many reasons. One of them is the outgoing behavior of men, working places. And the other thing here is mainly at the age of working men, so 19 to 65 years old. Do you have a pointer here? I'm not sure if we can use this. However, from 19 to 65, we have the most number of cases in this age group. At the night time more than the daytime, which is expected again, mainly Al-Madinah Al-Munawwara, and we don't really know why exactly Al-Madinah Al-Munawwara, maybe because they are reporting the cases more than the other areas. That's what we believe in. And mostly in the summertime, as usual, there is nothing here special about our statistics. And number of cases that they received the antivenom is 157, which is 107, which is 41% of the cases. So most of the cases, more than half, they did not receive the antivenom. So now we'll go to the scorpions. Again, just a quick overview. One of the most common species or clinically significant species is Liurius conquestratus. We have Androctonus crassicada, and we have the bicolor, and Nebo historicus in the southern area. Our number here is 580 cases in 2022. 66 of them are men, and the rest are women. And as the age group here, the most common age group is from 6 to 18 years of age. Daytime more than the nighttime, but I think this statistic needs to be observed over the next year, because I think we start calculating the numbers from 4 p.m., which is the time for our shifts. So from 8 morning to 4 p.m., from 4 p.m. to 8 morning. So they might accumulate both numbers, the afternoon and the night. Medina is going to be the number 2 in scorpion. Riyadh is number 1, 147 cases. Actually, this is only Tajammu al-Awwal, which is a part of the cluster 1. The total number in Riyadh is 147. Mostly in summertime, as usual. Received antivenom, only 19% of the scorpion stings patients that they received the antivenom, which gives us an idea about our cases. Actually, our scorpions are not as bad as their reputation is. So usually you can hear people, they die from scorpions. Mortality is very, very low. Centipedes, Umar 44. Interestingly, we have received so many calls about centipedes. We don't have, actually, we don't have really scientific data about centipedes envenomation in Saudi Arabia, but in non-scientific literature, we have a couple of them. In our case here, we are presenting a good number of cases. We don't really know what are the species. But the most common, clinically significant species in the Middle East is Sclerobendra valida, which the one is reported in countries in the Middle East like Iran, Jordan, Syria, Turkey, but not in Saudi. And the symptoms and signs are similar of anaphylaxis. So actually, 18% of them are female. 44% are female, and the rest are male. Age group affected is 19 to 65, which is the usual of them. Nighttime more than the daytime. Al-Madinah Al-Munawwara is still persistently high. The other area, Riyadh, is 7 cases, because we distributed the cases according to the clusters. In April, which is the time of the spring, is the highest number of centipede exposure or reporting to our services. And we want to touch base on the guidelines, how to treat, and protocols, how to treat the antivenom, how to treat the snakes. Back in 2020 in SASM, we came up with new guidelines that to simplify the current guidelines, the old guidelines. These are the old guidelines. So you have to distribute the snakes, you have to identify them, you promote the idea of bringing the snakes to the hospital, and you have bivalent and polyvalent, and that is not the case right now. So we came up with the new one at that time, which was in 2020, just to simplify things. We don't need to know the snakes. We have only one antivenom available, which is the polyvalent, since the bivalent stopped in 2015. So, but we did not answer a lot of questions. Why do we need to observe the patient for 12 hours? We might have some risks beyond 12 hours. So we relied on some Western literature, but snakes are geographically distributed, and which is different from one another. The other one is for how much we should give, for how long we should give the antivenom, and for how long should we observe. In order to answer these questions, we came up with the new guidelines. It might be complicated, and I don't think that would be the last one, but we want to answer questions, to go back to this one with evidence, with the statistics. So this is the new one. It's complicated, but it will answer questions. First of all, you have to observe the patient for 24 hours. Now we have to answer the question whether 12 hours is correct or not, or is enough or not. We have to observe the patients for 24 hours. And we will see from there if it is enough or not. The second one is observe symptoms and signs and perform labs Q4 hours initially for the 12 hours, then Q8 or Q6 hours. So total times will be 5 times of labs, 5 to 6 times of lab orders. After that, if the patient is fine, you can discharge him. Okay, during that time of 24-hour observation, if he has some hematotoxicity, which is high INR, low platelet, and so on and so forth, so you have to treat him. And this answers one of our questions. You have to treat him, repeat labs 1 hour after the administration of antivenom, and see if it goes better, it goes down, you don't have to repeat it. If it does not go down, you have to give another dose and wait 1 hour and repeat the labs. So here, now we want to monitor the efficacy of the antivenom. And after that, if he improves, let's say the INR improves, it went down, and everything was fine, so we can repeat the lab Q8 hours, and after that, discharge him within 24 hours. And with instruction to serum sickness. Now, one more question that we received all the time. What if neurotoxic? What if the patient was seizing? What if the patient had autonomic dysfunction, frothy secretions, high blood pressure, extreme heart rate? So what we need? Do we have to wait to repeat labs? No. We can give the 5 vials, and we can repeat it in 1 hour. We don't have, actually, even in the package insert, we don't have a maximum number. But if it does not work, you have to consider other measures, which is like intubation, like benzodiazepines, and other measures to rescue the patient. And you go back to 8 hours policy. If okay, you can discharge him with serum sickness instructions. Here are those guidelines we want just to keep for 1 year. We want to see that if we go back to the simple version of them, will be scientifically proven by our statistics, which is as simple as this. You just observe, do labs, 12 hours of normal discharge. If toxicity, either neuro or hematotoxicity, admit and treat. And one more thing here, I found it a very nice moment to talk about the ecosystem and the problem of snakes extinction, Saudi. Snakes is being a prey for other animals like falcons, like owls, like fox, like wolves, and they are being actually they prey on other like lizards and mice. So just to keep observe the ecosystem, killing them won't help us. And one more thing here, I want to touch base on our toxicology consultation services rotation. So I have a couple of residents, they have, and fellow, they have rotations with us. And I think it is a good time to tell you about our services here. We have 24/7 and 365 days coverage. So we don't take break. We cover all the time with 3 to 4 on-call consultants to back up the toxicology services. And we have 61 specialists in poison information. Those are the ones who pick the phone. And our statistics from January to June 2023, 31,400 cases, which is a huge number for training to be part of. Weekly academic activities, and we have multiple teaching pathways. Now we are inventing new pathways to teach and to certify SPIs, like SPI, Specialist in Poison Information Certificate and diploma. We have research opportunity. Actually, we have a huge amount of data and monthly evaluations. And I found it a very good time to let you know about our services and rotations if you want to join us. Thank you.
Thank you, Dr. Mubarak, for this very interesting presentations and for the statistic that you shared. The third speaker today with us, Dr. Bayan Abdul Baqi. She will talk about the latest update in approach to intoxicated patient. Dr. Bayan is an emergency medicine consultant and medical toxicology consultant at King Saud University Medical City. She got her, Dr. Bayan got her emergency residency training in Riyadh and got her medical toxicology degree from Emory University in Atlanta, USA. With more than 15 years of experience, she will present to us today the talk about how to approach toxicology patient in the emergency department. Please welcome Dr. Bayan.
سلام جميعا وكل عام وانتم بخير والبلد بخير. All right. So I'm going to talk today about the approach to toxin overdose patient in the AD and what to consider. And mostly from the psychological point of view rather than the medical. Well, first thing first is to have high suspicion, high index of suspicion. You have to think of it. It has to cross your mind to know that there is a possibility of poisoned or tox patient group in your emergency. Well, a while ago, I had a patient, 20 years old lady, 5 months pregnant. She came with her husband and his mother to the emergency with simple minor trauma. As her nurse was approaching me, showing me the VBG, she was a skillful nurse. I asked her to please and go and ask the patient to find a moment where she is alone, no mother and no husband, and ask her if there is an element of an abuse. And a few moments later, she came and confirmed, indeed, that was the case. With furthermore investigation and questioning, we found out that there is also element of an overdose. So the point here is not only to stress that abuse and overdose could come together, depression and overdose, psychiatry and overdose, neglect and overdose, that could come together in the same presentation, but also to stress the whole point of high index of suspicion. You have to think of it. You have to look at it, to ask whether it is or it is not tox case. Now, curious child and mommy guilt. Well, studies have found consistently, in general, that we fall into our own pattern, and we call that habits. But it's so special for this group of patients. The children who are testing the world through literally tasting it and then taking the information through oral examination, they're more prone to accidental ingestion, and more than once. Now, mommy's guilt is not just for mommies. There is another specific study was trying to look and compare for the two groups, control group versus those patients, the children who are presented with accidental overdose. And they found 3 points. The first point is those children exhibit more than the control group behavior that are consistent with ADHD and destructive behavioral disorders. Number 2, the mothers of those children, they had higher frequencies of psychiatry behaviors and diagnosis. 3 times fold higher. Disorder include anxiety, mood, and personal disorders. Number 3, interesting, smoking. The smoking was notably higher in both parents in those group compared to the control group. Now, dealing with mothers or with caregivers, of course, the mommy guilt is not just for mommies. If you have, let's say, a new mother came or brought her baby after wrong dosing of paracetamol, let's say. Now, we got to deal with those cases with delicate understanding, because you do not want to miss the abuse, but you also do not want to cause family trauma or family trouble. As adults, we also fall into our own behavioral pattern, and we call those habits. And as adults try to deal with their life stressors, sometimes they aim to belong or to fit in. And some of those behaviors are, it starts with something like social drinking or social smoking, and then it ends not in a very well ending. And sometimes the adults, they would aim, when they're all alone, to numb whatever they're feeling. And to do that maybe with Netflix, who's not guilty with that, or Sudoku, Solitaire, and all of the phone games. But then it can advance more. Now, the core difference, and this slide here is inviting all of us to really re-examine our habits. What is the difference between habit and addiction? And the core, or the main difference, is the consciousness. We control the habit, but the addiction controls us. We don't have control over it. Having said that, it falls into a different realm of definition. And it's interesting when we look for the exact definition of high. What is high? What is being high? Of course, being high include seen as depressant. So it's not just seen as stimulation. And sometimes, people would do something like sniffing glue or the smell in the gas station. What is high? What is it? And so one of the most convincing definition that I found is to be high is to feel different and new feeling than the feeling that you're feeling right now. And that's in a body sensational way, not the feeling way. And this is very broad and very creative definition. Now, the secret here with the new, because for the first few time, it would be new, but then you've been there. It's not high anymore. And so the joy of it, you lose the joy of it. It's not high, but you can't stop. And that's because the addicted patient, or person, I should say, are engulfed in their withdrawal syndrome. On top of that, the shame, the guilt, the negative self-talk, the hate, self-hate, and the loneliness, hopelessness, and sometimes it might end not in a good way, and I really hope to God that you get to be spared from the horrible experience when you're delivering bad news to a parent who lost their child after overdose, whether it is deliberate or accidental. It's loaded, not fun, let me tell you. Now, the treatment of addiction include a lot of or thorough, let's say, psychological, mental, emotional examination, as well as the biological part of it. The upregulation of the receptor insensitivity, the tolerance. Having said that, both of them, they have to be dealt with utmost delicacy and right to the point, to the exact point. Now, because of this, the ED role in the management of addicted patient is limited. We can give them appointment for pain medication, a pain clinic, addiction clinic, psychiatry clinic, some pamphlet, but we can't do much, and we shouldn't do much. Now, this is the oath that we all took, and it clearly states that when you have a diagnosis, it is for purely medical reason and not for moral judgment. And if you allow me, I want to read it with you. أقسم بالله العظيم أن أراقب الله في مهنتي وأن أصون حياة الإنسان في كافة أدوارها في كل الظروف والأحوال باذلاً وسعي في استنقاذها من الهلاك والمرض والألم والقلق وأن أحفظ للناس كرامتهم وأستر عورتهم وأكتم سرهم وأن أكون على الدوام من وسائل رحمة الله باذلاً رعاية الطبية للقريب والبعيد للصالح والخاطئ والصديق والعدو وأن أثابر على طلب العلم أسخره لنفع الإنسان لا لأذاه وأن أوقر من علمني وأعلم من يصغرني وأكون أخاً لكل زميل في المهنة الطبية متعاونين على البر والتقوى وأن تكون حياتي مصداق إيماني في سري وعلانيتي نقية مما يشينها تجاه الله ورسوله والمؤمنين والله على ما أقول شهيد. I invite you to remember this when you deal with addicted patient and those group. Now, there is another group of patients that sometimes, more often than it should be, I think, they get entangled with the overdose patient. And these are the sickle cell patient. Now, you know the sickling is irreversible. The hemoglobin gets polymerized and it sickles the RBCs, group of RBCs will occlude the vessels. And then, because of that irreversible, it will cause ischemia, hypoperfusion and no perfusion. So ischemic pain, and especially when it is irreversible, I would argue that it is one of the most, or the worst kind of pain, because you get to be conscious and fully awake while, let's say, part of you is dying. Now, the sickle cell patients, they don't last the average human lifespan. And these are the most common cause of death, the top 10, that cover 99.99% of the cause of death of sickle cell. And it doesn't include opioid overdose. And especially not in emergency, where you have monitored bed and it's IV, not oral, naloxone at bedside with a clean needle. Now, having said that, we know the opioid treatment is, on the biological side, it's just a clean needle with a long term of opioid, like methadone, not long term, sorry, long lasting effect. Okay, so when I was invited here to speak to you, I was honored, and thank you for the organizing committee. But I decided to speak to the psychological part, to speak in the name of those patients, because I know you're great at the medical side of it. And so, because I realized that this bit is a bit gloomy, I decided to end with those paintings. Those paintings are from very interesting artist. He used to draw his face every day for years, and then he decided to draw his face while high on different substance. For the particular motive to show us a little peek what goes inside those minds that are chemically, anatomically, and sometimes spiritually different than us. The black here is cocaine, up هذا الحشيش. The middle one is the mushroom. The top one is morphine, marijuana, of course. So I hope you enjoyed it. Thank you very much.
Thank you, Doctor, for interesting journey through the mind of the overdose patients. I will take a few questions to the speakers, then would like to welcome them to the podium. After that, the first question I have, the Kingdom of Saudi Arabia is going through transformation, and there are two concepts that being brought to the table. The first concept is approval of the kingdom for peaceful use of radiation as a source of energy, and the second is edutainment, where entertainment is part of the transformation strategy, where patients actually visit the kingdom subjective to innovation as well as envenomation, as well as from edutainment is intoxication. So first question, are we ready radiation-wise? I don't know, Dr. Muhammad, if you can enlighten us. Are we ready as SASM to be involved in this? What is our role? What do you believe we should do? Or what do you believe we should come out of this meeting knowing the fact that the future is going to be more focused on those two areas?
Sure. Of course, preparedness to receive those kind of cases, either in like higher level or higher numbers, like when a disaster happen, or just like a simple exposure, it should be an essential part. If we have any initiative to start, let's say, and inshallah it will come soon, a nuclear reactor for energy production. Those protocols should be side to side with the industrial and manufacturing and operational one, because those kind of incidents can happen anywhere. Some countries, they have nuclear reactors since 50 and 60 years, like Japan, for example, and they still have those kind of incidents, either like a meltdown or a leak or, God forbid, even like a bigger incidents like in Chernobyl. Are we ready or not? From SASM, this topic been discussed and brought many times in the previous assemblies, and it's good to have it on the table to educate our society about those things. The Ministry of Health and other entities, they have initiatives to start protocols to prepare for those kind of incidents. But I think the real step up or the milestone in this project will happen once we have the first brick in the project on the ground, because the project has to have the radiation preparedness abilities at the same time.
Thank you, Muhammad. Any questions or comments from the experts in the audience? Any? Okay. I have another question also about radiation. How about decontamination in radiation? In very brief answer, if you can enlighten us.
So decontamination, external decontamination, the usual one, with water and soap. If patients got exposed just to radiation, you don't need to do a decontamination. But if the patient has sticky material, sticky radioactive material, radioactive dust, some particles need to be washed out. It's not the usual scenario, but it needs to be washed out. Decontamination, usually here it goes to the internal decontamination with the chelation therapy, with blocking absorption, like as we mentioned, potassium iodine in the radioactive iodine, Prussian blue, zinc editor, water, tritium, and etc.
Thank you. A question to Mubarak. I think you mentioned, I noticed that you presented most of the reported cases of all envenomation, snakes, scorpion, even أمار ب40 ما أعرف أقول اسمه بالإنجليزي سامحني. From مدينة منورة تقريبا. Is it, as you mentioned, is it they are reporting each cases or the other area not reporting? And apart from reporting, under or over reporting, is there any other possibilities of this, like number of cases being major in Medina? هل هي something environmental في الarea? Is it something في ال communication في ال reporting system? Is there anything that you can comment on that?
صوت واضح؟ هو فعلا المدينة very interesting case, and I believe because of reporting, they report every case they receive. Number one. Number two, they have farms and they go out for farming and stuff. And that's why they report most of the cases. And I do believe that there are other areas where under-reporting is there. So the issue, for example, at Taif, for example, all the way from Taif, Linjazan, there is some under-reporting going on because the number of cases does not reflect what we believe is in the nature. And so on and so forth. So yes, and I do believe that they're reporting very well, and the environment is very suitable for such incidents.
Any further questions or Dr. Musa?
Thank you so much for speakers about the sessions. However, I'm a little bit mad because it was the last session of the day, and the attendance is not that too much. However, it's very important because it's something related to our epidemiology and our data and statistics. Thank you so much for all. I'd like to thank especially Dr. Mubarak because really we are waiting for these guidelines, snake bite, antivenom guidelines since almost 2 or 3 years. We are so happy now to have such guidelines that will guide us based on clinical backgrounds that we have it, and that's really amazing. Just to share the experience, we did a retrospective study in Asir region for the last 20 years, from 2000 up to 2021, about the snake bite. We end with like 68 cases. Interestingly, we have what we call complicated snake bite, and we define it with the neurogenic snake bite, which is it's happened almost like 15 cases, and the patient either bitten by well-known snake like cobra, and the patient brought it with him, or the patient present with cardiopulmonary manifestation. From our experience, we found that the medium dose for neurogenic manifestation that patient may need it reached up to 22 vial, while to reverse the hematological presentation, the median dose it was 18 vial, while the compartment syndrome you need up to 20 vial. So this is the median dose based on the last 20 years that we have it. No, the redosing time is based on presentation. Usually if we have compartment syndrome, we are talking about redosing over 48 hours, while if you have neurological manifestation, we are talking about redosing every 2 to 4 hours. So based on the scenario and severity, how it is. We found that also the atraxtaspidus or engadinitis mainly, or anderson, either one, that have very bad reputation. It kill within like 30 minutes. We found that however, it's not covered by antivenom, by the way. We find it's not that bad. We have like 5 cases, and we are processing and doing case series about them. All of them, luckily, they have just local manifestation or lymphadenopathy in the remote area with mild swelling there. There is one patient end with fasciotomy with compartment syndrome. However, all of them, they didn't receive antivenom because the antivenom we know is not covering it. But really, thank you so much for the new guidelines that we have it. I hope it will be promoted to cover more advanced case, like when we are talking about thrombotic microangiopathy, that we notice a lot in case of Echis coloratus or الحية الرقطة, spotted snake. We find they have thrombotic microangiopathy, and it's recommended for plasmapheresis in some cases, at least in Western literature with different species. So I hope at the time we can promote our protocols and our guidelines for that. Thank you again for all talk sessions, speaker. Thank you so much.
Thank you, Dr. Musa, for this very an opinion from an expert in the southern region in toxicology. So it's really great. Would like to ask the speakers to join on the stage for recognizing and appreciating the time and effort. And before that, I want to thank our organizers, Ula and نورا وعلا. فشكرا لهم على مجهوداتهم اليومين اللي راحت وبكرة. Thank you very much. سلمهم انت السينيور حقنا. لا انت السينيور حقنا. انت السينيور حقنا. دكتور محمد. دكتور مبارك الحارثي. دكتورة بيان.